Good morning, everyone. We are starting with the session. Namaste, Suswagatam, and a very good morning to respected seniors and dear friends from all across the world. On behalf of the organizing team of the second regional conference of Asia Oceania Network of Kangaroo Mother Care, I, Dr. Prarthana, along with my co-host Dr. Shwetal Bhatt, extend a warm welcome to everyone present over here. Kangaroo Mother Care is strongly suggested to become the gold standard for providing high quality health care to all infants, regardless of location or socio-economic status. It is recommended to be used as a standard of care because it is a practical, organic, and economical intervention. Its use has been proved to be an effective therapy for neurodevelopment apart from its beneficial effects on neonatal morbidity and mortality. Despite this, the use of KMC in clinical practice is inconsistent and underutilized. As an effort to improve the situation, the Asia Oceania Network was formed under the able leadership of Dr. Socorro Mendoza from the Philippines to support and promote KMC in the Asia Oceania region. Participants from this group share and keep each other updated on KMC practices. So let us continue with these efforts by continuously updating ourselves and improving awareness amongst others through our actions. It is rightly said, let us work as we pray, as work is indeed the body's best prayer for the divine. So we begin our day with a prayer. Mahaye, Mahaye, Mahabhagavatim, Mataram, Shri Mataram, Mahaye, Mahaye, Mahabhagavatim, Mataram, Shri Mataram, Premamayim, Anandamayim, Om, Premamayim, Anandamayim, Om, Mataram, Shri Mataram, Mahaye, Mahaye, Mahabhagavatim, Swargayasya Varadanani, Amrutani cha Suprabhapanani, Satyamayi Sacharaachar Bhutam, Mataram, Shri Mataram, Mahaye, Mahaye, Mahabhagavatim, Mataram, Shri Mataram, Mahaye, Mahaye, Mahabhagavatim. Let us now proceed to our first session on KMC experiences from different countries. And to chair the session, I would like to invite on the stage respected chairpersons, Dr. Neena Raina, Dr. Simin Irani, and Dr. Manish Mehta will be joining us late due to his some personal reasons. Dr. Neena Raina ma'am is the Director, Department of UHC Family Health, WHO, Regional Office for Southeast Asia from New Delhi. We welcome you, ma'am. Please. Dr. Professor Simin Irani Madam is a very senior and respectable pediatrician who led the department at KM Hospital and Somaya Medical College and Hospital in Mumbai. She has been the UNICEF consultant for nutrition and newborn care in Maharashtra and the national trainer of various programs. A heartfelt welcome to both the chairpersons. We have some couple of very special guests among us. The kids who have grown and developed with the help of Kangaroo Mother Care. So before we start our scientific session, we would request them to light the lamp and mark the beginning of the conference, which is actually made for the kids.
इंट्रोडक्शन कई जरूर नहीं कर हाँ कर दी थी मनीष ना नहीं જોઈન લેટ થશે હું કરી દીધું ઓકે પછી હવે પણ એમની ઇન્ટ્રોડક્શન મતલબ નથી ના હવે નહીં હવે ચાલુ કરી દેવાનું આ લોકો અહીંયા જ આવશે બોલો ત્યાંથી બોલશે ના હું ત્યાં માઇક આપી દઈશ તમને ખબર છે ને મેં કોને ઇન્ટ્રોડ્યુસ કર્યું તમને ખબર છે ને લિસ્ટ બે બાબાઓને કેટલું મસ્ત ગીત શું થયું રગડતી જ નથી એવું છે અચ્છા બ્લુઅર આવતું હશે એસીનું બેટા છે પેન ના ના કાલે પણ હતા કોઈ મારા જેવી છે નિહલને કહું કે અહીંયા એમએસસીમાં છું અનિતાનો નંબર છે તારી પાસે હા ત્રિભુવન કેએમસી વાળી એને કહેવાનું છે કે થોડા મોમેન્ટો અહીંયા લઈને રાખે હા નિહલ એમઓસીમાં છું હા એ મેં અહીંયા કોર્નરમાં મૂકી દીધી છે હા અને તને ને દીપાને કંઈક એવું આપ્યું છે કે દરેક ફેકલ્ટીનું પતે પછી એ લોકોને આપી દે
long press on off. Long press on off.
Persons, I kindly request the chairpersons to briefly introduce the respective topics and speakers. Over to the chairpersons.
Thank you very much, Dr. Shashivani, dignitaries, distinguished participants, ladies and gentlemen. It's a pleasure for me to chair with Professor Simin Irani, whom I have known ever since 1980. And when I started work on low birth weight babies in 1980s, I contacted Dr. Shashivani. I still call her mother of KMC. And at the field level in the community, when there were no guidelines, there was nothing known, she worked from her heart. And when you work from your heart, you don't need guidelines. Guidelines come in later. And since then, I think millions of babies have been saved who were born low birth weight or premature using KMC. And now WHO guidelines have been recently released. I'm very happy, Dr. Simin Irani, who has always worked on newborn care and joined hands, especially for premature babies. I think I'm so happy to meet my old friends. They are evergreen. They don't look old. But ever since 1980, I am seeing them like this only. So let's give a round of applause for Dr. Shashivani for hosting this workshop. And the opening batsmen are always, they carry a lot of hope. So Dr. Shashivani has warned me that the session should finish on time. It's very packed agenda. But I think this is a wonderful opportunity for us to learn from other countries. So this session is on KMC experiences from different countries. And without wasting much time, I'll introduce the first speaker. And my request, because all of them are very senior, I was telling Dr. Semin that let's keep some, monitor the time. And she said, they are also senior. How do we stop them? So we are a little apprehensive to interrupt when you are presenting. But since you people are all very experienced, my humble request is kindly stick to the time. I understand some presentations are for 10 minutes and some presentations are for 15 minutes. So the first one will get around 15 minutes, implementation of KMC in Mongolia. And I'm very pleased to introduce Dr. Bayas Galanti Bausaran from Mongolia. Let's give a round of applause to the presenter. Over to you, Dr. Baya.
Good morning, ladies and gentlemen, and distinguished guests, dear friends. First of all, I would like to say thank you for organizing committee and to Dr. Shashivani and other friends for organizing such wonderful congress. I'm a first time in India, and now in Mongolia is winter. -26. Here very warm, and I feel like I received the kangaroo mother care here. Yeah, it's very warm. Okay, The Mongolia, now winter we have 4 seasons. You can see the different pictures of our seasons and different picture of our weathers. Okay, let me start my presentation. We all know that Kangaroo Mother Care is excellent intervention for improving the health and survival changes of premature babies. And in this slide, I would like to show the neonatal mortality rate is decreasing in Mongolia. It was in 2010, it was 11.6 per mile, and decreased up to 7.3 per mile in 2020. It's lower than global average. Global average is 18, but it's higher than the Western Pacific region. The causes of, in the structure of the causes of neonatal mortality, prematurity-related conditions is very high. It's 47%. It was increased in 2022, increased up to 63. The Mongolian population is 3.5 million, and every year we have about 70 to 80,000 newborns, and among these newborns, low birth weight infants about 4.5 and 5%. In Mongolia, we implemented essential newborn care, and skin-to-skin contact immediately after birth, it's 80%, and baby placed skin-to-skin contact within 90 minutes after birth, it's 56%, it's quite low. Breastfeeding in the first hour, it's 96.5%, and not more than 20% of preterm and low birth infant in Mongolia received facility-based KMC. And home-based KMC not introduced yet now. And from the recent guideline of WHO on kangaroo mother care, it's recommended that the health system should have these following building blocks. The first is leadership and governance. In Mongolia, we do not have a strong national policy on KMC. We have just KMC messages in the context of essential newborn care. And health financing, in the health financing, we do not have allocated budget for KMC. And also there is no dedicated nurses for conducting KMC. Also, we should be working on community engagement as they know, due to lack of workforce and resources available. Also, in the health information system, we do not have any data collection and no documentation on KMC. And the resources that we currently have do not sufficient. And in this slide, I wanted to introduce the activity about KMC in Mongolia. We do not have national policy, but some NGOs and some organizations doing something on KMC. In 2000, we started to implement the essential newborn care and breastfeeding program. In the context of this program, we had 2 hours lecture on KMC. In 2011, we organized the first KMC and perinatal infection congress with support of FAOFC. And in Mongolia came Dr. Socorro Mendoza from Philippines, and from India, Ranjan, Dr. Ranjan. And they helped us to organize very wonderful congress on KMC. In 2014, we started to implement only essential newborn care. In 2019, we joined Asian Oceania network on KMC. In 2019, with support of WHO, we conducted the KMC workshop, just a workshop. They stopped, we organized the workshop and that's all, no more activities. And in this year, we also translated the WHO guideline on KMC. In 2022, we started to conduct training on small and sick babies management. In the context of this training, we also included the KMC informations. And from this year, we want to collect data on KMC. In Mongolia, the KMC introduced just in the facility-based. Okay, this is the pictures, photos from the first Congress. We organized it 12 years ago. And we have very cold winter, and we have a national costume which has a sheep skin. And in the winter time, we can use this national costume for KMC. This is Dr. Ranjao. In the future, we want to implement the following actions in order to successfully implement KMC in Mongolian. I understood that there should be the leadership where government can hold hospitals and wards up to standard and translate and adopt guidelines on KMC into Mongolian and make sure the mothers have access to supportive programs. Also, the insurance plans and sustainable financial resources which cover costs for treatment for low birth weight infants and sick infants, including KMC. And also support and train nurses and staffs and capacity building of health workforce, including pre-service and in-service training on KMC. And support low birth weight in sick infants, integration of KMC into small and sick newborns, comprehensive newborn care, and maternal and newborn care packages, and post-discharge follow-up at a health facility in the community. Also, the data collection is very important. I understood that, and we need to improve data collection and creation of data collection in the health management information system platform using special indicators, and provide staff and mothers with proper and adequate environmental and resources. And we came here, 4 people from Mongolia, staff nurses, neonatologists, and professors, and we wanted to learn more about KMC, and we'll have more information from this workshop. And I finish my presentation, and I wish success for all you. Thank you for kind attention.
Thank you very much, Dr. Bayas Galante. Wonderful presentation, and we understand from deep freezer you have come to an oven. So with 4% low birth weight babies, I think your numbers are not going to be a challenge. But as you said, WHO guidelines are there, but implementation requires a policy change and investments. And I think these two at national level, people and champions like you can drive and convince. And I'm hopeful that by next time when you come for this conference, you'll have this as a policy in Mongolia. Thank you very much once again. We move on. We move on to the next presenter. Everybody knows him. Dr. Sachin Gupta from USAID will be sharing USAID support for KMC in India. Over to you, Dr. Sachin.
Thank you. Thank you, chairs, and a very good morning to everyone. Really delighted to be part of this conference, and greetings from USAID. So my presentation will be more focused on the broader integrated efforts USAID is taking in India to reduce the burden of preventable maternal and child deaths, of course, the newborn mortality also. And after my presentation, I think Dr. Harish will be talking more about the specific elements of the KMC, where we will focus on what USAID is supporting in the field to reduce neonatal mortality due to the high burden of prematurity. So I will definitely finish, chairs, within time, but I'm not so senior also. Please remind me if I go over time. Next slide, please. It's here. Now we all know like where we are in terms of our current maternal mortality ratio, under 5 mortality rate, and neonatal mortality rate, and where we want to go. So the SDG goals for all 3 of them are 70, 25, and 12 for the neonatal mortality. But according to the India Newborn Action Plan, we have even more ambitious goals of reaching single-digit neonatal mortality rate by 2030, which is also the SDG year. So we have to keep in mind, and we'll talk a little bit more about that, the Government of India's leadership and the recognition of high burden of neonatal mortality. But I just wanted to like also highlight that how much time it has taken, because we are at like 22 right now, and how long does it take to reach 12? And how much it has taken for countries in the Southeast Asia region to reach 12 from 20. So if you can see almost 15 years for Indonesia, 19 years for Vietnam, 25 years for Philippines, Thailand it took 11 years, 16 years for Sri Lanka, and even for countries like UK and USA, it took almost 16 years is the average. But not to say that we also need in India the same amount of time to reach there, because thanks to the leadership, the political will, and the recognition by the Government of India, along with, of course, the development partners and the organizations, the NGOs, efforts of everybody, has led to a stage that our annual reduction rate is even better than many of the developed countries now in terms of reducing the neonatal mortality. So I can say that we are on track on neonatal mortality also, but just to highlight that the last leg of the marathon is definitely more challenging. Causes of under 5 and newborn deaths. Of course, we know that 63% of our under 5 mortality is now neonatal mortality, and there is no doubt that prematurity is the leading cause of neonatal mortality. And even if we look at the overall pie of the under 5 deaths, almost a third of the under 5 deaths are caused by prematurity as the leading cause. Burden of prematurity, almost 20 million infants are born with low birth weight. 94% of them are in low and middle income countries, accounting for almost 70 to 80% of all neonatal deaths. And low birth weight infants are also at risk of early growth retardation as well as development delays. So what is our response to all this? And the prevalence in India is also, the low birth weight is around 18%, and the preterm birth is also 13%. And when that translate into numbers, when these percentages translate into numbers for India, we know the magnitude of the problem and how much India can contribute to the global reduction if we can achieve the targets in India. So now this neonatal and mother died, and I think there is now more than ever recognition of working at the uh, intersection of the dyad rather than taking the child or the newborn individually and the mother separately. So the uh, ending preventable maternal mortality and every newborn action plan combined coverage targets are, we all know that 90-90, 80-80 is the newest terminology, where 90% coverage of 4 or more antenatal care contacts as a first step, 90% births attended by skilled birth attendants, 80% early routine postnatal care within 2 days. And for every newborn action plan, the national implementation plan for inpatient units and subnational inpatient units with a CPAP for 80%. And on the ending preventable maternal mortality side, more than half of the population within 2 hours of reach, considering the 3 delays in mind, the delay in deciding to seek care, the delay in reaching the facility, and the delay in getting the appropriate quality care. And of course, the shared milestones as the health systems building blocks, policies and plans, quality of care, equity is a big element in India when we look at even the variation, not only within the states, but at the sub-district level also. And that is how the government of India is also now focusing from the aspirational district concept to even the aspirational blocks concept. So I think going down and looking at even the variation at the block level is really important, and that is how we can achieve or identify the pockets of inequities in India and reach to the last mile, which is now going to be the frontier in our future planning. Oops. So coming to the USAID, India's MNCH support model, we are aligning our efforts to support the government in their efforts to reach the targets for mother and child health as well as neonatal mortality, implementing models, because we have seen that the policies are there, all high impact interventions are part of the policy, but when it comes to implementation, the challenges lie in the implementation. So demonstrating some implementation models for adoption of high impact interventions. For example, recently the CPAP model has been demonstrated by USAID supported projects in some SNCUs, and now several states are now taking that initiative. The focus on the highest priority districts and in high burden states was strategy to focus on the aspirational districts, and now also aligning efforts to focus further down on the aspirational blocks as we work with the GOI. Focus on partnerships as well as the private sector, and even when we are talking about KMC, we very well know that there is a big kind of, not I would say the knowledge gap, but implementation or practice gap in the public and the private sector. So that lies within various and a lot of policies. Even the knowledge gap exists. The government has the best kind of latest best practices and the high impact interventions, but when we go to the private sector, we see that the implementation, there is a difference in the implementation in the public and the private sector. So bringing along the private sector and making win-win partnerships to, with the private sector to even get their resources within the implementation program. Focus on the district and the sub-district level, some innovative models for development of evidence-based action plans. For example, the district health action plans and their implementation, looking at the local data, evidence-based action plan is the first step to actually implement the program. And of course, technology-enabled solutions and interventions to improve efficiencies in the implementation. Some examples of where we are supporting the existing government initiatives, for example, the Lakshya Program Management Unit at the Ministry of Health, the Quality of Care Dashboard, and I'll just take one more minute. The support for KMC, I would like the support for scaling up family participatory care, which the next presenter will talk more about. India Newborn Action Plan, won't go into the details, and I would again like to highlight the commitment of the government, because India was the first country to respond to the global call to action for child survival in 2012, and in 2013 the government of India did their own call to action. Similarly, for the ENAP, every newborn action plan, government of India was the first country to respond to the ENAP by bringing along the INAP, India Newborn Action Plan, in 2014. Some lessons learned from the KMC implementation model in the past from the USAID projects, and there is nothing new in that. KMC can be initiated with available resources. Private sector focus has to be there. Counseling is critical, and despite simplicity, it is a difficult intervention to implement. Thank you all.
Thank you, Dr. Sachin. Believe in me, this bell is not being rung by me. You have finished before time, and I don't know from where this bell is coming. Thank you, I think, for setting the stage for our experience in India. And you're right that countries do have taken time, but that was MDG era or pre-MDG era. And SDG, I think, has really put more pressure and given more ambitious targets for countries to achieve. And as per WHO estimates, we know that India will get to SDG target given the present annual rate of reduction. So India is on track for achieving the target of 12 by 2030. So I think thanks to you for bringing the issue on private sector focus, which is very, very important, the gap between the knowledge and practice. Knowledge, yes, a lot of advocacy has been done, a lot of knowledge has been better. This is more like a soft skill, which has to be transmitted from the healthcare providers to the parents who have to finally continue doing it. And these soft skills with some bit of gadgets and commodities may really make a huge difference in the survival of preterm babies. I remember when I started working on low birth weight in 1980, the prevalence was 30%. And now at least it has come down to 18%. Institutional deliveries have gone up. So there's a lot of hope from KMC for reducing the deaths. So with this, let's give a round of applause to Dr. Sachin. We move on to next presenter, which is going to be highlighting implementation of KMC in India, the USAID IP joint program, which Dr. Sachin alluded to as well. Dr. Harish Kumar from IP Global will be making the presentation. Over to you, Dr. Harish.
Thank you, Dr. Neena and Dr. Simyan Irani. Dr. Neena has promised me that she'll give me 2 minutes extra. So, Bell people be aware. If you don't take, she is the director in WHO. So be careful before you ring the bell. The fact that Government of India gives such a top priority is reflected by the fact that we have a Deputy Commissioner of Child Health from the country who on her weekend has decided to come here. It's a good opportunity to meet a lot of our mentors, teachers, friends, Dr. Shivani, who have been teachers since the days I was there in the medical school, Dr. Susan, Dr. Nalini, my friend from UNICEF, Narayan, my own colleague from Safdarjung, Dr. Chalani. I see practically everyone, the same kind of culprits who have been trying to push the agenda year after year. But the sad part is yet in India, we do not know what is its public health coverage. So we need to move fast. Sachin has set the stage right by wonderfully saying that yes, we have bent the curve, we are better than the world's global under 5 IMR, NMR mortality reduction. We need to do better than even US over the next 7-8 years so that we achieve SDG, and I am sure we'll definitely do that together with that. And it is in this quest that I'll be showing some of the models which we have worked with the state governments in implementation. I'll tell you a word about Samveg. What are we? What are our innovative nurturing care model? We have incorporated KMC as a bundled approach as packages of services. What is our policy to action support aligning with the country's priorities, and what have been our learning and how can we move forward? We are a project working in IP Global. It's a consortium by 3 other partners, John Snow India, World Health Partner, and Dimagi International, which help us, and we work in 5 states, 25 aspiration districts. The main mandate which have been given is that we have to demonstrate innovative models, which we try and do, showing evidence-based decisions for public health planning. We adopt human-centered design. We try to translate policy to action, and we work together in partnership. Friend, this is known practically to everyone in this August gathering. But when I shifted from my clinical side to WHO, I learned one straight thing. There are interventions which are treatment technologies or key community behaviors, but the implementation of which require intervention packages. So we can't take one intervention as such, but we'll have to implement them in terms of packages. We have known that KMC helps reducing morbidity, mortality, support developmental care, reduces hypothermia, prevents infection, improves development. But what is new? Based on some new researches, and one of which in my alma mater, Safdarjung, Dr. Chalani is here, one thing which has come recently is that immediate KMC is the one which needs to be focused specifically now. For earlier, evidence was only for the stable babies. Now we say that KMC for preterm or low birth weight should be started as soon as possible after birth. Second is, we knew about KMC, but when we learned implementation, evidence says it should be given at least for 8 to 24 hours, more the merrier. 24 hours may not be really practical, but then 8 hours. Whatever assessments we did, we saw that it is less than 4 hours most of the time. People put the baby on the chest and say KMC is done. We need to do a quality check of ourselves. So how have we been supporting? Together with one of my colleagues in RML Hospital, Dr. Aarti, we designed family participatory care as a model for starting. We have been supporting the country in terms of majority of the policies, including NBSU, FBNC guidelines, India Newborn Action Plan, RMNCHS strategy. So what we decided to do, we said we'll take it as a package, which is KMC Plus, which is in the framework of nurturing care, which will improve the health, address nutrition, provide safety and security, opportunities for early learning and responsive care giving through a model called family participatory care. So far, we did work. Initially was, country had already laid its guideline. I remember when in our last meeting with the Joint Secretary, we were talking about family participatory care, and there was a little bit of hesitancy. She made us change the lines that it will be only provided to children above 1600 grams, and it will be provided only for children which are stable. Now, evidence have improved. maybe we need to do a better advocacy with the national level so that we can start the early KMC, which have been the talk of the town today. So what we did, we worked with 6 state governments. We provided them gap support for family participatory care. We didn't want to stop at the SNCU level. We wanted to go a level down. So we worked at the NBSU. We worked with several state governments. We designed, we integrated it with the newborn stabilization unit package, and I'm very happy to share with you that the same has now been released with addition of KMC and FPC in the stabilization unit. This year, we started to do that let's measure. For we do not have enough evidence. Where are we moving in terms of KMC? We know we are improving, but how much? Where we have to achieve? So we thought, let's try and measure from the community perspective. How much have been their satisfaction? What have been their grievances? What kind of a behavior change they expect? And lastly, 50% of the newborn are taken care in the country by private sector. So unless we address the private sector, we partnered with professional bodies, IAP, NNF, and FOXY, and we took it forward in one of the states as a demonstration model. We started FPC. Our model was we did assessment, we provided catalytic capacity building support, we took it forward as a responsive innovation, and we provided them hand-holding support. We did such assessments in 6 states. This is an example from Himachal Pradesh. So far, we had trained 312 service providers. 74% of the total admissions, they received the benefits, which have been 26,098. Then 37,000 sessions were held. There were 33 newborns which were admitted for low birth weight, but we wanted a model for developmentally supportive care, including taking care of the feeding and prevention of accidents and infection for all babies. What did our assessments revealed? They revealed while we have a shortfall of the HR, but FPC helped tiding over the problem of HR reduction, for it can be taken care by the nurses. They save time in terms of providing routine care to the baby, and that much time can be utilized for providing the necessary clinical care to the baby. For just to give you an example, a nurse has to wash, we did an assessment, in an 8-hour shift, she has to wash her hand 25 to 30 times. If mother is there, 90% of the job is taken care by the mother. We found there are some infrastructure and logistic constraints. The biggest issue was in terms of program management. There wasn't enough focus. People thought it is only just routine video demonstration. They were not earmarked funds for FPC, but even though they had adequacy of the funds, but planning the session and conducting, that needed a lot of hand-holding. What did it result in? It resulted in 5-fold increase after we demonstrated them in select places by the state on their own. So while we helped them only in 30 units, it was scaled up in another 75 facilities by the 6 states themselves. We tried to collect our information. We knew already that FPC improves KMC. We did an assessment. It improved the record keeping. It improved the breastfeeding in the indices. It improved that the sessions were held regularly. But what it helped us was a follow-up which is mandatory as per India's guidelines in the subsequent visits. So this was one of the obstacles which can again be taken care for the healthy development of the newborn. When we took it forward with the help of stabilization unit, this is just an example from one state, Haryana, which documented its lessons, shared it at the national platform, and got the best practices award model for taking forward first newborn unit in Jagadri for family participatory care. We need to be agile. We need to have continuous support, and during COVID time, like in emergency humanitarian settings, we are seeing them, lots of it globally today, whether in Gaza or Ukraine or with the COVID time, we created specific materials that KMC can be continued even during COVID time. The only issue is that we have to take the necessary help. Now, supportive supervision is one of the integral component. and we try and build our model with the existing framework. We created one such model of MNCH Resource Center together in Jharkhand, which provided integrated supportive supervision, and most of the time people just document the processes. We tried to measure the improvement in scores, and we showed that with the help of such resource models, one could improve the scoring in terms of reduction of neonatal sepsis, better improvement of sepsis in babies, better management of the low birth weight babies. Recently, we have shifted our focus. The country has been taking it forward. We wanted to see how much is the social accountability, how much is the grievance redressal, how much is the patient satisfaction day. So we used a built up on an existing model of call center support. Instead of telling them only about the emergency transport, they have a structured questionnaire across 1,000-day continuum of care approach. We ask questions from the mothers in terms of their experiences during antenatal care, high-risk pregnancy care, birth care, SNCU care, immunization care, and childhood care. And we measure our indices across how much is the satisfaction on a Likert scale of 5. How much do they perceive that they are getting respectful care? What are the quality parameters as per the eyes of the community personnel? How much empowering of the woman is happening? Improved service provision is what score, and what are the community IEC needs, so that state can tailor-make their IEC as per the information. So far, we have reached 20,000 such women in Haridwar, and these have been some of our results related to family participatory care with a special focus on KMC. 92% of the women were allowed to visit inside the sick newborn care unit. 91% were trained on KMC. 88% practiced KMC while the baby was hospitalized. 91% continued KMC during the community visit after discharge, and 62% revisited the facility. So it's a win-win situation. Try and catch hold of the mother the moment baby is admitted or baby is in the postnatal care, and that will help us. We designed a newer model called SPECIAL, where SPECIAL stands for Strengthening Private Sector Engagement for Counseling, Integrating Antenatal Corticosteroids for its evidence-based usage and low birth weight care. We worked together with IAP and FOXY, and we started implementing in Jharkhand. So far, we have engaged 15 newborn units, 5 in Ranchi, 2 in Jamshedpur, and 8 in Bokaro. We have so far trained almost 40 doctors and 120 nurses. These units admit on a monthly basis 700 babies, and this is ongoing now for almost a year. And we try to have another model of helping each other to peer on-site mentoring visit. For private providers will not like outsiders to come and give them some guidance. There have been significant improvement in terms of premature care. From 70%, the record keeping has improved to 80%. Readiness in terms of designated area for providing counseling to the woman, use of government approved job aids, and training of the staff member has improved significantly, and it has helped in terms of improvement in terms of their methods of counseling, their communication skills of talking with the woman. Earlier we used to see badges outside the hospital saying entry is prohibited. Now it is a person with a rose who tries and welcome the woman. So that's the kind of behavior change which is happening. So our model is diffusion, best practices of the private sector to the public sector, and best practices of the public sector shifting it to the private sector. What is the way forward? India created its KMC guidelines in 2013. Several of the people in this hall have been authored together with Dr. Shashivani. I have taken some excerpts out of it. It's time we revisit it. In the evidence of newer guidelines, 8-hour minimum KMC has to be the slogan. It has to be continued in all babies rather than putting any restrictions. it has to be immediate KMC. We do not yet know by measurement how much is my public health coverage of KMC in the community in low birth weight babies. So we need to strengthen, now it's there in the HMIS, but we need to take it forward in our NFHS and population-based service. We have to involve providers. Of course, for quality improvement, we need to strengthen infrastructure, and that's when only the models which have been demonstrated by Safdarjung and now which are being strengthened, I think, in Mewat and many other places, can take forward. Strengthening human resource, their capacity, updating our guidelines. An important thing is we need to have a uniformity of the message. I remember, first time we wrote KMC in our IMNCI was 2003. Nina was in WHO. She had convened a meeting in Jaipur, and the first argument was, we had written for all low birth weight, and there was a big objection, you can't use the word KMC. It's reserved for babies less than 1800. So we changed it to skin. It's later on I learned that skin to skin is only at the time of birth, which has to be continued for 1 hour. But whatever we felt, if a thing doesn't do harm, there's no point. But yes, what I mean to say is that we need to have uniformity and we need to keep pace with the global advancement. But most importantly, what we need to improve in our facilities is initiation of KMC is happening in a lot more babies. It's minimum implementation for 8 hours, but its continuation in the community, which have again been shown by evidence-based intervention, needs to be continued in the country. Thank you. I think, Nina, I didn't take extra time.
Much, Dr. Harish. You have stuck to the time. I think this is the first time that I'm chairing and he has really finished on time. Wealth of information. I think one message which all of us must take home from this presentation is that we need to really not only focus on KMC as one intervention. We need to really package it well, and it's a bundle of intervention which should be delivered at the same time. The dividends are much higher if we package it together along with the essential newborn care, and KMC becomes part of that. Second message is very clear, and that is the community follow-up. Once we do it in the hospital, babies are discharged, we don't know what happened. We don't even know that whether they survived or not. So I think that information has been highlighted very well. The real challenge in a country like India remains on scale up. Yes, we scale up fast, but then what about the quality and what about the monitoring and the data which we get? Thank you very much. Let's give a round of applause again to Dr. Harish. I'm very happy to now invite Dr. Douglas Macmillan, who will be presenting and sharing experience from Uganda on promoting KMC health centers and home, both health center and home. Over to you, Dr. Douglas.
Thank you very much for the opportunity of presenting information from our work in Uganda, both with the teaching of quality improvement, integrated kangaroo mother care, and implementation of a kangaroo mother care program. As some of you who may have attended the workshop the last 2 days, we wanted to integrate a quality improvement program with a kangaroo mother care learning program by which we were teaching healthcare workers to teach mothers and other family members. We felt that this combination would help people overcome barriers and make use of enablers. The considerations for this is that we wanted an interactive learning program with familiar methods, focusing on healthcare workers, assisting the learning of mothers, providing personnel with tools to help overcome barriers, to limit the costs for education and KMC implementation to help sustainability, and making the learning program available with ability to expand locally. The objectives of this required preparation of health center, health workers, mother, father, and family, and community, healthcare workers learning, family learning, and finally and importantly, follow-up and goals assessment of healthy babies, healthy families, confident healthcare workers, a supportive healthcare system, and sharing and facilitating success with others, which I am about to do. With the assistance of Rotary International, we established what was called a kangaroo mother cave in Ambarara Regional Referral Hospital in Uganda. This 4-bedded unit was an adaptation of available space to which we added for the 4 mothers toilet and washing facilities. We provided some basic equipment to the rest of the NICU, but the equipment required for the kangaroo mother cave was limited. The KMC wraps, as organized by Rotary, were made locally by local seamstresses following the Laerdal model and provided some small income generation in the community. The cave itself was relatively quiet and clean, but very limited in size with 4 beds. One of the major problems that we had, and we'll see in a minute, was feeding mothers because the hospital did not normally feed patients at all, and they relied on other family members for their food. Our activities started in January 2021, and they finished in December 2022, 2 years. The results that I'm going to present, I'm presenting on behalf of Dr. Stella Koyagola, a pediatrician in charge in Ambarara. The first result was the training of healthcare workers. 54 health workers were trained in the components of essential newborn care, which included helping babies breathe, the EPIC, which is the Quality Improvement Program, and the Quick MIC for kangaroo mother care. 5 of them are now trainers and have independently conducted their own training sessions in their area. One of the major attributes of this program was the empowerment of the healthcare workers to do small things within their control, and one of these things were small quality improvement projects to support sustainability of kangaroo mother care and better newborn care. This included immediate treatment, or actually prevention, of hypothermia at admission by working with the birth unit personnel to start skin-to-skin care right at birth. They also had small projects on early initiation of breastfeeding among cesarean section mothers, and showed a modest increase in their success within 2 weeks. The use of KMC, usually initiated after the baby was stable, so this is not immediate KMC, rose from 0% to 17% to 50% over the 2 years, and the last quarter for which it was analyzed was 65%. There was reduced mortality among those who received KMC. It was 3.5%. Better thermal control and stability, faster weight gain, reduced hospital-acquired infection, reduced hospital stay from after the KMC was initiated from 14 days down to 9 days, increased babies' return to the follow-up clinic, and increased community awareness. One of the unexpected results from this program was that when the government came by and saw the program and the reduced length of stay, they put money into expanding this unit from 4 to 8 kangaroo mother care beds. The fact that they need 28 beds instead of 8 still remains to be accomplished. The fourth was that many family members were involved in helping other families learn. This is a young boy who's providing skin-to-skin care for his sibling because his mother had severe, actually eclampsia, had seized. The fathers were involved, and this really helped in the community. As one father said, "I told my wife that KMC helps babies to keep warm and grow faster, and reduce on episodes of falling sick and create bonding with us. Is there anything else you would like to add? Interesting. They reported a tremendous increase in staff morale and increased job satisfaction among a group of nurses that would have 2 nurses looking after 30 babies in the NICU. They had more babies that were warm on admission, babies better triaged for care because they decided to separate the sick and the stable babies, improved relationships with parents, and the workload was not perceived as being increased because parents taught parents. Better parent satisfaction, part of this was the increased feeding for mothers in needs. Arrangements were made to utilize the kitchen that provided food for children that were severely malnourished and provide the mother with rice and beans if she was authorized by a physician or a nurse to receive this because she had no other way of looking after this. The mothers were tremendously happy with this. This method of looking after our tiny babies is very exciting. We carry our babies in our chest, between our breasts. You can see the baby growing every day. My baby was born at 1050 grams, dropped to 950 grams, now has gone to 1200 grams and another 10 grams. This is amazing. I think all of you have seen this. In summary then, integration with quality improvement is helpful in kangaroo mother care implementation. QuickMIC, Quality Improvement Integrated Kangaroo Mother Care, is efficient and effective in implementation and monitoring of KMC. The focus on mothers and other family members providing care is considered a key to success. The Rotary partnership in establishing KMC had benefits for babies, families, and staff. There was recognition of positive results by the community and the government. This is self-sustaining and has now been expanded to other programs in Uganda and Tanzania and now in India. Further studies are needed to assess the implementation, the use of what people learn, and the actual impact on newborn babies and families in each of the local sections, areas. Information, if people wish, is posted on the website indicated. We thank the families, healthcare providers, consultants for their participation in this project, providing opportunity to contribute to better care and outcome for small babies. Thank you.
Thank you very much, Dr. Douglas, for an excellent presentation. And I think the focus of bringing in the element of quality improvement is amazing. I think this is something which is, we say point of now, WHO has come up with guidance on point of care quality improvement, which we call POCI as a process. Thank you. And I think it's very clear that these kind of projects bring in advocacy. An immediate benefit was increasing the number of beds from 4 to 8, and then scale up not only in Uganda but Tanzania as well. And the quotes from the mother and the father were interesting. Thank you very much once again. Let's give them a big hand. Now I hand over to my co-chair for taking the next 3 presentations. Over to you, Dr. Siman.
Thank you, Nina. We move forward, and there's one very important thing. We've been hearing about the importance of KMC to the newborns, low birth weight babies and all. But now we will be hearing the benefits of KM to families. Especially, please remember, we've been talking all the time about mother. But now we will be having Nalini. She will be telling us it's not only the mother, but the whole family is involved. It's not the father also, but please remember, any member of the family and also the caregivers. There are many times caregivers who give home visit. They are also to be taught about it. Yes, Nalini, thank you.
It's not coming up. Can you put it up? Okay. So when we provide KMC, we always talk about babies And I wanted to shift our focus a little bit and look at mothers. The mothers that are providing KMC, this is qualitative data. They're scared. They have a lot of anxiety. They really are made to feel initially because the baby is taken away from them, the baby is not theirs, and they're scared of harm to the baby. And the mothers do not reach easily a steady state where they're comfortable in providing care to their babies. If we look at what happens to the mothers, 1 in 5 mothers will have postpartum depression at some point in their immediate 1 year after birth. Now, you could say this is more data from the Western countries, but if you look at the studies, it's not just data from the Western countries, it's also data from some of the developed areas of the world. Somehow the slides skipped, so I'm now going to go back in the interest of time. But there was a meta-analysis done for WHO, which the reference is there, looking at all the studies till the end of from 1950 to 2022, and was published at the end of 2022, and showed the effect on what happens with the mothers. So if you look at postpartum depression, what happens? It favors kangaroo mother care. But if you only think about it for a minute, anything that will decrease postpartum depression, and it does it by up to 25%, if we had a drug that would do that in a randomized trial, we'd be jumping up and down and saying, let's do this, let's do this. The pharmaceuticals would be telling us, and all the doctors and nurses would be signing up. And yet, we are told that, and we're not getting our obstetric colleagues to sign up with us. Why? Because we've been talking about the baby only, and we need to start talking about the mother also, in addition to the baby. Now, if we look at maternal depressive symptoms, it's just as effective. So this is standardized data with standardized depression scores, and the studies that are included in this analysis are only the ones that had used the standardized depressive scores, not just qualitative data. Again, favors kangaroo mother care. Maternal anxiety. If you look at standardized scores of maternal anxiety, it's even much more favorable to decreasing in maternal anxiety. And this is not immediate kangaroo mother care. As I said, we missed some of the slides. This is an average kangaroo mother care being provided for 5.4 hours. So not significant, but still very significant in terms of outcomes. Maternal distress, again, it decreases maternal distress quite favorably. So as I've shown you, none of these have a bad impact on the mother. All of them have a significant good impact on the mother. And we need to highlight that. And the reason I wanted to choose this topic was because we're having problems convincing our obstetric colleagues, and I think the way forward is to combine. We talk about the dyad, but we only talk about the benefits to the baby. And when we're talking about the dyad, we owe it to ourselves to talk about the mother also. Maternal bonding, we've all known, increases, as does breastfeeding, and favors kangaroo mother care alone. Now, I would have loved to have told you that there's enough data on what happens with the fathers and the family. There are some studies suggesting there is some impact on the father's mental health, but there are also some studies suggesting that it has a negative impact on family life because the mother is in the hospital for a long time and the father has other kids to deal with. So none of that data is currently enough to say that what the impact on the families is. Some of the qualitative data suggests that the impact on the families is good. So in summary, what did I show you? I showed you significant data on decreased maternal postpartum depression, which is a huge problem, as I said, 1 in 5 mothers. I showed you decrease in maternal depression and anxiety scores, which again is a huge problem. 25% of the mothers will have anxiety and depression. I showed you improved bonding scores, improved breastfeeding, but I couldn't quite convince you of this impact on the fathers and the families, which I'm hoping we will get in the near future. I have one more quick suggestion, which is if we could somehow stop calling ourselves healthcare providers, we're not the ones providing care to the baby. If we could change our name to healthcare facilitators that help the families provide the care, I'd be very appreciative. Thank you.
Thank you, Nalini. I'm sure we all have seen our mothers having this postpartum depression, and whatever you have told us about people, mother-in-law, somebody really neglecting the mother, taking away the baby from her, and that is causing a lot of anxiety and depression. The problem here is what is depression and what is anxiety. See, many times people don't understand that anxiety is different from depression, and that is what it has to be put down to them. Thanks a lot, Nalini. It was indeed very enterprising for us, all of us, to know the difference that is happening over there and also here. Thank you once again. Please.
Before we move towards the next speaker, I would like to welcome Dr. Manish Mehta, sir. As all of you know, we are all neonatologists and intensivists. He had an emergency. So he is an intensivist at Synergy Hospital, and he is an EB member for ID Chapter Academy of Pediatrics. Welcome you, sir.
We have a very eminent next speaker, Dr. Shobna Gupta, who is a Deputy Commissioner in charge of Child Health and RBSK and of Maternal Health.
A very good morning to everyone. Thank you, chairs, Dr. Irani ma'am, Dr. Neena Raina, Dr. Manish, all the esteemed participants, my mentors, teachers, my many colleagues are sitting here. So it's really nice to be out here, standing in front of them on behalf of Government of India. At the outset, I would like to thank Dr. Shashivani ma'am and the KMC Foundation of India for organizing this wonderful workshop on this very important theme of kangaroo mother care with a large impact. So kudos to the team of KMC Foundation. And many people, I was listening to all these speakers from different countries. So definitely kangaroo mother care, no doubt, undoubtedly is a intervention being talked about for so long with such a high impact. But definitely there are barriers and challenges in implementing all over India, or I would say in the world still. So I will just like you all to take through a brief what Government of India stand is there, what we are doing, and what is the upcoming vision way forward, that how the upscaling can be done in the near future. So as we know, in India we have around 26 million births per annum, and most of the births, I would say 89% of the births are now institutional, out of which, if we go to the burden in India, we have, as per the National Family Health Survey, around 18% of the low birth weight babies are born. But still the major cause of mortality in 1920, as per the 46% mortality is still attributed to our prematurity and low birth weight. So that much is the burden if we talk about low birth weight and the importance of low birth and sick babies focusing on. As my previous speakers have told you about the INAP plan, the India Newborn Action Plan, where we had a goal of reaching to single digit NMR by 2030, and right now, as per the SRS, our sample review survey system 2020, we are at 20 per 1,000 live birth. Going by the trajectory, India is on the trajectory and should reach by 2030, but again, as we said, that the last mile is the most difficult. So here the need for convergence, integration and the quality comes, of which KMC definitely is a major part. KMC along with your early childhood development and components for the intact survival, that will actually lead us to reach that goal. Coming to the few initiatives which we have done in long back in 2011, we first came out with the facility-based newborn care guidelines, where KMC was one of the component to start with. In 2014, in response to the every newborn action plan of the global plan, India came out with INAP plan, and in that subsequently, as KMC was an important part of INAP, we came out our KMC national guidelines by the Government of India, for which there were budget provisions I would be talking about. In 2016, as we move forward with the further evidence, the guidelines were issued on the family participatory care with the involvement of the family, parents. So these guidelines are actually, just to apprise my audience who are not from India, that from Ministry of Health, the Child Health Division being a technical division, we issued technical guidelines to all these states which are come under the National Health Mission. In those guidelines, we also have a provision of budgetary provision that for the infrastructure, for the trainings rollout, and how they have to go about. So all that mentoring support is also provided. In 2018, with the ongoing evidence going on, we came out with the guidance note of the Mother Newborn Care Unit, again for which we had the support from the GOI. And with 2022, we did the midterm review of our India Newborn Action Plan. It was planned in 2020. We started in 2021, and in last 2 years, that review of the plan was done. That report is yet to be released by the GOI officially, but in the recommendations of those MTR review of INAP, the KMC intervention, the family participation, and the Mother Newborn Care Unit has a special focus, which we'll be seeing in the coming years to you. As we have already know, we all know we are here, it is the most powerful intervention for reducing mortality to the tune of 1/4 of the newborn deaths can be averted by universalization of the kangaroo care, and definitely the low birth weight babies, the less than 2,000 grams baby, have a 40% higher survival if it is being given. And this is the one of the priority which has been mentioned in the facility-based intervention for small newborn in the India Newborn Action Plan also. Just one thing which we have seen while visits to the facilities, that often if you ask the sisters when you go to the labor room, have you given KMC? Often this immediate skin to skin is very often confused with the KMC. That you keep the baby on the mother's abdomen for 5 minutes, 10 minutes, you take out and they say, yes, KMC tum dete hai. So there is often that confusion among our health providers who are at the ground level, that KMC is same as immediate skin to skin. So that differentiation, these are soft parameters which I'm sure the Dr. Macmillan in her quality improvement workshop would also be focusing on. So these are the softer parameters which need to be clarified at the ground level by giving trainings, that both are different things, though the purpose might be the same, but they have a separate value. Coming to the outcome of low birth weight and premature babies at every point, as we say, starting from the delivery point where we are facility-based institutional delivery. So India has around 22,000 plus newborn delivery points. So in those delivery points, it starts definitely with the skin-to-skin care. Not only and for the admission criteria, the less than 2,000 grams baby or less than 1,800 somewhere, that is the criteria for admission to the special newborn care unit or the newborn specialization unit. So those 1,800 to 2,500 grams are mostly with the mother in the postnatal ward. So giving kangaroo mother care at that level. Coming to we launched the MA program for the promotion of the immediate and the exclusive breastfeeding. So again, promotion of breastfeeding, definitely, as Dr. Rana also said, that it cannot be done alone. It is a package. You have to start with the essential newborn care. So your immediate skin to skin, early initiation of breastfeeding, continuing breastfeeding definitely makes a package out of which KMC is giving you additional benefits to that. So again, the promotion of the MA program. Then when it comes to the facility, when the baby is admitted in our SNCUs or NICUs, so having chairs at the facility level, and when they are followed up for at the SNCU or even our district early intervention center where our babies who are discharged from SNCU are coming, so counseling at that level for the continued KMC. And again, as we have seen, the family participatory care by the family, by the fathers, in-laws. In India, we have, system of joint family. So the family is a very important part to making the maternal or the paternal grandmother as a part of your caregiving is a very important part which has to be followed. So different guidelines as we have talked about these two are we have the guidelines for the home-based newborn care and the young infant care which are being done at the community level by our peripheral health worker which are called the ASHA workers. So the community KMC which we are talking about, so it's really important now that this community KMC part has to be made an important part of these guidelines in the version 2.0. That's what we are thinking of. It is there right now also, but definitely the more importance and the more stress on the trainings at that part. And these are the newer guidelines we have come out last year about the Palan, the journey of first 1,000 days. It starts when the mother gets pregnant in the antenatal period, talking about the early childhood development, the neural connections, how the mother's touch, the mother's bonding, that develops. So for promotion of this Palan first 1,000 days, we have early childhood ECD call centers that provision is given by Government of India, and some of these states like Meghalaya, they have set up a beautiful ECD call center. They have multiple, because in some of the northeastern state, the reach out is very difficult. It is very difficult for families in far-flung areas to come to the health facility. So there these community programs and our call centers, they play a big role in promotion and motivating the mothers to their day-to-day problems. So in the journey of first 1,000 days, again ECD and KMC, that becomes an integral part. And we have come with our revised facility-based newborn care training package, which was released last week during National Newborn Week. And the final version will be taking out within a month's time. And here also we have integrated our KMC with the newer revised guidelines, where the new WHO guidelines criteria of our 8 hours of minimum KMC in less than 2,500 grams, and even to small and sick babies. So we have included that package along with the revised note of the MNCU care package and the provisions for providing the facilities for infrastructure and the trainings. So this KMC intervention we have talked about. Somebody was telling about the provision for providing we have a budget for providing KMC. It was well there. So when the states ask us about the KMC state specific budget, that is being given. The training norms are there. The infrastructure is there. However, there is a gap in the implementation pan-India level because it is right now up to the state. So we plan to take it as a rollout this KMC in a more integrated approach so that we can escalate to the pan-India level. And it's very important that, for the implementation, it is being addressed at all the levels. Right now, what is happening, it is mainly either at the facilities, and now we are promoting community. So even your newborn stabilization units, where there are small babies mainly for the feeding, so there also we need to escalate it. Just a few data which I would like to share in less than 2,500. This is from our portal where we have the SNCU portal that in 2021, out of the 516,000 babies which were admitted, the low birth weight, around 36% got KMC. And in this quarter till now, around 40% babies have got KMC. So right now the reporting format, whether the baby is receiving KMC or not, and the till day of life they are getting. So if we see by 48 hours of life, around 26% had KMC, but there is a rapid decline as the baby's admission days goes on. So definitely this reporting format should need to be modified further for better quality supervision. Coming to the mother newborn care unit, as I told you that we had a guidance note in 2018 which shows the involvement of mothers in the care of the sick and small babies. So it has all the components. If we talk about the feeding support, the early nurturing care, supportive care from the mother, the benefits to the mother itself in the postpartum depression, as Dr. Nalini has told, and the zero separation of the mother at all levels. So the mother and the baby have to be together for adequate provisions. And till now we have 158 MNCUs from our record, which have the states, so it's very state specific right now, so that geographical variation is there, and they have been approved and functional pan-India. Now coming to the challenges as we have talked about actually. First and foremost, as we know, is the awareness required at all the levels, the providers and the users. If you see many a times, actually, when we go and talk to them, I think many of the pediatricians I have seen which are not confident in providing, a baby with the mother. That something can happen, infection can prevent. So first is the healthcare provider who has to be convinced. Once your doctor is convinced, then only you can convince your staff nurses and your supporting staff. Then comes definitely the users. So if the doctor is confident, I believe the mother believes in us. In India at least, people have a lot of faith in the healthcare providers. So if the healthcare provider is confident and motivated, mothers, they just follow what their doctors and the staff nurses say. That second is the intra and the inter-department coordination is very important. As we say for KMC, we are not targeting only the baby, it is the mother and the baby together. So we have to have that coordination with our nurses, with our obstetrician colleagues, with our pediatricians, along with definitely the policy and partners helping them out. But that coordination and convincing has to be there at all levels. Regarding the need for the dedicated and trained human, this is the thing, as we know, KMC is a very low cost impact intervention, high impact, low cost. So, and for the trainings we give up from GOI. What we require is a capacity building. I think that needs to be escalated at a scale up in the next 2 years, pan-India, so that it's a mind game, I believe. So if they are trained, they are convinced, we would be able to do it. Regarding the data collection and uniform monitoring formats, we have decided to come up with the revised monitoring format. Once the people will be trained, they would be ready to write how much hours of KMC has been provided at what level. Counseling has to be a continuous procedure, not during stay, even after discharge, and once the baby is in the community, when the baby is coming for the follow-up. And right now, I believe that private sector and government sector inter-coordination is little, is not at the level it should be. So definitely there has to be a universal policy at the private sector also, because why still in some of these states more than 50% babies are going to the private sector. So why the private sector cannot do it? Or why they cannot have the beds or the KMC implementation? So that is really needed if we want to achieve the SDG targets. Some of our states had an NMR of 3 and 5 and 6. So they need to indulge the private sector if they want to reduce further. So the way forward, as I said, would be the KMC at all levels, at all the delivery points, with the zero separation of the mother, early and continued is the mantra. In some of these states, so it has to be, India is a big country. There are variations in the states. So it has to be, some of the things have to be state specific. So the states which are already doing very good, they have to have more specialized ways of having neonatal nurses, more of IEC, BCC in their local language to promote and motivate the staff. And we have a quality parameter Muskan initiative where the special newborn care units and the NBSU are quality certified. So in those we have one of the key performance indicator is the number of hours the child is being given kangaroo mother care. So their serial number 11 is about the KMC, the continued and the early KMC being given. So there the limit was initially at least 1 hour. So that is one of the quality parameter which we have engaged to maintain the, to promote the KMC. This is my last slide. I hope I'm not crossing the time. Yeah. So in the INAB recommendations, the document which I was talking about, so we have the provision of establishment of mother neonatal care unit at the NICU, SNCU and even at the NBSU level. Because many a times people don't have, in the states their beds are not there. So if the mother is there, that problem of providing a bed to the mother, diet to the mother and other things will be taken care of. And we at GOI also give diet to the mother if the states say that we do not have option, we do provide the funds even for the diet to the mother for all the babies who are admitted in SNCU, because KMC and continued breastfeeding and ECD is a mandate. Secondly, the provision of immediate KMC in all the facility centers. That provision is there, so whatever state and the facilities feel they are capable of doing it, they can very well start it. Provision of community KMC by family members, and monitoring and indicators on KMC on our HIMS dashboard that will be seen. So these are the key recommendations regarding KMC which has come out our midterm review document of the INAP. So thank you for the patient listening, and definitely I feel that by the collaborative efforts of all of us, including the doctors, the partners, the WHO, UNICEF, all the UN agencies, and our staff nurses, doctors, we should be able to reach our SDG goal very soon. Thank you.
Thank you, Shobna. It was indeed a very nice presentation explaining the various programs which are available. It is only necessary for us to snatch all those programs and explain to the people how it should go around. You have really mentioned about the mistake which is being made in KMC, that is the skin-to-skin contact. And that is something which is left to the doctors and the nurses to explain exactly what it is. Secondly, you have mentioned about DEIC. But I would like to say that here it is very important to counsel properly for people to go where. And whether those centers are really established, there is infrastructure, no doubt. But the people working there, they should really know where we are referring. So that is a very important thing. The third point which you pointed out was follow-up, which is really poor. I mean, the first, second follow-up is good, then it just dwindles down. So really we don't have the exact data of what is happening. So KMC is one thing we know, it's very good. But I think the parents should be involved, especially when the fathers are spoken, they should be told. Counseling is something which we are lacking, and that is where we should really take. But thanks a million, and I think it has enlightened us, all of us, with all the different programs. Thank you.
I think Dr. Mehta to introduce the last speaker.
So before I introduce our next speaker, one thing happy to know 158 mother and neonatal nursery units are there with government, and in Ahmedabad I think Dr. Ashish Mehta sir has started the first unit with mother and newborn baby together, and hope to see more units in future. So I'll invite, it's my pleasure to invite our next speaker, Dr. Naraya Gaonkar sir. Everyone knows him very well. He is a health specialist UNICEF and always very enthusiastic for anything related to newborn and mother health. Welcome sir.
Thank you very much, respected chairpersons. I really thank KMC Foundation and all the partners gathered here to promote KMC for better survival. I bring greetings from UNICEF to all of you. So thank you very much for joining and cheering the organizing team to do more on the technical sessions and inspire the champions. There are a lot of champions we met. Madam, very happy to note that for the pre-conference workshop, our chief guests and guest of honors were the KMC babies, who got benefited. So it was so nice to see parents coming and talking their experiences. So we strongly believe early moments matter for every child. So in UNICEF, we would like to now advance the child survival through a humanized touch. So globally, we are supporting a nurturing care framework, where one of the main domains, the parenting, can very well take care of a lot of KMC requirement at home as well as in the facilities. We're also mindful that some of these babies need more than the others. So we have a small and vulnerable newborns. So these are the one who will get major advantage or benefits from all the efforts we do in KMC. So our focus, while remains on every baby, but additional focus or the sharpening the focus will be on these babies to promote their survival and development. So many of you know what UNICEF does globally to promote KMC and newborn survival. I just wanted to list. These are our engagements where we support mainly the Government of India and the partners in Gujarat. KMC Foundation is part of all our interventions. Whenever we do KMC, it is together with the partners, of course, under the leadership of the government to do it in a large scale all the time. So I just want to bring some of the experiences we had. We undertook assessment of KMC practices in all the medical college hospitals and district hospital few years ago. This was again together with KMC Foundation and IAP and medical colleges. So basically wanted to understand what is the level of implementation, what are the implementation bottlenecks, and what are the good practices which can be scaled up, and what is that we can recommend to the government of Gujarat as well as central government. So thankfully, we are very successful in recommending some of the improvement plans in central government also, thanks to Dr. Sheshivani, taking it forward for the national level debate and dialogue, which actually given us some good result. So just to say, it was a pan-Gujarat kind of initiative. We had a state level consultation to design strategies, what are the assessment criteria to see effectiveness of KMC implementation in the facility. Then we took a field visit with the experts. It was a very nice initiative where there were some young faculties, but also all the experts, the best of the experts we had in KMC were in the field to see the implementation level. You see some of the senior pediatricians in the picture. And then after the assessment, we came back together to make recommendations to the government. I just want to say a few things only. We found 92% of facilities were actually practicing KMC with the varying level of implementation. Some are excellent, some are actually progressing, but I remember what Dr. Sheshivani was saying that time. Irrespective of where we stand, you think what else can be done to advance KMC in your facility. So thank you, madam, for being the beacon that time to show the light where we have to move. So approximately 65% of the staff nurses and 80% of the clinicians interviewed were aware, and they were practicing KMC. So the rest actually we have to push hard subsequently. So it was also heartening to know, even that point of time, many facilities were promoting fathers or encouraging the father to do KMC. We have some challenges of privacy and same room and other things. I hear from Dr. Shobna and other colleagues that there are many states where the father's room is separately available and large number of fathers do provide care. So we can look into all the available good practices and learn more from those states and and the countries who do it differently. I saw Tamil Nadu where during the duty changing or cleaning time, the fathers were made to do KMC outside the hospital in the little bit light, so they were taking responsibility when mothers are getting ready, cleaning themselves. The fathers were doing KMC in a very nice environment, open air, of course, under the shade. So there are many good practices we can learn from and, try to improve incrementally so that we, advance KMC. So we also saw, there are some champions you see among the crowd today. They were counseling very well and convincing the mother, father, what is the need, how it benefits the child and also the mother. Some places, some enabling environment was very conducive to promote KMC. Many were actually promoting the positioning. If the proper positioning is not maintained, subsequently it becomes challenging. So I also wanted to bring, it is not only in Gujarat, all over India where UNICEF office is present, we promote KMC. Our colleagues in Maharashtra, again with the support of the KMC Foundation, did some extraordinary work in Maharashtra. We have a chair, Madam Irani is there. So you see some of the pictures here. They did a large scale TOT, and we have a home-based newborn care module in Maharashtra. We'll hear some good news in the evening. We are also planning to do the same thing in Gujarat. So they could kind of take it to every single district and wherever KMC wards and space are not there, they created. They looped in political leaders, they looped in medical superintendents, and then they made attempt in last 2 years to kind of take it to every single district. Madam, the chairperson, she's there, so you can share more experiences. But I don't want to miss this opportunity. And we have a lot of success stories. The photos are not of great quality, but they tell stories. The babies who are given KMC, they turn up for facility follow-up, and the growth and development is monitored. We do in Gujarat, in many of the medical college hospital, district hospital, similar thing. There's a linear tracking of the baby's discharge, and happy to see they are doing well following KMC practices at facility, at home, and subsequent development tracking is giving good results. And we have a lot of groups, WhatsApp groups for SNCUs, and we hear a lot of human interest stories every single day, inspiring others to do more. So we are more convinced than before supporting Government of India's support for promoting family participatory care. and also MNCUs. So we are taking baby steps, and we are also convinced, basically the pediatricians and the healthcare providers, even the baby can be given a CPAP when in KMC position. So we practice all of them. Of course, again, it depends on facility to facility. The implementation level differs. But I'm very proud and very happy to be part of some journey for the tactile and the sensory stimulation in SNCUs. These pictures are from Rajkot Medical College. We have a very dedicated team over there. There is a SNCU, there's a grower area, and where family participatory care is a norm now. And the mothers and the caregivers teach the new mothers who are coming there about KMC and participatory care. And it's very very much we use different patterns of clothes. Even see dotted black and white stimulation, and even switching off the light. There's also kind of nesting, the tactile stimulation. And I also heard from the nurses, the KMC also relieves pain for many of the babies in the ICU setup. So there also, mothers are very happy that, when I put here, baby keeps cool, and look at the mother. Sometimes, they feel so much of warmth in the mother's arm, and then pain is forgotten sometimes. A baby is in the ICU. So these are something very interesting, and, people are immediately feeling the difference in the quality of care when they are provided KMC. And we are developing guideline, how you can take it, the guideline in a sense, operational guideline, the national guideline and global guidelines exist on these things, but we would like to take these good practices to scale in a simplified way, easily acceptable way, and hopefully in a year or two, we would like to see this practice in every single SNCU in Gujarat, and would like to share this with the national level as well. So we also are part of the journey, comprehensive lactation management centers. We have around 15 of them in Gujarat. So they are making big difference, and fathers are encouraged to provide KMC when mother is not in a position, and at the same time the family members, they are providing KMC, and this is doing magic, where the doctor, we have some colleagues where Baroda, actually I heard more than 1,000 babies, maybe 1,000 plus babies getting benefited every year from these interventions. Imagine the scale, we do it in every single district. So I would like to seek the attention in state where we are having conference, more than 51% of delivery happen in private sector, and we do everything for the government sector in a structured approach, but still miss a large proportion of private sector. So we had an initiative a couple of years ago, 2018, integrated actions towards intact newborn survival. But the beauty is every time we think of new intervention, we stay together. KMC Foundation, IAP, NNF, everybody was there. So KMC was integral part of this effort. And now we would like to take this in a IAP ECD module, some of them. So large number of facilities, private facilities were assessed, skill stations were used when we are training this identified facility. And that time, 70% of the private practitioners were having some practice of KMC. And hopefully following the training, the things have improved. Dr. Manish was there as part of the team, so So what I mean to say, we cannot forget private sector. Actually, in many states, the proportion of care provided by private sector is increasing. So we need to think of them, and they also have a lot of influence in the general practice, not only pediatric practice, general practice. They have a lot of influence by these pediatricians. So if you can take them together, we have a lot of experts in the audience also who are part of this journey. So we need to think of them when we design the scale-up plan. So KMC stayed as an integral part of our Child Survival Initiative even during COVID time. Again, you see the profile of speakers, they are actually coming from the same pool, like we don't forget the partners, we do together. So during COVID, we had sensed a large number of people, thousands of people actually followed us, following, in the session we had around 580 people, but there are more than 1,000 people were following on a virtual and other platforms. So this is important, we take different approaches and multi-pronged strategies to popularize KMC. We have a lot of ongoing efforts in the government, facility-based newborn care, home-based newborn care, IMNCI, early childhood development interventions. So I was just requesting Madam Shobna Gupta also to see how we can further strengthen, intensify KMC component in the existing module so that we reach universe. for the it can be part of primary healthcare strategy. It can be integral part of our MNH strategy. We all agree. So we'll see how to take it to every healthcare worker and every newborn, these evidence-based intervention. The awareness generation, International KMC Day provides an opportunity for us to come together again, to advocate together, so we can do it more often now. And I thank Shashivani Madam for organizing state conferences of national conferences of KMC every year, but every time in a new state. It also gives an opportunity to build the environment and build champions and share experiences. So we are happy to support KMC Foundation in these efforts as well. Thank you, Madam, for leading. Yeah. The civil society organization play a big role. You might have seen some of them in the pre-conference workshops. They actually have a lot of influence in the community. Tribhuvandas Foundation is one such organization which is creating magic, So we would like to see more such organizations everywhere promoting KMC and influencing communities to adopt KMC norms. So we strongly believe early movements really matter for every child. And if we change the beginning of the story, we can change the whole story. Thank you so much for promoting KMC.
Thank you very much, sir, for a lucid presentation. And as sir said, the INTECT program of IAP, which was there along with UNICEF, and we found almost 70% of the private facilities were doing some part of the KMC, but I think KMC should be part of each and every IAP conference in future. So that will definitely spread more among the private practitioners, because we find some resistance in the private practitioners still yet. Thank you very much, sir.
Thank you, Dr. Narayan. And I'd like to I'll briefly summarize. There were 7 presentations, and there are 7 key points and key messages to be taken home. So the first one, I think, is very clear. KMC is possible, and it is not skin to skin. And I think that's something which we need to really break the myth. We presume that our health workers, once trained, understand it. And that presumption, I think, has been proven wrong. So we need to really clearly indicate that KMC is possible, skin to skin is not KMC. So that's the first message. The second one is we can't go on with KMC as a stand-alone intervention to be promoted in health facilities. So we need to integrate it with other interventions which are for essential newborn care, and which in fact KMC gives the benefit, like exclusive breastfeeding, early initiation of breastfeeding, prevention of infection. So there are many things. So we need to create a bundle of intervention under the leadership of KMC. So I think that's the second message, which is very clear. Third message, I think WHO has produced guidelines, but these guidelines will remain on the shelf unless there is a policy change, there is a policy commitment, there is capacity building, the investment in health system strengthening. KMC does not come free. It's not free. Investments are required, and I think that's the message every policy maker and I would say government needs to understand. Yes, it's a soft skill, but it needs health system strengthening. And I think Dr. Shobna's slide clearly indicated how much money is required if you want to establish a KMC unit in a facility. We need some more data on the investment, how much. Less we go to a donor, then we should be very clear how much data is required. And the next one, I think, which came on very well, that implementation and scale-up is the way forward with focus on standard indicators. I think we need to agree on the standard indicators. Otherwise, HMI's data, in any case, we say garbage in, garbage out. But then if we don't have these standard indicators, what data? Everybody will collect their own data based on their own understanding of the indicators. So I think that standardization is required. And monitoring quality and outcome. I think is extremely important. We need continuum from facility. We need also a community-based follow-up for the KMC, whether it was continued or not. We need to focus on the benefits of the mother, and thanks Dr. Singhal for bringing in a very important aspect. I think it's a different take you have given us, a food for thought. And we need some qualitative studies to understand the benefits to the mother and the families, or even the negative impact. And we need, I think, involve obstetrician. How many of you are obstetricians here? Can you raise your hand? See, I know. 2. So please, you are the 2 champions which will bring 200 next time to this kind of a conference on KMC. So we need to, I think, involve obstetricians as well, so that they can motivate the mothers and they can really support the mothers, because it's not, and I saw one of the slides saying in cesarean section, from less than 5%, it got to 19% of early initiation of breastfeeding. And I said 19% is still too low. Why every mother who has undergone cesarean cannot initiate breastfeeding early, and that's where the obstetricians come in. So I think my advocacy is for focusing on mothers, and I think you people can lead the way. We need partnerships. I think every one of you in your slides talked about partnerships, whether it's public-private partnerships or it's partnerships with the donors and development partners. And the Ministry of Health in all countries need to be in the driver's seat. I think that's very, very important. They can pull all the partners together and make sure that the scale-up with quality happens. Otherwise, we just count the numbers, but we don't know the quality. And that's the reason when the evidence comes, we say 40% reduction in mortality. But in reality, even if you scale up to 100% facilities, if you don't achieve 40% reduction in mortality, then KMC is not working. The quality is not there. So I think these are some of the messages, take-home messages from this session. And I would like to again thank all the speakers, the presenters, and I hope Dr. Shashivani will be getting the presentations in a pen drive or online through a link. Thank you very much once again. Thanks to my partners on my left and right, Dr. Mehta and Dr. Simin Irani. Thank you. And we finished on time. Dr. Shashivani, you need to really applaud this chair. All the chairpersons for finishing on time. Thank you.
Thank you so much, Madam, for so excellent summarization. Thank you all the speakers and the chairperson for the first session. We really had a very great treat. We have a few important announcements before we move towards the next part of the conference. We will be having a formal inaugural function of the conference today in the same hall, and we request every one of you to be present by 4:45. After the inaugural ceremony, we will have a banquet dinner and cultural evening at Rajwadu at 8 p.m. And one more, a most important announcement. Let us make our Sunday morning more memorable towards the noble cause for which we have gathered over here. We have arranged a KMC awareness walk at Law Garden, which is the most happening area of the city. The march will start sharp at 7 tomorrow. We now invite all of you for the inauguration of the KMC exhibition by nursing group from Karamsad Medical College. And to do the honor, we are fortunate to have Dr. Nalini Singhal Madam from Canada with us. Thank you so much. Ma'am, please proceed for the KMC posters inauguration.
poster walk, we have tea break for 10 minutes, and I request all the delegates and the speakers to please gather on time so we have a wonderful treat of all the academic sessions.
કઈ કઈ છે મને બતાવો પછી આપણે આ તમે ખોલેલું ને
Welcome back, everyone. Let us continue our journey of enlightening ourselves about such a lovely concept of kangaroo mother care. We begin our second session for the day. On 16th May 2023, World Health Organization published two important new policy and programmatic resources on kangaroo mother care: a global position paper and implementation strategy following the release of landmark new guidelines in year 2022. These guidelines recommend KMC as the essential standard of care starting immediately after birth for all the babies born early or small. These new publications aim to support global implementation and scale up of KMC in line with updated recommendations. That brings us to our second session on viewpoints on recent WHO recommendations of KMC. And to chair the session, it's my pleasure to invite on stage Dr. Socorro de Leon Mendoza and Dr. Ruchi Nanavati, Madam. Dr. Socorro de Leon Mendoza is the founder, chairperson, and president of the KMC Foundation Philippines. She is also the founder president of Asia Oceania network of KMC and has been working in close liaison with international agencies like International KMC Foundation, UNICEF, WHO, and others. We are honored to have you, ma'am, here. Dr. Ruchi Nanavati, madam, is the professor of neonatology. Dr. Ruchi Nanavati is the professor of neonatology at the KEM Hospital, Mumbai. She has been the master trainer for various programs like facility-based newborn care, NRP, and KMC, and winner of many prestigious awards and orations, including the IAP NNF chapter. I hand over the session to the respected chairpersons.
Thank you very much, Madam, for your introduction. We are now ready to begin our session, which focuses on the viewpoints on recent WHO recommendations of kangaroo mother care. To begin the session, we have a speaker from WHO Southeast Asian Regional Office in the person of Dr. Rajesh Khanna. Please.
Respected chairpersons, dear friends and colleagues, I bring greetings from WHO CRO. I am the medical officer for newborn child health at the regional office, and I belong to the same unit as Dr. Rana. I work under her in the Family Health, Gender and Life course unit. Now, it has been very interesting listening to the first half. I was part of the, listening very attentively to what people are thinking. There is a change. But more importantly, what I'm going to share with you is slightly different, or I would say maybe a paradigm shift in the thinking that we all have been thinking about kangaroo mother care. So my presentation is going to go through, of course, the burden, evolution of KMC, which I'm not going to go into the depth, but just trying to bring on what role WHO played with the coordinated researches, which have helped to come to the present stage, where how the new recommendations were drafted, what changes are required, and then, as my friend who just presented started in the beginning, the two documents. What are they telling us? Just a brief background in the Southeast Asia region. Over the last 1 decade, the Southeast Asia region has done tremendously well. Probably in terms of the reduction of the under 5 and neonatal mortality rate, the highest reduction is seen in this region compared to rest of the other regions, and globally it's nearly twice that what we are seeing. However, more than 50% of the deaths are still happening due to preterm and low birth weight babies. I'm just sharing you a little bit of the statistics to show that yes, in terms of low birth weight, we have 40% burden, and in terms of preterm, nearly 36. Because when you consider low birth weight, it includes both preterm and SGA babies. The burden varies between different countries. But one thing is very clear, that there is a much higher risk of mortality among both the preterms and SGA babies. And when you combine them, then it just multiplies the risk of mortality. Now, since 1978, it has been 45 years when KMC started. It has evolved quite a lot, but I would still say till 2015-16, the progress was much slower than what we expected. And one of the big reasons was the lack of concrete evidence. Of course, in 2016, we had the Cochrane review, which showed that if KMC is initiated in health facilities in stable babies, low birth weight, there is about 40% improvement in the survival rate when you compare it by 40-41 weeks. However, there were big gaps in the research. Global KMC coverage was still less than 5%. There was no robust evidence about community-initiated KMC. What do you do? And then one of the biggest challenge was the immediate KMC. I know this because when I was doing my master's in London School, my thesis was also a systematic review on immediate KMC. So in a way, you realize that most of the preterm deaths happen in the first 2 to 3 days. So if we are waiting for those babies to be stabilized, the policy looks very weak. That is where WHO stepped in with the help of all the partners, and it coordinated research in 3 key areas. One was the scaling up. What is the experience? How do we scale up? This was a multi-centric study, again done predominantly in India and Ethiopia. The second was the community-initiated KMC, done in Haryana, again India. And then was the immediate KMC, which was done across 4 countries. It was a randomized controlled trial. In all these 3, you can see the population was quite big. The facility KMC covered about 8 million population. The community-initiated KMC, low birth weight babies who were stable, and it included both those who were born in facilities and discharged home, and also those who were home delivered. And they were initiated within 72 hours of birth. And the third one was the immediate KMC trial, which was done across 4 countries. This covered babies between 1,000 gram and 1,800 grams. And they were initiated on KMC irrespective of their status. The only thing that was required was some restructuring where efforts were made to keep the mothers and newborns together right from birth. And I think we have Dr. Chelani with us, who led one of those centers in India. If you look into the outcome, in the scaling up, we saw about 50 to 80% KMC coverage was achieved. Community initiative KMC, we saw a 30% reduced risk of mortality in those who were initiated on KMC compared to those who were given conventional care. And in the immediate KMC group, 25% lower mortality in the first 28 days. In addition to it, there were benefits in reduction of infection, hypothermia, and hospitalization. So I'm not including those, but just letting you know the primary outcome that was used. I'm not saying that these are not important, the other outcomes, but I'm just focusing on the mortality reduction. Based on this new evidence, a modeling exercise was done. And what was realized was that if all these 3 interventions are integrated and brought together, then you have a potential to reduce 400,000 additional deaths of preterms and low birth weights. This is 1/3 of the total this is sorry, 40% of the total newborn deaths. And in terms of preterm and low birth weight, it's more than 60% of the preterm and low birth weight deaths which can be prevented. Based on this, the new recommendations were drafted. These have been published in the guidelines on preterm and low birth weight care. The first clearly says it is recommended as routine care for all preterm and low birth weight babies, not full term. Please kindly note. Second, it can be initiated at any place, health facility or home. And third, very important, which we often ignore, is that it should be given prolonged and for continuous duration, minimum 8 hours in a day. The second important recommendation, which is it should be initiated as soon as possible. Now this means irrespective of the status, the clinical status of the low birth weight or preterm baby. Now you will see somewhere it's written strong recommendation, high certainty evidence and all. This is the way the guideline process takes place. When WHO develops guidelines, it looks into evidence on one aspect. And when you look into the evidence, you look into the certainty. It is, when you do a meta-analysis, is it high certainty, moderate, or low certainty? Simultaneously, you also look into other factors, which is known as the decision framework, decision to evidence. You look into actually 7 criteria of how robust is the evidence, acceptability, feasibility, cost effectiveness, what are the resources, and is it going to be acceptable for the community. So there are 7 criteria, which is known as your decision, evidence to decision framework. So I'm not going into the depth of it, but just letting you know that it's not only evidence that was seen, you also look into practical aspects from a systems perspective and community acceptance. Now this slide I have specifically put, thank you Dr. Shobna that she pointed out that KMC different from skin to skin contact. But in order to be identified as KMC, there are 4 essential criteria and you cannot ignore any one of them. If one criteria is not there, I'm sorry, the forward movement is, the thinking is that you should not call it KMC. First, very clear preterm low birth weight babies, both well and sick, continuous and prolonged. Kindly note minimum 8 hours a day. Third, support for exclusive breastfeeding or breast milk feeding. This is unfortunately lacking in many scenarios that we have seen. And the last, once a baby is discharged or the KMC is initiated at home, you need to closely monitor that baby. Importantly, what was realized why KMC was failing was that there was not enough support for the parents, for the mother, parents, and families. So these systematic reviews were conducted. And in addition to systematic reviews, you see there is a good practice statement, which is intuitive. You don't have evidence for it, but it makes common sense. So a lot of good recommendations came up for how do you involve the mother, family, and support them. Important thing is you can also see there is a strong recommendation and conditional. Strong means there is evidence and it should be done in all settings. Conditional is depending on the settings. Maybe in high income countries where there's already this system available, you do not need to apply. Following this, there were 2 supporting documents that came up. And what was the need for it? It was realized that KMC has been lagging behind for quite some time. And just creating evidence and giving guidance and recommendations is not going to be helpful. What we need to do is to mobilize support from all the partners including the community, and commit to it. So you had the global position paper, which summarizes all the history of KMC, the evidence, and the rationale for making it as a prerequisite for provision of care for preterms and low birth weight, and then mobilize support. And then was the implementation strategy. No, quite challenging. We bring in a paradigm shift, but how do we support the countries? Now, this was not done by WHO. We have a strategy, we call it the STAGE, the Strategic and Technical Advisory Group of Experts, which meet every 6 months at the headquarters level. A KMC group was formed, and these were the partners who were part of it. This group was led by Professor Betty Kirkwood and Gary Darmstadt. Betty Kirkwood from the London School and Gary Darmstadt from Johns Hopkins. Now, they presented a very different vision for maternal newborn care. Now, I would really like all of you to focus here. First of all, they have said a vision, a service delivery model where mothers, newborns, parents, and families form an inseparable center. You are keeping them in the center of whatever work you are doing. Second, the health service delivery has to be organized around it. We usually go the other way around. We first plan and organize the services and then think of how do we get them in. And the third, this has to be done with close collaboration with healthcare providers and all the partners. A big change is how are we keeping our maternal and neonatal units. We know things are different in the places that we work, in the health facilities, medical colleges. These are separate units. But they gave a forward vision of how do you restructure maternal and newborn care units as single units. You change the layout so that mothers and newborns, zero separation even when either of them is sick. The third, it does not only involve keeping them together when they are sick or in the ICUs. This has to be thought of even in the postnatal and KMC wards, and supported when they go home after discharge. The guiding principles, there will be some repetition, so I will just focus on few of them. Recognize the mother's role as a primary caregiver. That is key point. It is not only coming from the thought that mother is the primary caregiver. It does not mean that fathers, parents are not involved, but it is looking at it from the gender empowerment and female empowerment perspective also. And we are moving towards quality. One of the big aspects is respectful maternity care. So keep her in the center. The second, family-centered care has been promoted. Now, this is an opportunity to integrate it here. Third, I'll just like to focus on the two last points. It will require health system blending actions at all the levels. And I'll just share with you what are the actions that need to be taken at all the health system blocks. And last, KMC should be implemented at all the levels. One very important thought that came up was, it's not a low resource strategy as people used to think. They have been able to generate evidence that the effectiveness, the cost effectiveness of KMC and integrating maternal newborn units is much higher compared to isolating them. So even if you scale it up, the cost will be much less. Just to give you, because I have not put it here, but when I was hearing the last panel discussion, the cost that was estimated was, when the scaling up process took place, in Ethiopia it came out to be about 15 to 25% additional cost in an year. But the main cost was for repeated training. That was the main idea. In India, it came out to be about 10 to 15% in a year. The infrastructure cost we all people think that it's going to be a huge infrastructure cost. It was just about 2 to 5% of this. Of the total cost that we are saying, it was just 2 to 5%. Now, coming to the actions required at all the level. Yes, we need commitment, but this has to be supported by national implementation plans which are completely costed. And when you say costed, they should be thought of right at the beginning. Healthcare providers' capacity building has to be really emphasized. It's a paradigm shift for them. We have been asking them to keep mothers separate, newborns separate, and now we are asking them, forget about separating them, but you also need to make sure that the mother is a part of the process. The families are included. Don't just focus yourself at the facility. A efficient referral network is important. And then KMC indicators. I think a lot was said. What is measured is only, what is done needs to be measured. And then financing. The Every Newborn Action Plan describes the various levels at how KMC can take place. Starting from the community, first level facility, second level, and the referral. Along with it, in the implementation guidance, there are certain programmatic tools. I think as program managers, when we go and advocate, there should be a theory of change. What are we advocating for? How things can be done? So this entire theory of change is given in this implementation guidance. Along with it, the facility-based KMC indicators. Other indicators of KMC are being finalized, and we hope that by next year we will have a complete list of indicators for the entire continuum. One important change, the Every Newborn Action Plan, everyone knows the target 4 was focused predominantly on at least 80% districts need to have a level 2 care for small and sick newborns. Recent revisions have been that you have CPAP added to it. And of course, KMC was a part of it. So a lot of focus is gradually being given on it. Friends, apart from KMC, there's a huge change happening at the global level. Everyone is talking of how do we integrate maternal newborn health. Since 2019, 2014 ENAP came, 2015 EPMM came. Then these two movements joined together. And now we have a joint ENAP, EPMM, global and country coordination mechanisms. Some of you must have attended the International Conference on Maternal Newborn Health that was held in Cape Town in 2023. That was the first one. Every 2 years now we are going to have these conferences. Apart from it, a lot of work is being done on making sure that the country plans that are being developed are planned and developed jointly by the Maternal and Newborn Health Division together with all the partners. The funding mechanisms is being looked into as jointly. Monitoring frameworks, joint frameworks are coming. Some tools are coming up in a big way. That includes the MNH transition model. How do you support the countries if they want to go from higher mortality to lower, or from average mortality to still lower? So these models are looking into not only newborn separately or maternal separately, they are looking into it jointly, including stillbirths. For KMC specifically, there is we have an optimized implementation research model that is being worked on, and a KMC practice guide, which was, I think, brought out in 2003. It is being 20 years now, so it is being updated. So lastly, these are the various access materials, but before I end, I'd just like to say, for 45 years, we have been struggling. We have the evidence, we have the partners on board, we have the joint frameworks in place. Now is the chance to work together. There are certain things where evidence acted as a hindrance to the development, even though for all of For many of us, now we understand that it's probably just common sense, keeping mothers and newborns together. Okay, but now we have got the evidence also. So I would urge all of you, don't be champions within your own facilities, but be the champions for integrating maternal newborn healthcare, using KMC as a platform maybe, but take it to the next level. There are very few moments in the history where you get this wonderful opportunity, and the time is now. Thank you.
Thank you very much, Dr. Rajesh, for that very inspiring talk, taking KMC at the global level in relation to the current recommendations of WHO. We will proceed with the next session, but I think we will have some time later after all the speakers to have a few questions raised. So our next speaker is Dr. Susan Niermeyer, who is a professor emeritus of pediatrics at in the University of Colorado and Colorado School of Public Health, Center for Global Health. Susan focuses on the development of educational materials that prepare health workers to provide essential newborn care and care for small and sick newborns. To talk about essential newborn care plus kangaroo mother care, let us welcome Dr. Susan Niermeyer.
Thank you so much. Thank you all. I especially want to thank Dr. Vani and all of the organizers for a wonderful conference, and to the moderators for this session. So I want to give you a little preview of the soon-to-be released WHO Essential Newborn Care course and analyze a bit how the content of that new course, the second edition, will provide a foundation for kangaroo mother care. Second, I want to identify the unique benefits of KMC that transcend context and apply to both sophisticated medical systems and more resource-limited settings. So Dr. Khanna has given us a beautiful overview of some of the WHO recommendations. But recently, many of those recommendations, not just the low birth weight and preterm guidelines, have really focused on care of the newborn around birth, with a goal that it's not just survival, but we want these babies to thrive. We want them to receive nurturing care during their stay in the facility, not just at home. And we want to put kangaroo mother care at the very center of care provision. So to that end, WHO has issued or is issuing a revision of their Essential Newborn Care course. And that is based on content from the first edition. You see the green Essential Newborn Care book there that's familiar to you. But it's combined that content with the educational methodology of helping babies breathe and the companion programs of essential care for every baby and small babies. And in addition, there are approaches that are taken from the early essential newborn care that you have heard about previously, because that program really focuses on clinical pathways and on integrating quality improvement into early essential newborn care. WHO also has issued the framework for quality care that's become really an orienting model and emphasizes experience of care in addition to provision of care. So what do we mean by that? It's really effective communication with mothers and families, respectful care, emotional support. So these are new aspects that are emphasized in ENC, in addition to what we are accustomed to, the conventional medical interventions that we perform. So all of this now is in a new package in a very flexible format that's available in print materials, in digital materials, and online learning formats to really provide a variety of platforms for active learning in the facility. So this is the formula for survival, or the formula for high quality care, really, in any setting. And it says that survival is the product of medical science times educational efficiency times local implementation. So we really know what we need to be doing. We know the medical science. What's lacking is an efficient system to transfer that knowledge to healthcare workers. And then even more so, what is lacking is the local implementation, actually getting those healthcare workers to incorporate this new knowledge, these skills, into their everyday practice and care of babies in the facility. So if we focus on these last two elements with respect to kangaroo mother care, I think we have a unique opportunity to achieve some of the best quality survival that we can anywhere. So the new ENCC really is based on these two action plans, ENC1 and ENC2. And action plans are actually algorithms for clinical care in the facility. And these algorithms, as I've said, incorporate these factors of not only provision of care, but experience of care. And I want to show you how they really focus on elements that are central to kangaroo mother care. So ENC1 on the left begins with welcoming the mother to the healthcare facility, communicating with her about the plan for her baby that may include kangaroo mother care. On the left-hand side of the ENC1 action plan, you see routine care in the green zone there, which has essential, really life-saving steps, drying the baby thoroughly, delayed cord clamping, and immediate and continuous skin-to-skin care for the first hour after birth, which of course promotes early initiation of breastfeeding. So this is really a model for zero separation from the beginning. Babies are no longer moved to a warmer after birth for stabilization. They stay with their mother and receive all the procedures in contact with their mother's chest. So ENC2 continues on with the ongoing care after the first hour through the entire facility stay. So it really emphasizes at the very center of it, in that yellow zone, the practical skills that are needed to deliver KMC. So as we've heard, KMC is not just skin-to-skin contact. It's a very specific KMC position. It's really attention to thermal management, to specific ways to encourage feeding of breast milk and direct breastfeeding. And then it's also a key component of assessment through the hospital stay. So here we see assessment initially to classify the baby and make a plan of care, routine, intermediate, advanced. We see assessment every day to update that plan and keep that baby moving forward through the facility stay. And importantly, we see assessment before discharge, because discharge and ongoing care in the community is the final component of the KMC package. A final feature is on both of these action plans, we see three cross-cutting themes. We want to emphasize infection prevention, we want to emphasize respectful care, and collection and use of data. So a second big part of the ENCC second edition are a series of thematic modules. The first three of these cover those three cross-cutting themes that I just mentioned, and then 10 other thematic modules really focus quite strongly on the skills and knowledge that's needed to provide kangaroo mother care. So examination and assessment, breast milk feeding, and special care of the small newborn infant. The learning methods in ENC 1 and 2 are quite active. They involve explaining, demonstrating, practicing with simulation, and discussing issues. There are videos that are both videos of the simulator to show technique and global health media videos that are actual clinical situations. So babies with respiratory distress, grunting, difficult breathing, and also interactions of health workers with mothers to model that behavior and that experience of care. There are many group practice simulations and peer learning, and I want to emphasize that all of this occurs in the healthcare facility, not in this auditorium, not in a hotel, but actually in the facility where care is being provided. The assessment is formative in nature in this program, and this is a very competency-based educational curriculum. And after the workshops, there is continued low-dose, high-frequency practice with simulation practice cards. And this gives the healthcare workers an opportunity to work on their team functioning and to actually improve their skills after the workshop. The learning methods in the modules of the ENCC course are very similar. These are some pictures from our recent field test in Delhi, and some of you had an opportunity to participate in that. In addition to demonstration and practice and simulations, there are clinical practice cards. These can be used either as checklists for performance of skills, getting to that competency-based education, or they can be used as observation checklists of facility routines, what goes on normally in the facility. And then that provides a way to identify gaps in care, and then applying the POCI, the Point of Care Quality Improvement template, we can take those gaps, identify changes that we're going to make, and initiate those changes through quality improvement cycles. So in fact, the ENC2 action plan, every action step on the action plan can be turned into either a process or an outcome indicator for use in quality improvement. So you see the stars there, and those indicate process and outcome steps like temperature, like weight gain, and certainly discharge disposition, the outcome of the baby, and the follow-up that the baby received. So as Dr. Khanna mentioned, these are going to be some important outcome indicators that we can measure for KMC. Dr. McMillan introduced the Quality Improvement Integrated KMC program that we've been teaching the past 2 days in the workshops. And you've heard the overview of this, that it integrates both KMC skills and QI techniques. And really, this is a program that is aimed at implementation of KMC. So it also uses the educational methodologies that are very similar to what's in the Essential Newborn Care course, but ENC really teaches healthcare workers the skills directly. What QuickMIC does is teach healthcare workers how to help mothers learn, how to help mothers and families learn those skills, and then how to improve the processes in the healthcare facility. So one exercise is based on having healthcare workers help families learn Another set of exercises really looks at quality improvement techniques, how to identify gaps, prioritize changes, and then put them into a PDSA cycle to make change in the facility. So I want to end with just a few words and ask you to think about what are the unique benefits of kangaroo care that make it a model for care everywhere. You know, I come from a very privileged situation in the University of Colorado. I have a beautiful NICU. We have very low mortality rates. We can make babies grow. We really have very low infection rates in my unit. So we can achieve these things. But we're beginning to realize that our way of achieving those with incubators, with warmers, is really a very antiquated model of care. We are still putting babies in boxes. So that style of care is probably contributing to abnormal neurodevelopment. And that has really been highlighted with new evidence review that we're seeing neurologic dysmaturation and abnormal development of preterm infants in this conventional NICU environment. And this was a very high-profile evidence review, a lovely review article published by Terry Inder in the New England Journal of Medicine recently, and I would suggest all of you look at that. I also want you to really look at this mother on the left. Look at her face. Look at the fear, the anxiety, the stress, and look at her baby separated from any contact, from any interaction with his mother. And then look on the right at this baby in kangaroo mother care. So this baby has the touch and the smell and the sound and the sight and even the vestibular stimulation, the proprioception of being with mother, as well as that reciprocity, that engagement. And those are the factors that build the brain and that build emotional and neurodevelopmental health. And those are impossible to achieve without human contact with close family members. So we've heard from other speakers this morning about the benefits of KMC to infants, to mothers and families, to healthcare workers even. But I would argue that it's this, infant and behavioral mental health, that is the unique contribution of KMC that we cannot achieve any other way. And it's also, through KMC, a benefit that we can achieve in both high and low income settings for rich and poor. And so we can begin to equalize the inequities from the very beginning by using KMC. And this is not just in low resource settings. This is in my country, in the United States as well, that we need to equalize these inequities. So just a word about KMC and some of the emerging research around its benefits for neurobehavior and development. There is now evidence that early parental holding, and especially skin-to-skin holding, results in better neurobehavior at term and better gross and fine motor skills at 4 to 5 years. And we are also privileged to have Siren Vuratadal, who's going to speak next, who has just published a lovely article about the effect of immediate KMC, showing benefits to mother-infant interaction as early as 4 months. There are also emerging lines of evidence about infant behavioral and mental health. So vocalizations and conversational terms, sensory patterning in infants, movement and excitability, and even childhood and adolescent mental health and psychiatric disorders. There is a need for a lot more research in this area, and I would really challenge all of you in this auditorium that this is an area to focus on in your research, because this is what is going to drive implementation of KMC in both high and low and medium resource settings. So I want to leave you again with the idea that ENC plus KMC is a model for care everywhere, and I hope you will access some of these very practical tools. The new Essential Newborn Care Course, second edition, is going to be available from WHO in the first quarter of 2024. And right now, the interim version is available on this hmbs.org website. And you can access the Quick MIC tools on the Canadian Neonatal Foundation site or the International Pediatric Association website. Thank you so much.
Thank you very much, Dr. Susan Niermeyer. Taken into another level or a different perspective, we really appreciate the information you have provided us and the updates. We now have our third speaker for this session. Dr. Siren Rettedal is a professor of neonatology in Stavanger, Norway. She has had special interest in newborn resuscitation, neonatal sepsis, and immediate kangaroo mother care. Let us welcome Dr. Siren to talk about experiences regarding challenges with scale up from HIC setting after WHO recommendations. Thank you.
Thank you so much, and thank you to the organizers, and it's an absolute pleasure and privilege to be here. I've been so lucky to be, I think it's a lot of responsibility that is on us present here now. We have overwhelming evidence for KMC, and we have the responsibility and opportunity to act on this, both in Global South and in Global North. I was lucky to be part of the immediate KMC study that was conducted in Safdarjung in India and 4 African countries. And these results from this study was published in the landmark paper in New England Journal of Medicine. And only a year later came the WHO guidelines recommending immediate and continuous KMC for all low birth babies everywhere. And this was really interesting. I was so happy when I saw it. It was not only recommended in the low and middle resource setting, but also in our setting, in the high resource settings. I'm from Norway, and we have a very low neonatal mortality rate of 1.3 per 1,000. And for decades now, we've been doing intermittent skin-to-skin for preterm babies. Even if they were on ventilators or CPAP, they were very sick. However, immediate KMC was new also in our settings. And I thought maybe now when the WHO recommendation came, it would be easy to implement immediate KMC in our settings. However, this has not really been the case. It is difficult to change the way people work. And in parallel with this study in the low and middle resource settings, we did a study on immediate KMC also in our setting in Scandinavia. In 3 units in Sweden and Norway, we did immediate KMC study where we randomized babies for either standard care in the incubator or immediate skin-to-skin or KMC after birth for the first 6 hours only. It would not have been ethical possible to randomize for more than the first 6 hours, because it was so prevalent with intermittent KMC. So the standard care was incubator care for the first 6 hours. And then was the intervention group that was immediate KMC or immediate skin-to-skin after birth. We randomized babies between 28 weeks and 33 weeks, so they were about 1 to 2 kilos. And this is Thea. She's a girl born at 28 weeks and weighing 1,100 grams. And immediately after birth, she was put skin to skin with the mother. She was covered in plastic wrappings not to lose heat, and then covered with preheated blankets. And the care was the same. She received respiratory support with CPAP after birth. Fathers are present at birth in the delivery room to support mother and baby, and the monitoring is the same. So care is the same, it's just a different place. Instead of incubator, it's on the skin to skin with the mother or father. 40% of the babies that were born preterm in our setting, they were born by cesarean section. And in that case, the baby had to be put with the father skin to skin. And actually, when we summarized all our data, we found that in the intervention group, it was the fathers that did the most KMC. Of the 5.5 hours we managed to do skin to skin, fathers did 4 hours, mothers 1.5 hours. So it was fathers that provided most of the skin to skin care. Nurses and, if needed, doctors were present when the baby was born in the delivery room and supported the care. And we tried to keep the mother and the baby together for at least the first 2 hours if the baby was born vaginally. And then we moved the baby, and here the baby is receiving expressed breast milk within the first hour after birth. And we did procedures skin to skin, like putting in peripheral cannulas. When the baby had to be moved to the neonatal intensive care unit, we did this usually on the father, either in a wheelchair or on a bed, or in some cases, if the baby was very stable, they walked with the baby attached in skin to skin. And we did it for twins, and many of these babies born preterm in our settings were twins. And when the mother was well enough to join us in the NICU, she came and provided skin to skin. And to us, it's been very difficult to convince people to change the way of behaving. And first they said this is not proven to be safe in our settings. In the KMC study, you showed that it was safe in low and middle resource settings, but we have different equipment, we have different staffing, one-to-one. Is it still safe in our setting? So this was the first task, to show that they're equally or more cardiorespiratory stable when they're in skin-to-skin position. And also to show, oh, there's something wrong with the photos, also to show that they are equally stable when it comes to thermoregulation, or more stable. There's less hyperthermia events. But I think the most important study was the one published yesterday in the JAMA Network Open, that showed at 4 months, these babies, they have improved maternal neonatal interaction. Their social and communication skills are better. So it goes to show that the neurodevelopmental outcomes are better at 4 months. And this is, I think this is mind-blowing, because we talk about 6 hours immediately after birth making a difference at 4 months. So we know this from animal studies, that we have this window after birth that is really important for the mother and outcome to stay together. And this is the same we're finding in babies. So I think maybe this is what is going to convince our colleagues that to change their way of doing maternal neonatal care. We have more studies coming. We are looking at a still phase paradigm at 4 months. We're following them up to 24 months also with Bailey's and neurodevelopmental tests. And my colleague, Carolina, that is here in the audience, she's doing a PhD looking at sleep patterns and EEG, whether they are better when they're skin to skin the first 6 hours. So I think our message is that it's the best care for every baby everywhere in the world. And this is, thank you very much.
Thank you very much. Very, very inspiring indeed. So I'll now turn over to my colleague, Dr. Ruchi, to introduce our next three speakers.
Thank you very much. We really had wonderful talks and a lot of insight into thinking and what should be our way forward. Now, to go ahead with this session, we have, whenever we talk of immediate KMC in India, we think of Dr. Harish Chelani. And he's here today to talk about enablers of immediate KMC in India. He's known to all of us, everyone in India. He's ex-HOD neonatology at Safdarjung Hospital, principal investigator in the most prestigious study of immediate KMC, now technical expert to WHO, and he has, of course, several publications, award to his credit, and we are happy to, have you here, Dr. Harish. Please carry.
Thank you, Chairpersons, and thanks to Dr. Shashivani ma'am and her team for giving the opportunity to speak to you. And what I'm going to discuss the enablers, what we learned while doing the trial, as well as after the trial, we are still continuing. So these enablers, which I'm going to talk about that. And thanks to Dr. Rajesh Khanna, and he has enabled many of my enablers, which I'm going to discuss. Those are some of the things which he has already covered. So maybe some of the slides you will find there. We all are aware that most of the deaths among these neonates are preventable, and we do have now strong interventions for the care of the small and sick babies, including antenatal corticosteroid and CPAP, and we should take them as a whole, as a package, which we had been listening from each speaker since morning. The status of the KMC, if we see the data, as Dr. Shobna also mentioned in the presentation, global coverage is around 5 to 10%. And if we see, we have got in India around 900 or 950 SNCUs, but KMC ward is available only in 350 or so. And we do have the targets for the KMC, but these targets which were there, they were for the stable KMC when they were made actually. That by 2025 we should have the 75% coverage of the KMC. Of course, at that time the duration was not mentioned. If we see in our HMIS indicators, it is yes or no. So even if someone has taken the KMC for 10-15 minutes, or even the skin-to-skin contact, as Dr. Shobna was saying, that's why in some of the presentations you will find 70%, 80% KMC. That's really not the KMC which we are now, talking about. When I looked up the literature of the barriers and the enablers, of course, we had this systematic review of the KMC. Of course, those are the stable KMC, and most of the studies in this systematic review were from 2010 to 2015. And what we found that if there is a strong support from the family members and strong conviction from the healthcare provider, only then it is possible to have the exact or the KMC duration and for longer period. This slide, we already know it, but what I want to focus on this, that the coverage we know it's less, but now we also know the ways to improve this coverage. We also know that the KMC can be initiated at the community level. What are the barriers and enablers at the community through this trial? If you read this paper, we also have what are the enablers at the community level about the KMC. We also now know that immediate kangaroo mother care reduces the mortality by 25%. But for the people who are the young colleagues sitting in this hall, I'll briefly touch upon what is immediate kangaroo mother care, and then we'll come to the enablers. Immediate kangaroo mother care is initiating continuous KMC as soon as possible at the birthing place, within 2 hours of the birth. That was also the inclusion criteria in the trial, aiming for 20 hours, but it can be given even longer. Also, because these babies are small babies, so support for the expression of the breast milk and breast milk feeding. And since for this, the mother is together with the baby, so the provision of the postnatal care. I'm discussing all these because I'll connect later on the enablers which are going to be working on that. So to happen this all, starting KMC at birth, whether in the labor room or in the operation theatre, transporting in the KMC position, bringing it in the unit where mother can provide the KMC for 20 hours or so, you need to operationalize and improve your processes. So you have to develop the mother newborn care unit, where you have to bring the mother's bed inside. If you have a space, develop the new structure. Otherwise, in the existing unit also, you can bring the bed of the mother if it is possible. But simultaneously, you must have a provision to start the KMC right at the birthing place in the labor room. So you must know what are the things which are required, what is the collaboration, because labor room and operation theatres, they are in the domain of the obstetric colleagues and the nursing colleagues. So that collaboration or enabling environment is required from there itself. Simultaneously, the essential care package which is required for the care of these babies, like provision of the CPAP or the resuscitation, all these processes and the training of the doctors, they required to be there. So this is the picture of you can appreciate the mother in NICU which we paid. There is a radiant warmer with each bed of the mom, and there is a nursing station. So these beds are around the nursing station. So there is a privacy also. You can put the curtains, and during the time of observation, these curtains can be removed, and each cubicle looks like that. So there is a provision of the mother's bed, the CPAP. So this environment is of level 2 care, right? And those babies who require the level 3 care would be shifted to the tertiary care unit. Since mom is there with the baby, so naturally you require the support services, also bathing area, the washroom, and the examination room for the obstetrician, sometimes for the stitch removal or other infection. So monitoring or even the bleeding or sometimes. So you do require the mother's examinations. When we created this mother newborn unit, it definitely provided the opportunities for prolonged and effective. Otherwise, when we see that mother, after the baby shifts it to the newborn unit, mother is either discharged in the private sector or in the government system, you will find she stays in the postnatal ward. And average time which we quantified, it is 3.8 hours on an average. And KMC duration is just 1.7 hours. With the presence of mother, you can see the duration of the KMC is improved, breastfeeding rates are improved. And when we talk about family-centered care, what is family-centered care or developmentally supportive care? The presence of the mother with the baby. When we are saying from the postnatal ward, she should come more frequently, at least let us provide this support 24/7. So the places where you can't create, I think that is the best way to improve the frequency and the duration of mother being into the NICU. That's the family-centered care. And of course, we have quantified the stress, as Dr. Nalini was also saying, we have quantified through the salivary cortisol level of both the mother and baby. The anxiety and the stress is much, much less. And these results we all know, that there is 25% less deaths in the intervention group as compared to the control. The point which I want to highlight here is that infection rate is 18% less in the intervention group. The fear which all the healthcare provider and the program managers they have. And I remember when we inaugurated this, even one of the mission director, he said, are you making it a general ward? You are going to increase the infection. And I think that's a strong advocacy message through this result which should go, that there is rather infection rate goes down and sepsis related mortality also goes down, which we published in the Lancet recently. Now what are the enablers? When I was looking into the whole perspective, we do have the Lakshya program where the companion is there in the labor room, but still the reach is not to that extent which we are expecting. And one of the enabler for the immediate kangaroo mother care is only if you allow the companion. The way our delivery tables are there right now in the public health system, they are more comfortable for the obstetrician than for the mom. At that time, who is there to hold the baby? Everybody says that skin to skin care is not happening. Why it is not happening? Nobody is supporting at that time. 2 or 3 nurses busy with so many deliveries. Who will hold the baby onto mom's chest? At that time she is exhausted, she may be drowsy at that time, post-delivery. Somebody has to be there. Then of course the mother newborn care unit, that friendly environment has to be there. Ensuring enough supply of the garment. When you are doing for the immediate KMC, these are the sicker babies. Believe me, I recently went to the district hospitals and the mom is keeping the baby onto her and she is stressful. There is no proper binder. She is worried the baby may fall on either side. So unless you provide a proper binder, mother will not be comfortable. Mother should be able to walk. We don't want the deep vein thrombosis and venous stasis to happen. So all these things are equally important, proper binder, and of course, she can't provide the KMC for all the time. They must be allowed the surrogate also in these MNCUs, family member of the choice of the mom. So KMC chair along with the bed. And another enabler which we have found in these, that peer group learning. The mother who has been there for a longer period, she infects, goes through to other mothers and enables the processes and these things. Then Rajesh also mentioned about the trained healthcare professional. And we heard yesterday from Dr. Shashivani also, for immediate kangaroo mother care, we need the same kind of monitoring. It's not that monitoring is not required. So we need the professional people, adequate training so that they can handle these babies in KMC position. And of course the role of the professional bodies. You can't unless you convince the professional bodies. And I here feel the Indian Academy of Pediatrics, National Neonatology Forum and FOXI, I think they should form a consortium to go for a common message. It's not that separate messages are given and separate movements are happening in these organizations. So training is very much required how to initiate the KMC in the delivery room and transporting, because initial few hours obstetricians, they do feel they require, the mothers, they are to be in the delivery room or in the OT. So we require the support of the surrogate for initial few hours, 2 or 3 hours, by the time when the mother is available. And how to put the CPAP in the labor room, in the KMC position. That's an art. We also had a lot of apprehension, and thanks to the KI team, at that time during the trial helped us. And then we are, able to now continue it. And enough supply of the binders. So that is very important, and adequate supply of even the availability of the pulse oximeter. So this is the garment which I wanted to show you. So inner binder and outer cover, which provides the privacy as well as it supports the baby from below, falling. Those, because now this is available in GEM. So those who are in the government sector, they can easily purchase because rates are now fixed. So both the KMC chair and the KMC government is available in the e-government system procurement. So one can go for the purchase of these garments if one wants to have, otherwise they can use the one which they are already using it. Very important, collaboration and couplet care. Unless we involve the obstetrician right from the beginning, from the labor room, that's the area, and then they have to come from their own department to the, the NICUs to take the rounds of these postnatal mothers. Similarly, our newborn colleagues, they should not feel that they have to confine themselves only to the newborn care unit or to the postnatal ward. They have to move themselves to the labor room. That's how, unless we cross the boundaries, we are not going to have the proper collaboration and activity. Dissemination is another advocacy, equally important amongst the professional organization, partner agencies, and the advocacy should start from your own home, from your own hospital. Residents keep changing. I think it's important to train them, only then we are able to. And thanks now, as Dr. Shobna mentioned, it is there in the now national guidelines. Once it is there in the national guidelines, it will be easy for the states to go for in the PIP plan, go for the CPAP procurements and the KMC governments. That is going to help. Private sector, very important, 60% right now care is with the private sector. The challenge is how to cost the bed of the mother in the insurance system. And this is an example which I am showing you, Amrita Institute of Medical Sciences in Faridabad. Recently they have started this MNCU concept. And they have added 2,000 rupees in the cost of the package of the care. And I am requesting Madam, and because Dr. Paul will be here, we already have in the Ayushman Bharat this package, and thanks to Dr. Paul, he has already given a lot of public-private partnership packages in this. With new evidence now, the cost of the mother's bed also should be included. So I think we must make a plea when he is inaugurating this, and that would be useful for the private sector to go for. And otherwise nowadays what happens? Mother is discharged. And then at the time of the discharge of the baby, we tell that, okay, give breast milk, do KMC. It's not an on-off switch to do it when 10-15 days the process has not been initiated. So now I think this last but one slide. How to overcome these challenges? We must have the LDR units where you new design, Lakshya program, allow the companion in the delivery area or in the MNCU. Redesign your structure if the space is there in the existing NICU. Otherwise, if extra space is there, I think you must create the new MNCU. Ensuring KMC government and collaboration with the obstetric nursing colleagues right from the beginning. That's the key to happen. And of course, the support you will automatically get from the peer group. So now translating science into reality, I was thinking that let us put zero separation and position MNCU in the center of the care. And that would be the entry point for the nurturing care what we are looking for. That will promote the KMC duration, breast milk, developmentally supportive care. That is going to be the entry point of this, and we need to change the policy, allowing the companion in this, and more importantly, I feel the mindset of all our healthcare facilitators. Thank you, Dr. Nalini. Thank you very much.
Thank you, Dr. Chelani, for a very clear and lucid presentation. Thank you very much. I think we'll be taking questions at the end of the session. So now the next talk in this session is on a very important topic, and that is KMC implementation research. And to deliver this topic, we have Dr. Suman Rao. And I have a pleasure in introducing her because I know her for last 25 years as a DM student from our institution, and where she has reached today, participating in various studies at the international level and working for WHO. Suman, all of us are very proud of you, and I welcome you to deliver today's talk. Thank you.
Thank you. Thank you very much, ma'am. It's always such an honor to present in front of my teachers, both Dr. Rekha Udani and you. And it's really my pleasure to be here. And I thank the organizers for this. And it's the KMC, like we used to call IKMC family. The KMC family is also so close. It's a pleasure to meet all our friends, international friends here. So welcome to India. So I'll be talking for the next 15 minutes on kangaroo mother care implementation research. And this is something you have been seeing, that yes, small babies are only around 15% of the total births, but they contribute to 70 to 80% of all neonatal deaths. You keep hearing this because this is the starting point. And we know this. And as Dr. Khanna and everyone has been reiterating, we know this for 45 years. And we go back to 2015 because that is where things started changing. We had three things which you will have seen. Global coverage was low, and one of the main reasons was that it was initiated only in hospitals. Though many of us, including Dr. Shashivani, have been initiating in the community, but we did not have any evidence, and KMC was only for stable babies. This was where we started, and therefore a huge implementation gap. There was also an evidence gap. And the big change is to this one gentleman who probably has done the most for generating evidence for kangaroo mother care. And we are honored now to have him as the Director General of Indian Council of Medical Research, Dr. Rajiv Behel. I know Dr. Vani has been trying to get him for the KMC conference, but Dr. Behel is always the doer, and these conferences, he says, others can take it forward. And these were the three big research that he initiated. And I call that as the trilogy, the bestsellers of kangaroo mother care, because it has changed practice. That was the scale-up kangaroo mother care study, which I'm going to talk in detail now. The community kangaroo mother care, which has changed the evidence and brought out new guidelines. And of course, I would say the bestseller because it created a lot of news in the international network, that is the immediate KMC. Back in 2015, we didn't even know what was the KMC coverage. Because as you all keep reiterating, any skin-to-skin was considered KMC, and the reporting was all over the place. And therefore, we started with the thing that, yes, probably the coverage is only less than 5%. And to build this gap of implementation, we had to look at implementation research. Way back then, implementation research as a science was also very nascent. And we, I would say, have grown along this past 15 years in implementation research science. And when we came up with this, the question here was not, what is the impact? It is the big question of how we do it. And in fact, in the protocol development workshop, the big debate was what should be our outcome? And the outcome here is to create a model of how we can rapidly scale up. And the scale up was a whopping big long jump from less than 5%. And the goal which the WHO set for us was a huge 80%, not in your facility, not in a group of hospitals, but in an entire district. Every baby born in a geographic area have to get kangaroo mother care. That was the big challenge. And on top of that, it was not only about skin to skin, any skin to skin. They said we have to achieve quality care, and that was where the effective KMC came up. KMC was considered to be done only if it was more than 8 hours per day, along with exclusive breastfeeding. All of us, the researchers in the hall, thought it was impossible. And we tried to haggle for an outcome of 2 hours, 4 hours, but it was very evident that no, this is aspirational. Don't worry about where you will land. Work towards it was what was the direction. This was done in 7 sites, 4 in Ethiopia and 3 in India. In India, it was in Haryana, led by Sharmila. In UP, by Dr. Vishwajit Kumar, whom many of you all have seen. And in Karnataka, in the Koppal district, Dr. Premoni and I were the investigators. And we here, along with other partners, including the KHPT team, but the main partner here is the government. Implementation research is research, but the driver's seat is with the government. And that is a message that we have received consistently, and that is a message we take forward, that implementation research is to be done by the government, by the Ministry of Health, by the people in the facilities. The research team is there only to help. And their role is important, yes, because they do the formative research, they provide implementation support, they collect the data, but everything feeds back into the implementers, and that are people on the ground in the community, and that's very important. And therefore, it was important to have the government in all the research meetings. Even today, when we present implementation research to ICMR, unless there is a government partner, there's no entry for any research proposal. And this was the model that we started with. We said, let's start with the current government policy, do formative research to understand why the challenge. Because in India, it was one of the countries which had a policy. And many of us in the team have been part of developing this implementation guideline. But still, the take-up was so low. And then develop a model and keep on working towards the goal of our 80% coverage. Change the model as you need, but your goal is to reach 80%. And that was where we were. We had to work in 90 facilities. Quite a whopping challenge. Initially, it was discussed that we would have KMC implementing maybe 2 or 3 in the district. But in Koppal district, this did not work because people were not ready to send the small, stable baby to a SNCO or a district hospital. They wanted to manage at the PHC level. The families were not ready. So we said, yes, let us give KMC wherever it is possible. And we created many KMC implementing facilities. So facility mapping was the first step. The next step was formative research. And formative research opened our eyes. We found that there were a lot of barriers. And the first one was an identification of the low birth weight. We'll talk about it. But the biggest barriers has been, unfortunately, the healthcare providers. More the doctors than the nurses. But it is the doctors and nurses who have been the biggest challenge. Community implementers, not so, and family, where people kept talking about maybe a family, a culture will not accept that, maybe this religious group will not accept that. That was not at all there. The family embraced KMC, and this is our biggest challenge that we had to work on. And throughout the system, it was quite challenging. The first year when we were developing the model, I remember so many times going to Koppal. We used to visit Koppal all the time, and coming back very dejected because we found that we were not moving the needle. And that was mainly with the healthcare workers. But coming to the first point, which we could address very easily, we found that low birth weight babies, identification was a problem. In fact, 25% of the normal weight babies were actually low birth weight. And there was a lot of rounding and heaping. If you see 2.5, 2.5, 2.5, you can be sure 2/3 of them are actually low birth weight. And by the facility, they identified only 18% as low birth weight. But when we went there as a research group, we found 35% low birth weight. So that was the beginning. But we could change this very easily because a simple thing of replacing all weighing machines by a digital weighing machine changed it. And this was an easy barrier or thing to overcome. But our biggest barrier, as I said, was healthcare workers. We worked pre-facility because we had to get the babies to the facility to do kangaroo mother care. Community-initiated KMC was still not the norm then. Our biggest work was in the facility. We also had to continue kangaroo mother care in the community once they were discharged. So post-facility work then moved over to all the 4 taluks of Koppal, and I'm presenting only the Koppal part here mainly, but the story was the same everywhere. And over a period of a year, we did develop a model. At that time, we had not yet reached 80%. We were still struggling at 10, 15, 20%. But you know all these research projects are time-bound, so we had no other go but to enter into the evaluation phase of the study. And we did a lot of each model. What was important is, please remember in implementation research, it's not only about what you achieve, it's also about how you record and document what you did. So there was a lot of this where we had to not only record what worked, but also record what did not work. So as I said, though we started off planning on establishing kangaroo mother care wards only in the bigger hospitals, we had to do it even in primary healthcare centers because babies were not ready or the families were not ready to move. And you see here, this was particularly from our site, we found that we had to establish many KMC wards in the district. Anywhere there was a baby who was not ready to move, we were ready to give KMC there. The biggest challenge, as I said, was the healthcare workers. So we worked around this mentoring concept, and we have Marianne here, who is the biggest leader of training for mentoring nurse mentors. And we, as doctors from medical college, served as specialist mentors to sort of impress upon the healthcare workers in the facility. It was a challenge. Training was easy. We all are, many of us are in the medical school, so training is not a problem. We did all that very well. We also helped them skills, but the challenge was making sure that KMC is not a standalone intervention. We had to embed it as part of small and sick newborn care. So we made sure that when we talked about KMC and we went there to mentor, it was the entire newborn care and not just kangaroo mother care that we focused on. So we trained them in resuscitation and other care of the small and sick baby. We did a lot of CME. We tried to influence the doctors there by getting their teachers to make a difference. But we still found a challenge. We did a lot of things in trying to see how we can bring about the behavior change. We identified and recognized them as KMC champions. We used the quality improvement principles, yet it was still a challenge. This was one success story where the referral linkage between the primary care and the district hospitals worked well, thanks to WhatsApp group, and we saw a lot of vibrant activity happening here. We realized that to make a difference, counseling is the biggest thing that we need to do. So we worked a lot on counseling and training of counselors, and empowerment of the family is very, very important. We use the ACCA model where one KMC provider would influence others, and it was all based on the human-centric design. You will see many such pictures because KMC is such a do-good thing. You feel good about it, family feels good about it, and everybody embraces KMC, right from the people who live in the tents to all other family members. Community facility linkage was a big challenge. babies would get discharged and we would lose track of them, so we had to ensure that community facility linkages were well established, and we had to train ASHAs to try to visit them as soon as possible. If the ASHAs could visit them immediately the second day after discharge, KMC would be much better. So we did all this, but one of the biggest things which moved the bar was celebrations of kangaroo mother care. We had triplets, 3 girl triplets after 1 girl child, and the family was not ready to take care of them. And these 3 triplets were taken care in kangaroo mother care in Koppal District Hospital, and that became a big story in WHO. When there was international focus, there was national and district level focus. District hospital the doctors were now happy to see that their hospital was in focus, and that made a big difference. So it's very, very important to make news and celebrate. And that was a big game changer for us, where we saw that our KMC coverage definitely improved. And for the next 5 years, Koppal district was celebrating the birthday of these 3 girls. Community mobilization is very important, and we used all opportunities, including the local jatras and all, to promote kangaroo mother care. But one key thing, as they say, evaluation is king. Unless it is there in your review meetings, unless you highlight what is the coverage, it's not going to fly. And that's what we did. We provided the data to the district program officers, and they would discuss it in their monthly meetings. Yes, as I said, not everything worked. We thought we would use the village health sanitation committees to promote. It didn't work, so we gave up. We realized that specialist mentoring visit, just going once in 2 months was not enough, so we changed it. So there was a lot of adopt, abandon. And finally, when we concluded the evaluation and we published this in BMJ Global Health, we saw the story was similar across all the 7 sites. We managed to get that big long jump and initiate KMC in more than 80% of the population in 4 waridas in Ethiopia and 3 districts in India. Exclusive breastfeeding rates was also very high. Effective kangaroo mother care, that is more than 8 hours per day, and exclusive breastfeeding was not 80%, but it was close there. And we were really very, very happy about it. And the hours of skin-to-skin contact was anywhere between 11 to 14 hours in Ethiopian sites, little longer there as compared to the Indian sites. So this implementation research is probably like a case study for implementation research, which is now being used to understand how to make the big leap in high impactful interventions, whether it's antenatal corticosteroids or whether it's kangaroo mother care. And this is what is going to help policymakers, the implementers, to take these life-saving interventions to scale. And this is the basis, this kangaroo mother care WHO study is the basis for the implementation strategy document which has come out last year. And here we look at not only about what we should do at the facility, but what at the leadership and the governance, the policies, the health financing, we need to look at it. And as we said, there's a lot of work in the WHO about getting KMC as an ENAP indicator. It should be out because the groundwork is all done. And here it's going to be proportion of low birth weight babies initiated in kangaroo mother care, which is going to be a reportable indicator, and that is going to again help all governments to make the big leap. And then we had this landmark study. Now the big thing is we now know that we should not wait for 45 years to make the change. And therefore, immediately after this study has been published, WHO has changed the guideline within a year. And you see that guideline there, which is so important, which we are discussing in detail. But in addition to it, WHO has embarked on an implementation research. Just because there's a guideline on immediate KMC doesn't mean it's going to be scaled up. There's a lot of challenges. And therefore, this implementation research, which is now being done in 4 countries, in 6 sites, will give us a model which will help us to scale up immediate KMC. And not only that, in this implementation research, there's also an effectiveness kind of study involved. There's a cluster randomized control trial, which will look at the impact of the scalable model on neonatal mortality. So this has just started. We are in the formative research phase, and I'm sure over the next 2 meetings, we will be able to give you more information on this. We now know much more about implementation research, so we have now put the immediate KMC implementation research in a proper consolidated framework, and we are looking at it much more scientifically than when we did the scale-up KMC study. So in WHO, kangaroo mother care has been a sort of leader on how to transform small and sick newborn care. It started with the gap identification, where we found 3 gaps, and then these 3 research projects have bridged those evidence gaps, and then we have the new guidelines, and then now it's about the stage which has used KMC as the tool. This is the last slide. Implementation research on immediate KMC, dissemination and policy dialogue, monitoring, and this may again give us more gaps for us to work on. So this has been like a transformation of newborn care, and implementation research is leading this. Thank you very much. I leave you with the photo of the 3 triplets who are now, of course, more grown up. Thank you.
Thank you, Suman, for a wonderful presentation and telling us what the reality is, and also telling us where to focus, when to focus, how to focus, and what is our way forward. Thank you very much. With this, we go to the last presentation in this group, and this is on sustaining KMC through research, recent evidences from the Philippines. And to talk on this, we have Dr. Maria Esterlita from Philippines. And as you can see here, she's got a lot of experience. She is the president of Philippine Society of Newborn Medicine. She's a vice president of Kangaroo Mother Care Foundation of the same country. She's director and research professor of Institution of Child Health, vice chair for the research and publication of Department of Pediatrics, Philippine General Hospital. She's assistant division chief of Philippine General Hospital, and of course, NICU head. So I think you are the right person to address this issue, and I welcome to deliver your talk. Thank you.
Hi, good afternoon or good morning, everybody. I'm Dr. Tita Uy from the Philippines. We'll talk about KMC research updates from the Philippines. As we all know, KMC started in Dr. Fabella Memorial Hospital under the leadership of Dr. Suki Mendoza. And from the data they gathered, they were able to show that there was decreased mortality and sepsis, decreased hospital stay and hospital costs through their KMC program implementation. But these were just published in their local hospital journal. So that realizing that results should be disseminated more and that more KMC research should be done, in 2010, KMC Foundation Philippines, again under Dr. Suki Mendoza, provided small research grants to pediatric residents, neonatology fellows, and even consultants. So that in the Philippines, neonatology fellowship programs require a prospective research output from their fellows to be able to graduate. And so the first neonatology fellows who applied for the research grant and were the first recipients were from the Philippine General Hospital where I came from. And the initial KMC studies in the Philippines were mostly randomized controlled trials on the benefits of KMC, again solidifying the evidence that showed benefits in weight gain, showing that intermittent versus continuous KMC had the same benefits on weight gain. There was significant prolactin and breast milk letdown in the first 3 and 5 days for those mothers on KMC. And there was also decreased maternal anxiety and depression scores found postpartum among the mothers. Because we had initially a young program, we had an implementation assessment of the KMC program at PGH, and what we noted was that there was fair acceptance of the healthcare providers despite having good knowledge about KMC. What's unique about what happened in the implementation of KMC in our hospital was that because the residents, the fellows were doing randomized controlled trials in the NICU, subsequently the nurses who were really resistant started seeing the benefits of KMC, started getting used to seeing mothers on providing intermittent KMC. And it was the research actually helped with the acceptance of the nurses with regards KMC because they became more familiar with the program. Subsequently, the fellows and other residents from different hospitals started doing KMC research, and they were doing systematic reviews, updating systematic reviews, and solidifying the evidence with regard to significant increase in weight gain, length gain, head circumference gain, decreased nosocomial infection, and what's important is a higher exclusive breastfeeding of at least 6 months, which is one of the targets, the UN targets for infants also, and of course, decrease in mortality and decrease in hospital stay. Subsequently, the question became, is there a role for KMC among medically unstable preterm infants? We had sessions on KMC transport, and one of the first studies in the Philippines was facility-based KMC transport. We have the delivery room on the first floor in our hospital, and if the baby needs to be admitted to the NICU, it's 4 floors above. So we randomized them to either transport incubator or KMC, and what we found was the physiologic parameters were the same. In another hospital in northern Luzon, they did inter-hospital transfer as far as 40 kilometers from the facility to the tertiary hospital, and what they found was no babies on KMC develop hypothermia, but 50% of the babies swaddled in an open crib, transferred in an ambulance, develop hypothermia. So this translated to a relative risk of 0.0625, or a 94% reduction in the risk of hypothermia if the baby is transferred by KMC. Another study in our hospital is randomizing infants on nasal cannula to either KMC or inside the incubator. So what was found was that the duration of nasal CPAP among those on KMC was more than 50% shorter than if the baby is in the incubator. And the duration of oxygen support, again, was more than 50% shorter if the babies are on KMC position compared to incubator, showing us that babies in respiratory distress, actually the distress resolves faster or earlier when they are on KMC position. Furthermore, the question was about KMC among intubated low birth weight infants. Again, in the hospital, a randomized controlled trial was done. Intubated infants were randomized in KMC position for at least 6 hours per day for 5 days, compared to those inside the incubator. As you can see, I'll just share the primary objectives. 87.5% of the babies in the incubator had a hypothermic episode, compared to only 18.7% among those on kangaroo mother care. Furthermore, what about the number of deaths? 56% of the babies in the incubator died, compared to only 12.5% in the kangaroo mother care position. Because of this result, the university's ethical review board actually advised us to stop already recruitment, because there's already significant benefits that further recruitment will already be unethical. Because of these past studies that I have shared with you, we embarked in the KMC bibliometric study in not only in the Philippines, but also in Southeast Asian countries, to see the research outputs of the different countries. And the search was from 1996 to 2022, which yielded 815 articles, but we only had 50 articles eligible for analysis. As you can see here, most or more than 50% of the research publication on KMC topic were in the past 5 years only. And the Philippines had the highest publication per country, followed by Indonesia, followed by Singapore, thank you, followed by Vietnam, and then Thailand and Malaysia. But as you can see here, most of the publications were in the Acta Medica Filipina, which is a Scopus Index medical journal in the Philippines. And we would like to thank the KMC Foundation Philippines for sponsoring the issue, for collating all the KMC manuscripts to be peer-reviewed in that journal. The other journals were Journal of Neonatal Nursing, Acta Medica, BMC, and BMJ. So these are the types of study design that were used. Most still do randomized controlled trials, but there's some would do cross-sectional studies, and we have like 16% already undergoing qualitative research. And the topics were mostly still about effectiveness of KMC. 1/4 is about the implementation. Some would still be about knowledge, attitude of practices of the mothers and the healthcare providers, and some would associate KMC with success in breastfeeding. And most of the target population would be the KMC recipients, the preterm infants, the mothers, family, and father, but also the KMC providers, which should be the healthcare provider and the administrator. So I would like to share with you the usage metrics of the KMC research in Southeast Asian countries. As you can see on the farthest left would be the number of citations. So despite the 50 articles, in the past 25 years, the citations were still very low, around 15, an average of 15 to 20 citations per article. With regards views, that means the reader check the abstract and then click on the full text. As you can see, it's still around 200 to 250 in each country. Usage means who actually read the full text. Most would be in the Singapore study. And capture means they saw the abstract and then just click it, bookmarked it, saying that there's an interest to check on it. And as you can see, the highest would be the yellow bars, which would be in Singapore. So what does this mean? If you look at the violet ones, that would be from the Philippines, I think that is relatively high because we had the highest publication. But look at the Singapore, the yellow bar, they only have four articles. But these were our studies which are multi-country and were published in high impact factor journals. So as you can see, even with just 4 articles, they were able to reach a lot of stakeholders. And then look at the farthest right. With regards to our presence in the social media, it's still low. So I think we have to work on laymanizing our results to be able to reach more stakeholders. So in summary, KMC research in the Philippines were mostly done by residents and fellows in training. Majority were still effectiveness studies, and I think there is a need for multi-center cohort studies which should be led by consultants. Implementation research should be done because we already have more than 100 hospitals with KMC training. As you can see, with regards the simple implementation research at our hospital, the acceptance is low, so probably we'll be able to go back there and see if it has already improved. I also want to do some translational research on how to place all these studies into policy and most especially into practice. I shared with you the KMC transport, nasal CPAP, and intubated babies studies, but still they are not being practiced. They know that there's a benefit, but there still has not been translated into practice. What about the KMC bibliometrics in Southeast Asian countries? Our research output is low compared to India and compared to China, and there's a need to increase usage metrics to be able to reach more stakeholders by undergoing or conducting multi-country collaboration, as well as publishing in Scopus Index journals. So my recommendation for the Philippines and Southeast Asian countries with regard to sustaining KMC through research is to increase research publications in these countries engage in collaborative multi-center, multi-country studies, aim for journals with high impact factor, and use social media to promote KMC research results in layman terms. So I was inspired by the father of the Indian nation that probably to be able to pursue this, we should be ourselves the change that we wish to see in the world. So Dhanyavad, thank you, and salamat from the Philippines.
Thank you, Maria, for a wonderful presentation and telling us how to sustain KMC through research and the importance of usage metrics. Really enjoyed your lecture. Thank you very much. I think with this, we come to the end of this session. And I would like to check with the organizers, do we have some time for questions? Because I think audience must be, interested in asking the faculty lots of questions. So Dr. Nitin, do we have time?
Yes, ma'am. Yes,
Yeah.
yes. We can have one of the questions.
So can we have the first question first? Please go ahead. A microphone, please, for... I hope she can have a microphone.
Do you keep patients till discharge in MNC unit? After commencing IKMC, once they become stable, do they go to the postnatal ward or they discharge home from MNC?
In fact, the same thing which we are doing, once the baby is stable, they are going to the KMC ward or the postnatal ward. Currently, we do not have the system of giving the tube feeding in the KMC ward. So moment they reach to the cup feeding, they go there. But I ideally feel that because in the states or district level, we do have the nursing people at the KMC ward. So even the babies who are off the IV fluids or respiratory support on the tube feeding, they can be easily shifted. So we are still fighting on having the support of the nursing people. They go from the nursery once or twice in a shift to see those babies. So, yeah.
Dr. Chilani, just one question to you. That of course yours is a very busy unit. So are you able to provide immediate KMC to all those who deserve, and what do you do in the remaining cases?
I think excellent question. We have currently only 12-bedded unit. So after the trial results were there, so first is this baby will go to the MNICU. And once all these 12 beds are full, then only they will go to the, the conventional care. But fortunately, recently, Dr. Rajiv Behel inaugurated 15-bedded outborn unit where we keep the mother and baby together. So even tertiary level care, non-invasive ventilation is with the mother. And this is the model which we are doing it for small and sick babies. So even a bigger baby, more than 2.5 kg, who is sick, is with the mother. This is for the outborn babies. Yeah.
Thank you, Dr. Chilani. Any more questions? Yeah, Deepa.
Thank you, sir. Wonderful presentation. My question is, what is father's role? Should it be MNICU or parent NICU? And is father allowed to enter this NICU because he'll be separated from mother and the baby?
So, in our OBG, as Madam said, it's a very busy unit. Almost 80 to 100 deliveries are happening. So currently the hospital policy is that the male members are coming only at the visit time. That is 4 to 5. Otherwise, female attendant is always there. So that's the policy currently we are following, and fathers at present, they are not doing the KMC in the facility. Yeah. 80 deliveries per day.
Thank you, sir.
Per day.
Thank you. Yes, sir. Go
Question
ahead, please.
for Dr. Suman Rao. How are the babies in the community monitored?
In the scale-up KMC was started in the facility and then they were discharged. So first thing is the mothers were sort of empowered to monitor. But in addition, there was a lot of focus on training of the ASHAs, and they were advised to visit these people as soon as possible. Initially, it was after 2 days or so, but with constant effort, they were able to meet them after 1 day. So they would see them once, but the continuous monitoring was by the mothers. By the mothers. Sustainability you mean after the study or after this first 7 days? Sustainability definitely, like when it is in a research mode, it is very high, but then it sort of comes down. But it is glad to say that in Koppal district as a whole, the sustainability is still there. And we were glad because one of the photos I put up about the advertisements on the buses was not during the study. It was after that. So that was something which was very hearty to see that they were taking it forward.
Thank you very much. I think in the interest of time, we would like to close the session, and we are very appreciative of your presence and participation in this session. We thank all of our speakers. Thank you very much. A round of applause for them. And I give it back to you.
Before we end this session, I would like to invite Dr. Dilip Gadvi, he is an obstetrician, and who would like to express his views on this for a minute.
Yes, good afternoon, friends. And thank you, Dr. Vani and Dr. Dudley, for giving me a chance and opportunity to deliver something new in this conference. Since morning, I am listening every lecture. I am going to tell you something philosophical. What we have learned till today, just now, was scientific and evidence-based. Madam Shobna was telling there is no need of skin to skin, and don't use the word skin to skin. Yes, of course, it is not skin to skin, it is heart to heart. When baby, I am an obstetrician, I am delivering the baby, so I am converting fetus into the baby. The senior obstetrician, Dr. Milind Bhai, Professor Aresh Bhai, and many obstetricians are here, those who are leading the Foxy. So we are the person who make fetus to the baby. And once the baby is coming out, the whole surrounding is changed. The baby is not comfortable with the new environment because the baby was enjoying liquor, was playing with the cord, was playing with the placenta, and everything is getting changed. So that baby becomes very uncomfortable. So once you put the baby on your chest, she feels I am feeling the same heart rate which I was getting from the umbilical cord, or same blood which I am getting. And the mother who was eager to see the face of the baby, since 9th month, once she becomes pregnant, she is always keen and eager to see the face of the baby. Once she put her child on the chest and look at her, she feels that I am in the heaven. So look at the philosophical way, not always, because recently many things has gone, the Ethiopia. Many of you must have heard or read the book, The Ascent of the Human Being. It is said the human race has begun or ascent from the Ethiopia. So Ethiopia is the land from the we people have come to every corner of the world. So anything which is happening in the Ethiopia, we are there. Another thing, any mammals who can stand up on the 2 legs and having only two breasts, will keep his child on his chest. Either is a monkey, langur, or chimpanzees. So we people know that having 2 legs, we always like to put our child or a fetus on the chest. One more thing, when we are putting the baby in the incubator, is in the supine position, or the right or left lateral. But when it is in the kangaroo position, baby is erect position. So naturally dyspnea will be less. The baby will be comfortable with the oxygen level compared to we put it in the incubator thing. So Bertrand Russell has said, the intelligent people are always full of doubts, while the fool and the fanatics people are always confirmed in their own views. So we have to think in that way, how we are getting change. Recently, Madam Vani was asking me that, Dilip, you ask Foxy people to take this program. I'm sure, Madam Vani, the Foxy has accepted, and we are going to more concentrate on this program. I am here as a chief observer from the Medical Council of Gujarat. But another one thing I would like to say, the Nischay. Frederick Nietzsche has said that people don't want to accept the truth because they don't want their illustration to get destroyed. So these are the things, though people know that this is the thing, but we are not ready to accept it. But make your hands high, ask God, have a shower of blessings on my child. Definitely that child is going to survive their comfort zone. Thank you very much for giving me the opportunity. Thank you.
Thank you, sir, for your inspiring words. We now break for lunch. We are running a bit late, so we'll have a quick lunch, 20 minutes, and we'll be back by 2:10. 20 minutes. May I request all the speakers for the second session to have a group picture with the chairpersons. Dr. Rajesh Khanna, Dr. Susan Nirmayer, Dr. Siren Rettidel, Dr. Harish Chelani, Dr. Suman Rao, and Dr. Maria Estrella.
પિક્ચર લઈ લો અથવા મેં એકચ્યુઅલી 2 લીટી લખી રાખેલી કદાચ છે આગું પાછું થાય તો હું ચાલુ કરું આ રીતે એટલે આઈ હેવ રિટન ફ્યુ લાઇન્સ પોસ્ટ લંચ સેશન
અને પછી એકાદું છે એ બધાની સીવીઆઈ છે કે નથી
એ જોવું પડશે મારે ચેક
ઇટ ઇઝ લાઈક 15 મિનિટ્સ અ સેશન
ના એટલે યુ નીડ નોટ વરી અબાઉટ સ્પીકરની સીવી
ઓકે
યુ હેવ ટુ જસ્ટ સ્પીક અબાઉટ ચેરપર્સન્સ પછી સેશન 4માં ડૉક્ટર રવિ પરીખ ડૉક્ટર જતીન મિસ્ત્રી
આ બધાની ચિંતા નથી
એ તમારે નહીં બોલવાનું ના આ તમારે પછી અહીંયા બોલાવવાનું આમ અહીંયા થેન્ક યુ કહીને યુ હેવ ટુ જો એની ક્લોઝિંગ લાઇન છે ના અહીંયા પછી બ્રેક નથી ને ક્યાંય બ્રેક નથી થેન્ક યુ અને પછી
અગેન નેક્સ્ટ સેશન
અહીંયા થેન્ક યુ કોને એટલે આઈ રિક્વેસ્ટ ઓલ ધ ચેરપર્સન એન્ડ સ્પીકર્સ ટુ કમ ફોરવર્ડ ફોર અ ગ્રુપ પિક્ચર ત્યાં સુધીમાં વી મૂવ ઓન ટુ નેક્સ્ટ સેશન અને એમાં પછી આ બોલવા માંડવાનું અને ફોર ટુ ચેર ધ સેશન વી ફોલો અપોન ડૉક્ટર રવિ પરીખ ડૉક્ટર જતીન મિસ્ત્રી
હવે એમનું છે રવિ પરીખ સર એટલે તો પહેલાં
એ આમાં સીવીમાં હશે
ઓકે અગેન તમારું છે પાછું
એ આપી દો હા ચલો હું આપી દઉં
જસ્ટ ઇનિશિએશન ટોપિક ઓડિયો વિઝ્યુઅલ માટે કોઈ હતું નહીં ને મેં કીધું કોઈ હોય છે ને સેશન 3 માટે સેશન 3 ચાલુ કરવાના છો એમાં I don't think this is the session. We'll start the post-lunch session in next 5 minutes. So moving forward to our third session. So we all know breastfeeding helps in early initiation of breastfeeding and also enhances the breastfeeding success. So moving forward, we explore special aspects of improving breastfeeding with breast milk during KMC in our third session. Welcoming our esteemed chairperson for the same, Dr. Hetal Vora and Dr. Abhishek Bansal. Dr. Hetal Vora, she is superintendent and and HOD of pediatrics at Srimati NHL Medical College. And Dr. Abhishek Bansal is a neonatologist and pediatric intensivist at Apple Children Hospital and Child Health, Ahmedabad. Sir, the stage is all yours.
Yeah. Thank you so much for having us here. Now I want to welcome Dr. Srinivas Murki, who is a DM neonatologist and practicing at Hyderabad. He runs an independent KMC unit there, and his areas of special interest are lactation management, national trainer for NRP, and all other aspects of neonatal care. And well, he doesn't need any introduction. He's a very well-known figure in neonatology in India and world over. Welcome, Dr. Murki.
Thank you, sir, and thank you, Chair. And my special thank to Dr. Shashivana Madam for involving me in this galaxy of stars and legends of KMC. And it is really an honor to be present among all of you to present some work which we do in our NICU. And the topic is improving the art of express breast milk collection, storage, and administration. So I would have preferred this express breast milk to be written as mom, because I enjoy the word mother's own milk rather than express breast milk, and I think each one of us should become champions of mom along with KMC. I think that's where all the tertiary care NICUs can start doing it. So my objective is to deal with how do we improve the mom or mother's breast milk expression, how do we store it, and how do we administer it to the babies. So as I said, when I heard the word express breast milk, I remember that ma'am want to speak me on mother's own milk and not just donor milk, because my heart is now in mom. It is a gold standard feeding for all preterm, very low birth weight and extremely low birth weight. So there is no alternative. This is the milk for the babies. It has shown to have dose-dependent effects on reducing feed intolerance, necrotizing enterocolitis, late onset sepsis, bronchopulmonary dysplasia, retinopathy of prematurity. You name the morbidity, it is there in the list. And it improves the gut microbiome. We know Mangla is going to speak on this aspect of gut microbiome. and it is definitely decreases the hospital stay and is very cost effective. In most of the NICUs in India, we discharge our babies at 1,300, 400 grams, even extremely low birth weight babies, only because we make the mother feel that she can take care of the baby at home with kangaroo care with her own milk. And what are the key drivers for express breast milk or mom? These are the 5 key drivers: education, pumping, improving mother-infant bonding, taking care of the maternal health and maternal nutrition. I think this is one of the weakest link in the current practice. I think this needs to be focused a little more. And also we have seen how data collection and EBM metrics can help in improving the outcomes. Just collecting data is going to improve the outcomes. I'll show you how. So the first concept is education awareness. This is our unit. This is what we do to ensure that awareness is spread among the parents. We have this mom leaflet given for every very low birth weight baby admitted to our NICU. I'll discuss the details of this in the subsequent slide. We have a dedicated lactation nurse. Her job is to ensure that every baby gets its own mother's milk. Whatever way it is, she has to ensure the mother's milk comes to the baby. Then we have a dashboard every day reminding us how many very low birth weight babies we have. Out of them, how many are giving exclusive mom. So you can see here the date, it was 22nd of November. We had 4 VLBW babies and 3 babies were getting exclusive mom. 100% only mother's small milk on the enteral feeds. The other important thing is we need to discuss this every day with the nurses, and that can happen only when you have a column like this here. In the notes, what is given to the baby? Is it breastfeeding or mom? Is it donor milk or is it formula? We need to have each feed record what it is going to the baby so that we can evaluate on a day-to-day basis. And this is indirectly an educational practice and implementation practice by the nurses in the NICU. So this is a leaflet I was talking of, which is given to all the parents, be it father, be it mother's attendant or anybody. If the baby comes to the NICU who is a very low birth weight, this pamphlet is given to the parents. They congratulated for getting a baby and what the mother needs to, how they can improve the care of the baby on the first day of delivery, in the first week, in the second week, and then onwards. How mother can contribute to the improving the outcome of her or our baby in the NICU. So education is crucial of the parents, of the caregivers, or the nurses, or the resident doctors, nurses. Everybody in the unit should be committed to ensure that mother's milk come to the baby. The second important point is pumping. Whether it is manual or whether it is using a machine, both are equally efficacious. In the initial few days, manual could be okay or good, but later on I think there is a need for hospital grade mechanical pumps. And we need to tell everybody in the unit should know that the first pumping should be in the labor room. Every day 6 to 8 pumping should be there, and out of which 2 should be in the night. Each pumping session should last about 15 minutes and mother should pump from both the breast. As I said, initially it can be manual and later it should be by pump, and manual pumps should be there with every mother. All mothers who are delivering very low birth weight or ELBW babies should have a pump with her, and in all the tertiary care NICUs there should be hospital grade breast pumps easily available and in a place where mother's privacy can be ensured. So these are the pumps which we have in our unit. Every mother is given this at the time of admission. The mothers are not charged for this. We found resources to get these pumps free in our NICU. Every mother, if she is admitting a VLBW baby, she gets a pump at admission. Then there is hospital grade pumps which are available round the clock for all the mothers who come to the NICU to express, and some more pumps are there in the ward and in the maternity units also to ensure that she has 24/7 access to breast pumps. Now once I said this, all people in the unit should have access to how should ensure pumping should be done. So when we did a very recent QI and then we realized that to involve everybody in the unit to ensure that they promote pumping, we need to involve them in bringing out educational material. So this is one material which we made while we started our second QI study, where our own residents, our own nurse team made this video, and after making this video I could see the change in the practice in our NICU. So they could understand what pumping means, how the mother should be encouraged, what all manures or what are back massage, breast massage, how each one of them will contribute to improve the milk output. Mother going to the baby and talking to the baby and then pumping, how it improves the milk output. So each one of them, then all this was done by our nurses and residents by themselves. When they do it by themselves, they understand the process and they understand that this needs to be implemented. They own this video, they own these skills. That is why they are implementing this on a regular basis in our unit. So just it's a 2-minute video, but each concept, each one has been done with meticulous attention by the residents and by the nurses. I did not get involved in making this video at all. And that shows that there is commitment by all the people in the NICU. When you give them work, when you make them responsible, they do it better. And this is education, this is skill development, and this is implementation. So these are the ways in which we can try to ensure that Suman said it is difficult to convince nurses and doctors. I agree. But I think when they're given responsibility, they do it. So when they own the thing, then they do it. And this is what happens if you start involving them in making educational material, in also making videos, in skill development. If you involve them, they're going to become part of that. The third important principle is improving mother-infant bonding, or all of us said that it should be family-infant bonding. This should be improved. And how do we do that? If possible, we should have a family-centered care where all the parents, all the mother, father, family members have free access to the baby. And I'm sure it is not possible in most NICUs now. All are working towards it. But at least every NICU should have unrestricted access of mother to the baby. So if mother is not able to come, send a video of the baby to the mother. Nowadays, WhatsApp is easily available. So just click a small video and send it to the mother daily. She will be immensely thankful for you, and she starts flowing milk. And once the mother is coming to the unit, make her do all the baby care activities, whether it is feeding, clothing, diaper change, oil massage, weight change, weight monitoring, growth monitoring. She should get involved while the baby is in the NICU. And we should ensure that we set 6 to 8 hours or more than 8 hours. And if you have to do more than 8 hours in the NICU, all the family members have to do it. So we have, if father wants to do KMC, they get access 24/7. But if they're coming only to see, they don't get access to see the baby. So mother gets 24/7. Father can get access to the baby if he wants to do KMC in the NICU. So extended family care is the way to improve the number of hours. And maybe we should start doing pumping by the bedside of the baby so that we can improve the quantity and quality of milk the mother produces. And non-native sucking, this involves that extremely low birth weight babies, they should be put onto the breast as early as possible and not on pacifiers. Non-native sucking is putting the baby on empty breast so that the bonding improves and the milk output will flow. So you can see these are pictures from my own unit where father, mother, all are doing KMC, and mother is getting, she is doing the baby care activities sometimes with the guidance of the nurses, sometimes for her own. The fourth important aspect is maternal health and nutrition. We should ensure that mother's pain is relieved. There should be extensive support. These days we know that most of them are nuclear families. They do not have support. So each of the nurse, a small bad word or by a small, any insult to the mother, any wrong word used to the mother will going to ruin the entire cycle of breastfeeding. So a positive thinking, positive attitude of the nurses and doctors is going to help this. And we need to have a privacy for the mother for expression of breast milk, or when she wants support, we should ensure that. And every comfort should be there when the mother is coming to the NICU. So we should welcome mothers coming to the NICUs 24/7. Few important things which are already there in the community where we need to encourage. Mother should be well hydrated. And if you go to PGI Chandigarh, you will see that almost all the beds of the mothers will have jeera water with them. So I love this concept of jeera water because it will hydrate the mothers, it will help them in improving milk output and make them feel special. And also highly nutritious diet. So panjiri, chikki, mutton, egg, there is no restriction. Whatever the mother likes, you should encourage her. Don't force feed her, but if she likes it, that should be given for the mother. We should remove the myths such as garlic rice. I think entire South, you know that they eat rice and garlic as the basic food, nothing else. They think that improves milk output. Forgetting balanced diet, they go only for rice and garlic. So which we need to remove the myth that, okay, continue with that, but add on with more nutritious diet for the mother. And there is a biggest myth that jaundice and diet. Mother doesn't want to eat many food because baby will have jaundice. So this principle has to, the myth has to be broken, and that can happen only when more and mothers start giving the milk for the babies. Galactose, although all of us do not want galactose as a routine to be supplied, because even if it's a placebo effect, even it improves the confidence of the mother, it is worth doing it. And the fifth point is having metrics, measurements. We need to measure mother's own milk or EBM metrics. So we should start recording when did the mother pump first? When did the mother's milk reach the baby first? Is it 1 hour? Is it 2 hours? Is it 1 day? Is it 3rd day? When did the mother come to the baby first? How many hours after birth? When did she do the first skin to skin contact? When did the mother do the first non-native sucking? All this should be documented and recorded. And if you put it in the summary, it is going to be very useful, because people will start thinking, what is this? So when it should have been done. So once you do it, you will make improvement. And we should record number of expressions the mother is doing every day and which time she is doing. And you should measure the amount of milk the mother is expressing on each session, so that in 24 hours how much milk is produced by the mother. And you can see here that we have this metrics in our daily enteral feeding chart. The other metrics you need to measure are, when did the mother reach 500 ml per day? This is something, if the mother is able to reach 500 ml per day by 2 weeks, end of 2 weeks, very likely that the baby is going to be breastfed at term gestation age and following that. So this is very useful and very simple. You need to work on the first 2 weeks. If you work well in the first 2 weeks, rest of the journey of the NICU and following that is going to be easy. And we need to measure the first 1 week and second week volumes, so that we tell the mother that you have a chance for improvement. We tell the residents, we tell the nurses that you need to work on this mother. Proportion of enteral feeding as mom should be recorded. I believe that all human milk is not mom. Mom is specific for her baby. So we need to ensure mother's own milk and not DHM or PDHM. PDHM can be used for if the mother's milk is not available, but I prefer mother's own milk over PDHM. And again, you need to see out of, if the baby receives 100 ml of milk, how much was mom in the first 1 week, in the second week, during the entire hospital stay, and at discharge, how much is the mom out of the enteral field. These records should be recorded so that we can continue to do quality improvement projects in our NICUs. If you start recording, you will see that although we talk a lot, but in all these metrics, we perform very poorly. Only when we start recording, we'll realize that there is a huge scope for each one of us to improve. And other thing is, start recording at term gestation age or discharge. How is the baby? Is it come to breastfeeding or not? Now, second concept of express breast milk to storage of breast milk or storage of mom, I feel it should be ideal to give immediately after expression. In the room temperature, you can give for 4 to 6 hours. In most of our NICUs, we keep it around 1 or 2 feet more. If it's refrigerator, you can use normal refrigerator for 24 to 48 hours. But if you want to store for prolonged durations, then you have to pool, pasteurize, and store. And we need to follow the first in, first out principle. And even in that, you can try to see that if you can give the same mother's milk for the same baby, it might be better off rather than as a PDHM. So every tertiary care NICUs, now it is very simple. You have small mass pasteurizers, we have small cabins, small refrigerators to ensure that your NICU can have a small milk bank. The average cost of this is going to cost around 10 lakh rupees, which is equivalent to or less than an incubator in the NICU. So I think it is possible. If we have a will, we can do it. This is a photo from one of my friends in Hyderabad. I feel mother's own milk is the best, so I don't want a milk bank. I feel that that should be the way forward, because I'll show you in the subsequent slide. In our outbound unit, we are able to do almost 100% mom without even a milk bank. Administration of mother's own milk. Everyone should start colostrum coating of the mouth in the newborn, especially if the baby is not on feeds. If he is on ventilator, on high ventilator support, or if he is anatropic support, we should ensure that the colostrum comes to the mouth of the baby. And always in all the very low birth weight babies, if your babies are not reaching 150 ml per kg per day of enteral feeds by day 7, that means there is a scope for improvement. So this is the metric you can remember, that VLBW's babies or ELBW babies by 1 week, they should be on full enteral feeds. If you're not doing this, there is a scope for us improvement. And we start probiotics for all our babies, even though on mom, all very low birth weight babies, we add fortifiers when the baby comes to full milk. And this is with regard to administration. We progress from gavage to palate to non-native sucking to breastfeeding, and this is the order we follow. And we believe that most of these babies by 32 to 34 weeks, they can come to full breastfeeding. So this is what I was talking about. Ours is an outborn unit. This is a small study which we did in our NICU as a quality improvement project. And here the mothers were coming to our NICU by 3rd or 4th day, because most of the time the baby comes and the mothers come on 3rd or 4th day. But we started our QI by sending pumps to the mothers and encouraging them to come to the NICU as early as possible. If you see here, the bars, these are the purple bars are the mother's milk, and the blue bars are the enteral feed needs of the baby. These are all very low birth weight babies. The average gestation was 29 weeks. Average weight was 1.1 kg. So you see that what the mother is producing by the 4th day, or by the 4th or 5th day, the baby needs are actually lesser than what the mother produces. You can see here. So mother is always producing more than what the baby wants. All preterm mothers produce more milk than what the baby needs. This I'm talking about babies less than 1 kg babies, and mothers who are delivered 29 weeks babies. And in the 2nd week, you can see all purple bars are more than the blue bars. That means every baby can get his own or her own mother's milk. At least from 4th day, you can ensure that there is no need for any donor milk or PDHM. So just to summarize, the key drivers for improving mother's own milk or express breast milk: education. It is the crux of all the interventions or implementation. Having mom leaflets, dashboard, nursing notes, and doing QAs. I realized that in our unit we do a QI on related to mother's milk regularly. For the last 10 years we have been doing one or the other QI. So that is the principal way I think that people will get used to doing more changes, improving the mom metrics, because reaching 100% is possible, but it is a everyday affair. Pumping 6 to 8 times a day, 2 times in the night, having adequate breast pumps, skill development of all the people in the NICU, ensuring that family mother bonding is done, and obviously KMC is part of it, and concentrating on mother's health and nutrition, and last but not least, measurements. Measurements are key to outcomes. Only when you start measuring, you will know that where you stand and what we need to do. Storage, milk banking only if you are not able to get mom, but I said work on mom. Your milk bank will work only for probably late preterm babies or term babies, and not for very preterm babies. Administration wise, concentrate on colostrum, full feeding by day 7. After full feeds, probiotic and milk fortifier supplementation is going to help in the outcome of these babies. Thank you very much.
Thank you very much, Dr. Murki. Any questions from audience?
Thank you, Dr. Mukhi. It was a wonderful oration, and I have been going through some of the research related to CPAP. I have been myself a working pediatrician till 2002, and then for the last 20 years I have gone to the public health. I have a couple of questions to you. One, we are trying to promote probiotic here. I know there is a lot of research going on globally, but it hasn't yet become the evidence-based science. The WHO, I believe, maybe WHO is here also, they can tell us what is the latest for, this is going to come soon, but as yet, there are no recommendations to take it forward in the country's public health platforms. My second issue is related to manual expression versus use of able to take out, in addition to the cost, in addition to likely contamination. So what is it that we need to promote, which cases? Because here I believe it's a workshop which is being sponsored for the countries to take scale up in the country. And
So-
some of the best clinical practices may not have yet reached a proportion of evidence-based intervention.
Thank you for both the questions, sir. The first regarding the probiotics. I'm talking about very low birth weight babies or extremely low birth weight babies, where we have clear-cut evidence that if you're giving full milk of the mothers, you need to supplement with protein and carbohydrate. Obviously, we do not have the best probiotic, the first best probiotic so far. Yeah, but the current science says that irrespective of the type of milk given, probiotic will help in decreasing further reduction of all the morbidities. Regarding the second intervention of breast pump versus manual pump, I would suggest whatever is easy for the mother, whatever is doable for the mother, give the choice to the mother. If she is want to do manual pump, encourage her. But if she wants to do need a pump, please help her. Thank you.
Now, let me invite Dr. Kumuta J. She is a dean at Savitha Medical College, Chennai, and professor and head of the Department of Neonatology. She is also executive committee member of NNF and winner of KMC Oration and several other awards. Welcome, ma'am.
Thank you, sir. Good afternoon, one and all. At the outset, I would like to thank Madam for inviting me to be part of this great conference. I know how much with all hardship she has arranged this despite her health issues. Thank you, Madam. The topic given to me is Art and Science of Colostrum Feeding, the earliest immunotherapy, and clues for early initiation of oral feeding in small and sick newborns. As I understand from Madam, I'm going to talk only about colostrum swabbing, not touch on trophic feeding. And all of us know that the colostrum swabbing comes to all small and sick newborns, and preterms are highly vulnerable. And this august audience does not need me to enumerate the handicaps they do have, especially the extreme preterm babies. And again, a word about colostrum. All of us know the merits and advantages of colostrum, but I feel when we teach the postgraduates certain points to be emphasized on them, especially this first statement, produced when the tight junctions of the mammary epithelium are open, and this allows more immunological factors of passage into the milk. One of the mothers appreciated, why didn't you people talk about this earlier? So that is one thing I thought would also benefit when we are talking about the science. And also the antimicrobial, especially the secretory IgA, and also the growth factors which are essential for growth, and also the anti-inflammatory factors, because they are very highly vulnerable. And we know whenever we talk about colostrum, more than the nutritious content, we talk about the immunologic property of colostrum. And so it is also very essential. It not only has immunological properties, but also anti-inflammatory factors, which an exaggerated immune response may be there in an extreme preterm baby. And again, this is another slide really interested our postgraduates when we took session, that the colostrum, if you look at the secretory IgA, the component when compared to term milk, it is almost 8 to 9 times more. So this is the most important, that the colostrum feeding we do not only for extreme preterm babies, but also all the babies who are born in this world. And also their interleukin, which is again to the tune of 10 times from the term milk, which is very, very important, why we should also do colostrum administration or swabbing, even oropharyngally to the extreme preterm infants. And again, when the colostrum is administered orally, there are great advantages. Apart from feeding, when it is smeared over the buccal cavity, it stimulates the lymphoid tissue, oral lymphoid tissue, and also you have mucosal absorption is there, and also the oligosaccharide absorption modulates intestinal microbiome. Dr. Mangalabharati is going to talk about it, and if we are going to have friendly microbiome, we are going to have lactobacillus and bifidobacter, which is very, very important for having a normal microbiome in the gut. And also it decreases the addition of the pathogens, providing an epithelial barrier translocation. We know that mouth is the point of entry of most of the organisms, and if we can administer colostrum oropharyngally, we have multitude of advantages which we can provide the baby. Other benefits, I don't want to go through, it will be, some of them will be repetition. And again, if you look at the evidence for oropharyngeal administration, many studies have divided opinions, and they've also demonstrated both salivary and urinary excretion or secretion of IgA and lactoferrin is much higher in babies who had colostrum feeding or colostrum swabbing. And also they had low TGF, tumor necrosis factor, which is very, very important in the inflammatory reaction. And not only that, there were decreased outcomes of sepsis and also necrotizing enterocolitis, and time to reach full enteral feeds and hospitalization was less in many of the studies. But if you look at this graph, you can see even at the first week and in the second week, those babies who are fed on colostrum, you could see their secretory, salivary, lactoferrin and IgA levels are higher. But the Cochrane in 2019 did not, they looked at 3 primary outcomes. One, they looked at necrotizing enterocolitis. They did not find any significant difference. And also late onset infection, there was no significant difference. And if you look at the death before discharge to home, again there was no significant difference, but there was a significant difference into days to full enteral feeding. But they concluded the study saying that they need more numbers and further studies are required. And again, if you look at the meta-analysis recent, involving about almost 17 studies, they have concluded that if you look at the forest plot, it favors the colostrum swabbing, especially necrotizing enterocolitis. But I feel even the studies, if they are not even giving conclusive evidence now, but I think it is common sense intervention. We know that colostrum has all the advantages, and swabbing them, and when it is safe for the extreme preterm babies to be administering that, I think we should go ahead and do it. And we have 3 types of neonatal therapy as oral hygiene, instilling sterile water or sterile water plus mother's milk. And the third one is what we are talking about, that is colostrum swabbing. And as of in our unit, we have started doing it. In fact, we are in the process of a study. Our study has not been concluded. When we have a birth of a preterm, extreme preterm baby who might be born with or without problems, the immediate action we do is collection of mother's colostrum. As Dr. Srinivas said, if you do it immediately, then we have the collection, but of course pre-education during the process of delivery is very, very important. Even in mothers who are eclamptic, admitted in ICU, we have sensitized the nurses in the ICU and we go for colostrum collection. So that is possible and feasible, but a lot of education goes into it. If a baby's NPO or minimal feeds, then oral immunotherapy with colostrum is given as a prescription. Again, as he said, unless we put it as a protocol, instead of just saying you do it, they don't do it as just CARES part. It is given as a prescription and it is given every 3 to 4 hours. And we can do the colostrum swabbing either using the cotton swab, but that should be low absorption because all the milk should not get absorbed into the swab and then it will not be transmitted to the oropharyngeal. But we are using this Manto syringe, 1 ml syringe, and 0.1 ml into each side of the cheek is administered. We try to give only 0.2 ml and it is administered every 2 to 3 minutes. Sometimes if the baby starts sucking or something, we add few drops into the tongue also. That is how it is distributed as oropharyngeal administration. So this is a practice that is very safe and it is feasible. We have found that there are no physiological parameters which get altered during this administration. Of course, the nurses are trained before doing this and it is very, very well tolerated. And it is almost done up to 96 hours of life once we get on to trophic feeds and we are able to give the volume. But when I went through the literature, there are some people who are, even if the baby is on a fairly good amount of nasogastric tube. They continue to do this colostrum swabbing, but we don't have such an experience. If somebody has an experience of that, they can share for us. So again, to conclude on colostrum feeding, it is easy and it has been shown a lot of advantages. So please, it has to be given as a prescription. The baby has to have the colostrum swabbing or administration of oropharyngeal every 3 to 4 hours, as we would give a feeding, even if the baby cannot tolerate feeds and remains NPO. Regarding my next part of the topic, early feeding cues in preterm infants and sick infants. In neonatal nursery, we do have the habit of small babies and sick babies receiving scheduled feeding. That is, either we give it second hourly or third hourly as a unit policy, and our nurses stick to this very strictly, and they tend to disturb babies even if they are sleeping for the sake of feeding and have lot of problems. So I think these early feeding cues really would go a long way, because it's a very good crux or heart of the developmentally supportive care we could be providing for these babies. So this cue-based feeding focuses on behavior and hunger cues of the infant rather than on a scheduled feeding, and also it demonstrates assessment of readiness to feed rather than going for a fixed schedule. Again, lot of staff training requires to be done. In fact, mothers who have been allowed in the NICU are able to identify that my baby is ready, please feed now, rather than making a second hourly, a third hourly schedule. That is what has happened once we have started practicing this. And again, it is a responsive feeding, and it is very individualized and gentle method that focuses on establishing the baby's own rhythm rather than our time fixed schedule of feeding. This is what is cue-based feeding. And we should look at the positive feeding experiences the baby would feel on a cue-based rather than volume-driven. So what are the advantages? The advantages are faster transition to oral feeding and leading to shorter hospitalization. In fact, they have an increased weight gain. After this and KMC for prolonged hours, we are not using fortifiers for our human milk feeding. We are giving exclusive human milk feeding. Our usage of milk fortifiers have reduced after the combining cue-based feeding along with KMC for prolonged hours. And also it has improved parenting skills, because we are involving the parents also, and also the workload of the staff also comes down. Instead of giving 10 or 12 scheduled feeds, she would give feeds based on the cues. So that is what her workload also gets, and she gets the involvement of the parents and the family. I have covered this. And actually the behavior characteristics we should really observe in this are, we should look for hunger cues, which are just searching, holding the nipple, especially if the baby is on KMC position, mouthing while they are undergoing KMC, and sucking also. But if they have the self-regulatory, that is liquid loss, drooling, closing the mouth tightly, or too much tongue extension, grimace and all that, we should not feed the kid. And again, stress cues also, they have to identify changing color, especially a child becoming blue, cyanosed, regurgitation, reflex, choking, all that has to be identified. I think few slides only. And we should also identify satiety also, because the baby falling asleep, turning the head and pushing away the fluid, when to stop. In cue-based feeding, we should understand. And actually there is a chart, especially for preterm, like term babies, we do have what are the early cues, which are staring, mouth opening and sucking, and mid cues and late cues. So this is what we should identify. A nurse and the mother also can be roped in to help us, and whenever the baby awakens spontaneously, roots and suckles his own hand and has a good muscle tone, then the baby is ready to be fed. And benefits, as I told you earlier, the length of stay is less and they have lesser physiological, improved physiological outcome. They have increased nutrient intake and fewer adverse events also. That is also there in benefits. So there are again lot of tools available like EFS and then PIBBS, supporting oral feeding in fragile infants, and infant driven feeding scale, especially after oromotor stimulation. We can do all these assessment scales also. When coupled with premature oromotor stimulation, this really helps in having a complex of interventions which will drive us to the developmentally supportive care of the newborn. I think when to stop, that is very, very important. As I told you, when there are a lot of stress signs and signs of loss of self-control, then we should not continue this feeding. We should stop and then go back and wait for the baby to be ready for the baby to be fed. That is what we need to do. Then, in conclusion, I want to say that colostrum, we do know the advantages. Even if the baby is not ready for considerable volume of feeds, then the baby can undergo oromotor or oropharyngeal administration of colostrum, which would help them in going towards the developmentally supportive care. And again, cue-based feeding is much more towards family-centered care and developmentally supportive care, which I think we should adopt in our units more. And then also we have to contribute to evidence which is currently lacking and help our babies for a good nurturing. Thank you.
Thank you, Dr. Kumuta. There is an important announcement. Those who are having oral paper, please contact Dr. Ravi Parikh. Dr. Ravi, he is there. So please contact him, those who are having oral papers. Now let me invite Dr. Mangala Bharti. Dr. Mangala Bharti. He is head of the Department of Neonatology at Institute of Child Health, Agmore, Chennai.
So very good afternoon, everyone. At the outset, sincere regards and thanks to KMC Foundation and Sashivani ma'am for this wonderful opportunity. So when we talk about the relationship between gut and brain, I think all of us will realize well what have been the impact of lunch on all of us now, right now, right? So all are happy, but a bit sleepy also, maybe after lunch. So there's no doubt, and whenever we make some decisions which we don't understand, but where we strongly feel that's the right decision to do, we call it a gut feeling, right? I don't know where it comes from. It may not be based on any sound rationale or a principle. Something tells me that this is the right thing to do, and we call it as gut feeling. So I have only 15 minutes, so I understand this is a very huge and wide topic, and I'm not such an expert to discuss this in detail. So what we'll try to do is to give you an overview of what people are trying to do or understand about the so-called gut-brain axis, and most importantly, what is in it there for us as neonatologists practicing people taking care of newborns. So what do we understand by learning this gut-brain axis? So these terms, I think more and more we talk about microbiomes when we talk about health and disease. The word microbiome means the bugs. When we say microbiota, we talk about the genetic material of all combined microbes, whether it is bacteria, virus, whatever it is. They combine all the genetic material of the bugs within us is called microbiota. And we are more interested in the relationship between our genetic material and the genetic material of microbes. That's why we bring in to use the term holobiont, where it is a combination of or interaction of humans with the microbiota. I think the techniques have advanced a lot in terms of the sequencing the various microbes present in the human body. Again, I'm not going into these, I'm trying to say, right now we have a very, very advanced technology where almost more than 99% of the genetic material of the microbes within us can be identified easily by these various techniques. So we know what is there inside our body exactly, clearly. But the equation is not so simple, because that's where this omics era comes in. Because there was a time where people thought once we are able to identify on the genome, so we will have an answer to how it will behave. But for a genetic material to get expressed, it's not going to follow a same pattern. So again, even though we know about the genetic material, it might behave differently in different people or different babies. There may be an influence of, there will be significant influence of the environment. That's what we call as an epigenetics, influence of external factors on the expression of the genome. And the way how it goes to get transcribed, people are studying transcriptomes. It has to become a protein. We can study that, proteomes, some metabolites, fine. Just to highlight, so even though we know a lot about the genomes of a microbe, still many steps are there regarding its expression. Though we say that microbes constitute a significant portion of the human body, there are a few areas where they are found in large numbers. Obviously, in our oral cavity, skin, the digestive tract, and of course the urogenital tract. This is where most of the bugs are located in our body. As far as many of the lifestyle diseases are concerned, now there is a reasonable amount of evidence to show that interventions in the form of playing around with this gut-brain axis, for example, say probiotics. There was a question on probiotics now. I'm talking about the adult literature. There are certain diseases like, say, depression, anxiety, obesity, overeating, anger, and all, where there is a clear evidence that actually interventions playing around with good microbes definitely makes an impact in the outcome of the disease. Whereas about, there is suspicion, or we all know what is the difference between association and causation. So there are lots of diseases, including very serious diseases like schizophrenia, autism, cancers, liver disease, and even ischemic heart disease and all, where microbiologically, by studying the patterns in those who are diseased versus those who are healthy, people are showing that their microbial pattern is different. The genetics is different. So there is some association, but really, what does it mean that there are no reproducible signatures? It is not that every diseased person has got the same kind of abnormality in their microbiota. If their microbiota is altered, they seem to be at a higher risk, but we don't know, we don't have a single pattern to say if this pattern is there, this is abnormal and is going to lead to disease. In humans, sorry to bore you with micro, again, I'll quickly pass through the slide. All I'm trying to see, even though there are a lot of bacteria, they fall broadly under one of these four groups. The actinobacteria, predominantly the good ones, Bifido, Propio, Corynebacterium and all. The proteobacteria, where all the bad bugs we know, Enterobacter, Escherichia, Klebsiella, Acinetobacter, and Firmicutes and Bacteroides. These are the four main groups. And when we say that can the gut, these microbes in the gut talk to the brain? So one of the questions is that, okay, so how can we talk about? Most of the time when we say this gut feeling, so we know there is a nerve directly connected, vagal nerve innervation is there. It should be neurally derived. Or many times it may be just a chemical mediators, a lot of hormones, other things are there. That might be the connection. Where does a microbe come in when we talk about a connection between the gut and brain? So these are the postulations. Again, we don't know for sure, but there is a strong reason to believe that microbes in the gut affect the functioning of the brain by, number one, the most of the serotonin in the body, if you look into where it is being produced maximally, they're all produced in the gut. So a lot of serotonin is produced in the gut. We know the importance of serotonin and a lot of interventions even related to serotonin. We talk about many diseases of the brain. So that is one probable mechanism. A lot of cytokine related immune mediated mechanisms are being postulated. The third most important interesting point where people are just exploring a lot and trying to bring in therapeutics is certain bacterial molecules. What are those bacterial molecules? So the complex carbohydrate which cannot be broken down by the body. Obviously we need microbes to digest them, and that produces simple kind of short chain fatty acids like acetate, butyrate or propionate. And these seem to be a very important bacterial components which seem to be a language which is spoken between the gut and the brain. The importance of microbes in maintaining, sustaining and repairing the epithelium or the integrity of the gut is well established. That's why we talk repeatedly about NEC, sepsis and other things where gut integrity gets compromised a lot. This is a very interesting evidence. People have shown that the same reasonably happens on the blood-brain barrier as well. Animal experiments were done and whenever there is been, like a sterile mice without any bacteria in them. And even what happens in fetuses, their blood-brain barrier is very, very porous. The junctions are not tight. But once our body starts accumulating these microbes over a period of time, they seem to affect the blood-brain barrier, bringing in more integrity. That is again one of the important mechanisms by which these bacteria act on the brain. So let's get to our focus of interest, actually what happens in a human fetus and in a neonate. Obviously the neonate is not born in a sterile manner. There is a transmission even across the placenta of the bugs from the mother. But so, see, I'll just show you some slides with a small illustration to understand, is there an evolution period or a period of maturity even when we talk about this so-called establishment of the bacterial profile in the gut. So as I said, these are the four main ones in our body. See, the blue ones are from the oral cavity, the pink ones represent the vaginal flora, the green ones represent what is the kind of flora, what is there in the skin, and ultimately the brown one is our area of interest, what happens in the gut, the kind of bacteria what we have in the gut. So the small yellow ball, what we say in the middle, is this modeling has been done some wonderful research. They just want to show what is this helps us in understanding how microbia are involved in a newborn gut, in a baby gut. To start with, just see this is what happens over a period of time. So you just see the axis is moving from birth as time progresses. To start with, it's around pink, right? It's the maternal vaginal flora is the kind of flora what is there in the baby's gut for a significant amount of time. Then there seems to come an influence of the green one, an interaction between the pink and green. That means the skin start playing a big role, the skin flora and the vaginal flora. The oral, even though we talk a lot about what we eat, hardly the oral kind of pattern seems to influence this one. Ultimately, at the end, it takes around 27 months for the baby to establish a standard kind of a profile, like what is the kind of a profile what we see in the adults. That much amount of time is needed. So this is a summary. At birth, soon it's more of a vaginal, and it takes 27 months to reach or establish the kind of flora what we see there in adults. And again, the process is more delayed in a preterm baby than a term baby. Okay, I'll skip that. I'll just get fine. So what are the various factors that can influence this establishment in the period of 27 that had been studied? I'll just touch upon the names of the factors only. Obviously, whether it is a baby is born a preterm or a term, what gender, the baby's influences in the postnatal. Most importantly, the mode of delivery seems to play a bigger role in establishment. And early experience in terms of obviously sickness, medications used, NICU environment, whether the baby got exposed to stress and pain. Yeah, our parent-infant separations and comfort interventions seem to play a bigger role here, and of course the type of feeding. That seems to influence the host gene variation and the gene expression and leads to play a big role in brain-gut microbiota signaling. Okay. So to convince you that, okay, there are articles which had looked into what had happened to the neonates microbiome in the NICU environment. There is a wonderful systematic review on the impact of various influences. We don't have time to go through. These are the various studies. I'm just trying to say there are so many studies which have looked into each of these factors. What is the influence of the mode of delivery on the intestinal microbiome of the newborn? What is the impact of the feeding pattern? What is the impact of skin-to-skin care? What is the impact of separation, pain? So all these factors are getting studied right now. So ultimately, this slide is a very, very important slide. See, there are clear, at least mechanisms been shown to show that on the top you see the development of the brain. the brain also develops over a period of at least from, let's say, the first 2 years we know, right? The lots of processes, myelination, synaptogenesis, changes in volumes, the synaptic refinements keep happening. Parallelly, there seems to be something for the gut also. It is not from the microbiome pattern, it is not mature. It starts at birth and it takes up to 27 months for various patterns to change. And we have reasons to believe that these two talk to each other over this period of development and maturity throughout this period of 24 to 27 months. And we know there are a lot of reasons to believe, because of the various morbidities and the various interventions what we do, we meddle with this process of how this biosis happens in a baby. So that means a lot of dysbiosis happens. And of course, this biosis is likely to influence the maturation and development of the brain. So some clinical data is also available to look into the various practice, but it's indirect data related to the kind of various practices, its impact on dysbiosis, and what is the impact on neurodevelopment. There is evidence to believe it improves. So units which had good practices like enteral feeding, reduced sedation use, early extubation, most importantly, more skin-to-skin care, have a very less incidence of dysbiosis and a better neurodevelopmental outcomes when studied at the age of 2 years. So I think that's my last slide. Of course, this is the theme of today's conference. Okay, so what about what is the influence of skin-to-skin contact on this gut-brain axis? Because again, not getting into the details of individual studies, there is evidence to show that. So KMC helps in establishing earlier colonization of the baby's skin from the mother. And most importantly, not only it helps in establishing good or healthy bacteria, it discourages the establishment of the bad bacteria that is coming from the NICU environment. The more we do KMC, the more we can avoid dysbiosis. And of course, the help always comes from the mother also, as she gets from baby skin. Once the bug information goes to the mother, she helps in terms of an immune transfer against protection. And above all, we repeatedly saw stress and pain as a concept play a lot of role in related to dysbiosis and gut-brain interaction. So there's a wonderful interaction and intervention which decreases stress and decreases pain. So promotion of KMC and breastfeeding should play a big role in ensuring a proper establishment of a biosis in the way it has to happen in the first 2 to 3 years. And even though we are not very sure, we have a lot of reasons to believe this will definitely have a good impact on the neurodevelopment. We'll stop here. Thanks for the opportunity.
Thank you, sir. I think it was a very difficult topic, and the gut feeling tells that this is really, we could understand a lot in this. So I would like to invite our next speaker, Dr. Milind Shah. He's from Solapur, and I think sir is a senior consultant, and he's also Secretary General for Federation of Oceania Perinatal Societies, and he's a past president for Indian Society of Perinatology and Reproductive Biology. Sir, over to you.
इधर है नहीं अच्छा slowly. Thank you very much, Dr. Hetal Hora and Dr. Abhishek Bansal, for these kind words. At the onset, I must say big thanks to Dr. Shashivani, Dr. Parag Dagli, and the entire team of KMC Foundation, with whom I am associated since many years. And I realize, yes, that is the need of the hour, but the naturally question comes, what about the obstetricians? Because people always feel that, let me see whether it runs.
En vérité, ta naissance a été très rapide et très facile.
So this is basically to awaken you, as you saw just a wonderful floral presentation by Dr. Mangala Bharti on viruses and bacteria, and wonderful slides and nice actually knowledge. But I thought, yes, post-lunch is a challenge for the speaker as well. And that's why now telling the role of obstetrician is also very, very important. You know, friends, I realized the importance of KMC when during this COVID pandemic, because we were delivering these COVID positive mothers, and it was a big challenge for us how to make the babies with mother when COVID positive. We wanted to observe all those handles by which we wanted to avoid actually the transmission of the disease to the baby. Fortunately, out of the 25 deliveries which we conducted, we could not see a single case whereby the baby got a positive status, but it was a great challenge as well. And the today's challenge for me would be this one. The great struggle in medicine these days is not just with ignorance and uncertainty, it is also with the complexity. How much you have to make sure you have in your head and think about. There are 1,000 ways things can go wrong. And where comes the role of the skin-to-skin contact with the mother and the baby. But after listening to so many talks and so many deliberations on KMC on all aspects, I thought, let me put some practicality in my talk instead of putting the same thing again and again. Probably certain actual slides may be repetition, but that is also important. Now question come about the counseling of the parents, and I'm very actually surprised to see that people always used to think that probably obstetricians are not promoting KMC. It is not true. We always and always want to have the KMC to be adopted in our nursing homes. You know, friends, in India, we have a more practice of small maternity homes as well as the big corporate hospitals and the government hospitals. And especially in the private hospitals, which I'm observing over last 5-6 years, when I'm got associated with this A to O network, I realized that they want to promote this kangaroo mother care very much actually in their clinical practice. So there is no question of whether this task need to be carried forward by the obstetrician or the neonatologist. Anyone can do that. And the best one, what I realized in my own setup was the lactation nurse, because she's the one who sits with the patient for longer hours and she explains them everything about the kangaroo mother care. We offer them one kangaroo mother suit, and that always helps to explain her how actually one should do about. When we started this particular activity, when I was president, and I was very much happy that Dr. Mani, you have brought me to this particular field to understand more. And more actually credit goes to Dr. Suki. I don't know whether she's here. When I went to Manila and when we decided to have this foundation, Asia Oceania Network for the KMC, we realized there are a lot of things which we need to do. And this is again an eye-opening paper I came across. The multi-country analysis of health system bottlenecks and the potential solutions. And in that, probably we'll realize that one of the challenge was the personnel, how to deal with. And that's why the conclusion of this particular study was, there are at least a dozen countries worldwide with national KMC programs. And we identify 3 pathways to scale it: the champion-led, the project-initiated, and the health system design. And all that need to go comprehensively to see that our efforts come to a real dream. And that's why the combination of all these 3 pathways is essential in promoting kangaroo mother care. Another actual wonderful publication which tells about that how everyone want to endorse. Yesterday we had one meeting actually of the A to O network, and I was surprised, shocked, impressed, and must give big applause to Dr. Shashivani that she made it to see that each and every organization comes forward to endorse the importance of kangaroo mother care. And we, the group of obstetricians, are not behind it. The Foxy and all other organizations are definitely trying our level best to see that the KMC comes in a clinical practice in each and every maternity homes. Because we realize that it was started with the low birth weight or the preterm birth, but also for the term babies, it is quite effective and has so many actually the hidden advantages which we should exploit by utilizing that. That was introduced basically for the low birth weight, but now we realize that we can use it. And again, the another very important thing which we learned about the exclusive breastfeeding, which was encouraged. Now there are a lot of misbeliefs. I could see there are so many actually the speakers are from South India. And you know, in Karnataka, in Andhra Pradesh, there is a practice whereby they say the colostrum need to be thrown out and the feeding should start on third day. So it takes a lot of time to dispel this particular myth, and we always want to do that by our efforts, by telling our staff as well, from reception to the doctors, to see that all those myths need to be dispelled very properly. At the same time, we need to do a lot of advocacy of that particular fact by public awareness activities are there. This practice resulted in improving the outcome of the low birth weight infants, humanized general care of the infant in hospital, decreased hospitalization time, less overcrowding, and the less abandoned infants which is there. You know all about why it is called kangaroo. I don't need to repeat that, but all these components need to be incorporated, because quite often many of the obstetricians were thinking that it is only skin to skin contact. No, it is equally important about the kangaroo nutrition as well, where exclusive breastfeeding we need to incorporate in our program. The kangaroo discharge is another entity whereby we should continue this activity. So what we do, we ask actually the every patient to carry one suit with them, so that when they go back, they will incorporate that particular activity at home also. And the kangaroo support, where all healthcare staff provide support to the mother to take care of her infant in the hospital, and then eventually family supports afterwards when they go home. The binders, there are n number of binders you find, but what we found useful was this, and this was stitched by one of our patient only, and then eventually we give that particular job. That family was having certain issues as far as the economy is concerned, and she's immensely happy that all other actually the hospitals in the city started taking from her these suits, and now she has developed that particular sort of entrepreneurship. The support also incorporates the emotional support. The mother needs encouragement if she has to give the kangaroo mother care. The teaching mothers the skill to take care of the low birth weight, and after discharge, the infant need a regular follow-up as well. Support from the family again doesn't need much emphasis, but again we need to sit with them at least for 2 minutes to explain them how important it is, and that way we can do it. There are n number of opportunities by which we can do it for the community level as well, apart from the facility-based services. You know, we always observe the word prematurity. We see that on every those prematurity day in the year, we sit with our patients, we sit with the crowd, sometimes with the hospital staff and doctors. It is all are actually the people who work under aegis of the ISOPAP, that is Indian Society of Perinatology, whereby we encourage them to conduct such activities where everyone teaches them what need to be done. This is a video which is not running, but which tells how sister is empowered to tell how actually this KMC works to all those parturient mother, and they get very much involved in that. The public awareness is again very important. We need to create a lot of actually articles in the local languages. We know India is blessed with so many dialects and the languages, but what is needed is we'll have to see that every language, every newspaper has this particular news, and accordingly the society at large with one print goes to the maximum people to reach this particular support. So these three actually components we need to emphasize in that as well, and we'll have to tell all those advantages what baby, mother, and even the hospital receives. Now question comes, what are the benefits to the obstetricians? Plenty of benefits actually what we observe. There's a lot of cost saving as well as the better outcomes on the less dependence on the incubators, less nursing staff is necessary, and it shortens the hospital stay as well. There is another challenge which we face about this insurance issue, because you know that nowadays many of our patients, they have the insurance, and whereby they want to have the services to be included in that particular facilities which insurance company gives. But we can incorporate KMC with the help of whatever small actual unit you have, and then we can definitely tell our actual patients to take advantage of that. It improves the moral and quality of the care, and the survival is again very, very better. At large, it gives a lot of benefits to nation as well, because it decreases the neonatal and infant mortality and morbidity. KMC is simple, easily applicable, cost effective, and results in the healthier and more intelligent babies. Now, when we went to Afghanistan, where we have a maximum perinatal mortality, when I took over as a Deputy Secretary General of the FAOPS, I was just searching on the Google, let me have a look where actually the mortality is more. And to my surprise, I realized that the Afghanistan was having a very high actually number of perinatal deaths. And when me and Suki, we went there, we empowered, we incorporated actually KMC in their actually curriculum. It was a great change what we realized from those friends. We need to keep the record of that. Whatever you are doing need to be properly documented and need to be published as well to see that whether this WHO recommendations really gets applicable as well in our day-to-day practice. It has to be given continuously, but again depends from case to case scenario. We cannot apply a rule of thumb, but whenever it is possible, we should try to see that we'll have to extend the period of kangaroo mother care, which is always and always beneficial. Previously, we always used to think that it is only the mother. No, it's definitely the father. Always used to call it the KFC, but yesterday I realized that there's a terminology which says not KFC, but the father kangaroo mother care. And that is again very important because all said and done, the husbands, they get absolutely, you mean to say, excited when we tell them that you'll also take part in the rearing your baby. And to my surprise, I realize it gives a lot of bonding in the family. And that bonding is very, very important because eventually the baby needs to be brought up by the husband as well as the wife. So close family ties, better parenthood, confidence building the children and wife, and humanly approach towards the family is another indirect advantage one can avail when we advise them KMC as well as the father kangaroo mother care. Again, we take the help of all our celebrities. They always help us to do this promotion. Similar is the case with the ventilator support, where whether we should give it, but when I saw the Harish lecture and this new actually changes, yes, now we can definitely think about the mother also going in the NICU and offer the kangaroo mother care. So friends, it's very essential to see that what long back we had declared in the Bogota that it is a basic right of the newborn and should be an integral part of the management of low birth weight and the full-term infants in all settings, at all levels of care and in all communities. So we decided this as well as obstetrician. We have a small group called ISPAT, that is Indian Society of Prenatal Diagnosis and Prenatal Therapy, whereby we got some funding for the 50 plus CMEs, which will be happening over 3 years, and that will be across the nation, whereby we have incorporated important talk of the KMC as well, and the similar initiatives definitely will be taken by all obstetrician groups to see that we support this KMC. So thank you very much, friends, and thanks a lot once again, Dr. Shashivani, for this wonderful opportunity, because I know we are in minority in this crowd, but yes, we are always with you. Rather, we should work together as well. Thank you very much.
Thank you, sir. Sir, that was very nice. I think in next 10 years, we will propose to change the name of the method also.
Thank you. Thank you.
So I would like to invite our next speaker. Dr. Ashma Rana from Nepal, and he is going to take us on the role of obstetrician in promotion of KMC in Nepal. Ma'am is President of Perinatology Association of Nepal, and she is also a past President of Obstetrics and Gynecology Association of Nepal. Over to you, ma'am.
Good afternoon, everybody. I would like to thank Prof. I bring love, lots of love. Where is that? Okay. Good afternoon, everybody. I bring you lots of love from Perinatal Society of Nepal. And Perinatal Society of Nepal, so this is the love. And I would like to thank Professor Bani at the outset for, inviting me, and even my society gives a lot of respect to Professor Bani. And I'm so grateful that she gave me such a topic, the role of obstetricians in promotion of KMC. Actually, it should be globally, but also in Nepal, it's important. And because, there was a zero retrieval from Medline search when I looked for role of obstetrician in promoting kangaroo mother care. Why it was like this? So I feel this is a novel subject which Madam thought was important. Thank you, Madam. But despite of this, there are lots of multi-center studies and collaborative studies running through countries, and we have seen from many papers in the beginning, like Nepal has been a part of, with so many collaborative studies, like Bangladesh and Tanzania, but the role of obstetrician has never been a topic of concern. So I would like to say why we were not, given little bit of importance right from beginning. When we see that, we are with the mother and baby since the first time the mother comes to us. We are connected with the baby, seeing the baby in the fetal heart in the ultrasound at around 8 weeks, and then on first trimester you can hear Doppler, and then that goes up to labor. We are always constantly with mother and her baby which is unborn. See, until the blessed moment of joy, the baby is born by cesarean on one side and vaginal delivery. How active the babies are, so athletic. And look at this another one, even trying to pull everything. That is because of the care of ours. The obstetrician, they are looking always, and pediatricians are getting more, like they are getting so much praises. So role of obstetricians is, what I would like to say, is not just limited to handing over the baby to pediatrician, a healthy baby or a sick baby, but extends beyond helping baby survive, not only survive but thrive, as in context of small and sick newborns and small and sick newborn babies. So what happens? We can anticipate. Obstetrician can anticipate, okay, this mother is going to have baby earlier than the others, which others can't, right, ma'am? And in this way, she can team up in advance, and she can offer readiness. All of us, she or he, even Milind is there also, I should say he also. She or he can, they will have readiness and preparedness to receive preterm, low birth baby, timely informed, teaming up so that the baby gets the better service. So baby needing special assistance and care are cured in NICU, and we have one hospital set up. The first doctor is Sunil Raja Manandar. He told me to use this slide. And they are also managed in intensive care unit, and in Nepal, still their kangaroo mother care is being done inside the NICU also. But what happens to the majority of newborn, They really do not need pediatrician such a lot, but they need more of obstetrician, because the preterm, the incidence is 6 to 10%, somewhere 13%. One paper said that the IUG are growth restricted baby or low birth weight baby in the morning conference was up to 36%. That means, say 1/3. But 2/3 babies are healthy ones which are under our care, obstetrician's care, and they remain in the postpartum unit as you see in the picture. But what do you see here? Do you see this is a cesarean room of my hospital, and how much overcrowding it is. Look at the situation. So husband, sleepers, people on the floor. This type of situation you see in many of the low-resource country, not only Nepal. So see, when there is no room, the relatives are handling baby, and they are just in the place where the junior doctors usually make discharge. So infrastructure, obstetricians should have a big role if she is a head of unit, not only head of unit, she's a head of the department, or she's a director of the hospital. So space is the important problem, and postpartum ward is very important, crucial. Look at this baby also is coming there. So we need a spatial area for provision and practice of kangaroo mother care. And you see, we saw that some the advanced hospital, they have so many neat things, such a nice mother and baby unit also in NICU. But let's start with the kangaroo mother care in a small setting in the hospital. And there are these that are there, but what I would like to say, it is not, or emphasize, it's not universally present. You know, it will be in few hospitals. Say, suppose if Nepal has, say, 160 hospital, it will be in 10, 20 hospital, or say 30 hospital. So it won't be everywhere. So our motto is to make it available at every hospital, then only the care comes. So in this regard, what as an obstetrician, I would like to feel that I would like to play some role that preterm baby is less, you know, and also the growth restricted ones are also less, so that, you know, we don't have so much stress of mind looking after them. But nature has its own say. Sometimes they are born preterm. And when this challenge comes, role of obstetrician is that if we are going to promote KMC, we have to do it properly, in a proper way. So supervision comes for the first thing. Ensure KMC is correctly practiced and adopted. Just don't say it's KMC and somebody is coming doing like that. It is not allowed. So it should be done properly for the best effect. And Nepal has made one, you know, wrap with the Jipaigo. This is called Nyano Jola or Nyano Angalo. And the other role I would like to say that, you know, we say like you kangaroo mother care, you know, somebody in the morning, I was so attentively listening, the chances of DVT, mother sitting in a chair, semi-reclined position, so many hours, you know. So she is also a human being, you know. She will be stressed, she will be very tedious and tiring moment for a continued commitment and restricted mobility. So she'll get into depression. So our role as an obstetrician is, don't you think our role is so much? We can get mother to educate her, build her confidence, and support mother plus family, because they are known to us right from the first day of antenatal care, from 8 weeks of pregnancy till the delivery. Okay, she's been with us. So we can educate, do all this, and make her cope up with KMC. That is one. I didn't see much of literature, so it's my own way. I just felt that it is our role as an obstetrician to make the mother cope up with KMC, the tiring business, the tiredness to, you know, when the baby comes, the main name goes to the father, family, not to mother. In our country, the child is born, the name of the child will definitely have father's bearing. So we'll have to pacify mother to ameliorating her deleterious effect of, you know, like to cope with KMC, tiresome business. So to help promoter, and also, you know, this might, if you make her cope with KMC, then maybe we can help her to promote maternal bonding with the baby also. These have come fresh from 2 studies. So kangaroo mother care, at the end I say, in Nepali we say Maya ko angalo, that is a loving embrace, and skin to skin, I think chest to chest contact is what Dr. Bani said, mentioned. So we all know the kangaroo mother care has proven benefit in the middle line since 1988. So what should we do? We have to, obstetrician shouldn't only come to the conference, we should go from fest to the center, to the peripheral village area in different parts of Nepal. And saying this, there was one paper I saw. Most of the papers on kangaroo mother care from Nepal are published by pediatrician, less are published by obstetrician. And one paper said that out of the 12 hospitals, 7 of the hospitals, they didn't have kangaroo mother care. So that tells us our responsibility is so much. So if we go hand in hand with pediatrician, neonatologist, the role of obstetricians looks very vital. Then maybe out of 12 to 12, every hospital will have a kangaroo mother care. So with this, I would like to thank so much.
So much, madam. So now I think we can invite few questions for whole of this session. No time for question? Okay.
So there is one information for all of you. Our perinatal society is going to hold FA-OPS in 2025, November 14 to 16. I would like to welcome you and invite you for this conference because most of the people want to come to Nepal, I think.
Yeah. You showed so beautiful pictures over here. Oh.
Thank you all speakers and the chairperson. We invite them to have a quick photograph. All on the dais. All the speakers and the chairperson on the Dr. Srinivas Murki, Dr. Kumutha, Dr. Mangal Bharti, Dr. Milind Shah, Dr. Ashna Rana. Next session. So let us move to the next session for the most interesting of all, recent KMC studies by young researchers by Dr. Ravi Parikh. I will invite sir on the stage. Dr. Ravi Parikh is MD, MRCP Consultant Neonatology UK, Neonatal Intensivist and Neonatal Eco Trainer, Founder Trustee of KMC Foundation, India. Welcome, sir.
Thank you, Curie, for the nice invitation. I would like to first invite Dr. Rekha Udani Madam and Dr. Ruchi Nanavati Madam, who are our esteemed judges for the oral presentation. You can sit. You can sit there, Madam. So this time we got a very varied presentation of all the papers, lot of papers, almost 20 papers we got it, and it was so much variation, right from the first year resident, second year resident, DPED student, MD student, obstetrician, nurses, everybody has contributed to the papers in this Kangaroo Mother Care Conference, and I'm very happy for that. So now we will start with the first 3 papers for the doctors category and the second 3 papers for the nurses category. And I'm pleased to tell that there is a first prize award for in each category, doctor category and the nurses category. So first paper, please. The first one is Observations, Beliefs and Sciences of Obstetrician on Kangaroo Mother Care. The first one is Observations, Beliefs and Sciences of Obstetricians on Kangaroo Mother Care.
Good afternoon to one and all present here. I'm Aishwarya Karthik, and I will be presenting my study right in accordance with the previous two lectures, the OBS in KMC, which translates into the observations, the beliefs, and science amongst obstetricians in kangaroo mother care. We all know that kangaroo mother care is the cornerstone in neonatology, which is why we're all here today. However, being an obstetrician myself, I find that the role that an obstetrician has to play in KMC is a very niche area that is very lightly touched upon so far. Like Dr. Milind and Dr. Ashma said, the obstetrician has a monumental role to play in KMC, as they do in other neonatal outcomes like breastfeeding, survival, etc. However, I find from personal experience as well that the awareness, the in-depth knowledge, and the interest is quite limited. Now, with the advent of the immediate KMC, the role of an obstetrician becomes even more prominent. Therefore, there is a pressing need to address these lacunae as well as simultaneously achieve a rapid scale-up of KMC as well as IKMC. The primary goals of our study was to obtain insights into the knowledge and attitudes of obstetricians towards KMC, to determine their practices in its implementation and to identify their role in it. We carried out a cross-sectional study in the form of a survey using an online platform, Google Forms, with a survey tool supporter. Our study population included obstetric healthcare specialists, those in training and otherwise, and institutional ethics committee approval and informed consent were taken. Our survey included 38 questions pertaining to demography, questions related to obstetric practice, and observations, beliefs, and science of KMC. This was validated by 6 experts using the Delphi method. We then disseminated our survey through private links initially. However, we found that the response was quite poor. So then we approached FOGSI, which is the Federation of Obstetric and Gynecological Societies of India, and our survey was then sent as a text message with a link to over 40,000 participants. The survey was also kept open for a period of 6 months. We performed a descriptive statistical analysis wherein the categorical variables were reported as frequency and percentage. We also graded each answer, wherein we allocated each option a certain weightage and used this to create a scoring system using the partial credit model and the Jenks break classification, and classified this score into a low, moderate, and a high score. We also tried to find associations between age, location of practice, and this score by using the non-parametric Wilcoxon sign rank test, wherein the level of significance was set at 5%. Although our survey was sent out to over 40,000 participants, only 222 managed to open the link, and 215 consented while 7 did not, and only 215 completed the survey finally. Most of our study participants involved females, especially between the age group ranged between 30 and 40 years. 43% of our participants had less than 5 years of experience, and most were based in tertiary care centers and in private hospitals. As you can see here, over 90% of our study population undertook the delivery of preterm babies. However, most of them delivered less than 50 in a month. When we asked our participants whether the institutions were equipped with a KMC ward, 35% answered no. However, 78% of our study participants stated that their institutions had a KMC policy in place. When it came to the science of KMC, we found that while majority of our study participants knew the significance of reduction of neonatal mortality by KMC, the extent to which it was reduced was less known. Also, as per the older guidelines, where KMC was established after stabilization, was what was most of their opinions as opposed to immediate KMC. While most of our study participants agreed that the father can also be a KMC caregiver, more than half of our study participants were quite uncertain about who else could be a KMC caregiver. Regarding the observations of KMC, I'd like to highlight that 70% of our study participants stated that they practiced immediate KMC in their institution, which sort of highlights that there is still a confusion between skin-to-skin contact versus KMC. While most of our participants also stated that they do counsel patients antenatally regarding the initiation of KMC and the benefits, there is a significant 16% who state that they would prefer to leave it to the neonatologist to do the counseling entirely. and only 53% inquire about feeding and KMC practices on a routine postnatal follow-up. Again, while most 74% encourage mothers to stay in the hospital for the entire duration of the baby's admission, there is a significant 26% that also do not actively encourage the same. 65% stated that more than 90% of their low birth weight babies were exclusively breastfed before discharge. However, this remaining 35% is significant, that again emphasizes that breastfeeding support for low birth weight babies is absolutely essential. And as mentioned here, KMC being a tool to improve lactation was severely underutilized. Our section on the beliefs of KMC gave a more positive response, wherein our participants most of our participants agreed that women as well as their relatives must be counseled antenatally regarding KMC as well as its benefits, and most of them were very eager to incorporate KMC training into the postgraduate curriculum of OBG as well as pediatrics. Also, most of our participants also stated that they would like to attend more workshops and like to gather most of their information even by addressals from a neonatologist directly. This is our scoring system that we had made. We noted that in the science and observation sections, most of our participants scored a moderate score, while in the beliefs and attitudes section, they scored a higher score. We tried to form an association between the location of setup of practice, that is rural versus urban and secondary versus tertiary centers, and the score that they and what they scored on the survey. However, there was no association. However, there was a significant association between age and the score that they for example, those aged more than 60 years fared a better score on the survey. We found that the obstetricians' knowledge and practices were moderately good, and their attitudes were, with respect to KMC, were very good. The global position paper and the implementation strategy for scale-up of KMC also shows a pivotal role of an obstetrician, therefore reiterating the close association between the two fields. Our strengths were that we are probably one of the first studies to address and bring in the role of KMC, of an obstetrician in KMC. And although we reached out to over 40,000 participants, only 215 responded, and this small sample size therefore reduced the internal consistency and reliability of our survey, which raises an important point that awareness and interest among obstetricians is limited, therefore emphasizing the need for a collaboration even more. In conclusion, I'd like to say that obstetricians do have a moderately good knowledge on the science and practices and very good beliefs and attitudes towards it. Therefore, it is time to harness this and join hands together with an obstetrician and consciously make an effort to incorporate KMC into the curriculum, pre-service and in-service training of obstetricians as well, as a close collaboration for implementing KMC is the need of the hour to support every woman and her right to a healthy low birth weight baby. These are my disclosures and conflicts of interest. Thank you so much to the organizers for for giving me an opportunity to present at this conference. Thank you all for a patient hearing.
Thank you. It was very nicely done. Over to the questions. Questions together, yeah? Okay. So second presentation. Exploring the perception, sorry. Question. Yeah, okay.
Yeah, Aishwarya, thank you for, it is a very nice topic, and thank you for conducting this research.
Thank you, ma'am.
First I want to know that the response, you addressed it as a limitation, but response from the obstetrics, 215 out of 40,000 is very, very low.
Yes.
So is the, the way obstetricians look at KMC, do you think that has affected the response?
No, ma'am, I don't
Did you try to find out why was there such a poor response?
Ma'am, when we had sent it out as private links initially, most of them responded saying that they were very busy to look at it and they would do it later, and they actually sort of forgot. So we had sent the message 2 or 3 times. But when we went through Foxy, we had probably sent only one message. Maybe we should have done it a few more times in order to gauge a better response.
Yeah. Because generally for questionnaire based studies, one would get response about, say, 50%, 45 to 55% at least. Here the response is very poor. That is one thing. Yes. Second is, in spite of this, and even the percentage of whatever are the effects of KMC and how they are practicing KMC is not very satisfactory. Yes. So do you say that attitude of obstetricians is good for KMC?
I feel like the attitudes are good. On a more personal note, I would like to say that when I started practicing KMC as a postgraduate, I also was not aware of the extent of how powerful a tool it was. For example, all of us knew that okay, this reduces mortality, but when I found out that it reduces mortality by 40%, I was totally blown away by how powerful and simple a tool it was to really practice. So I think that awareness is lacking, and I feel like maybe if we just sort of reiterate and emphasize on these aspects of it, maybe we can increase their make their attitudes even better in practicing.
Yeah. And the last question is, of course, following your study and looking at the results, what is your next plan?
I feel like it can start off even as small as a small perinatology meeting in our own respective hospitals. If we can just bring this about, most of our hospitals have perinatology meetings every month. Maybe if you can devote even a few minutes, 5 to 10 minutes of KMC and bringing about awareness, then automatically it will start. And as per the history of KMC, it started in hospitals first and then went out to the community. So if we can go along the same route, then I think that would be a good option.
Okay, thank you.
Thank you.
I think in Bangalore, KMC was started long back.
Yes, ma'am.
Right? At least I would say about 20 years.
Yes.
And then always we think that there has to be a connection between the obstetrician and neonatologist, right?
Yes, ma'am, definitely.
So in that case also, you have been sending 40,000 all over India. Then also very little response you've got.
Yes, ma'am.
So really you need to do something with the obstetrician, which you have said, but really very emphatically and very quickly.
Yes, ma'am,
because
absolutely.
we need to scale up, and if we don't scale up, then what?
Yes, ma'am, absolutely. Even today, I was surprised that only 3 or 4 obstetricians were in the audience. Maybe if we can actively encourage them to participate in events like these, then it would make a difference. Thank you.
So second presentation is on improving early initiation of skin-to-skin contact and breastfeeding among newborn delivered vaginally at a tertiary care hospital, a quality improvement study. Dr. Anil.
Good afternoon, everyone. I am Dr. Anil. I will be presenting my paper on improving early initiation of breastfeeding and skin-to-skin among newborns delivered at our hospital, a quality improvement study. So neonatal mortality is a major contributor for under 5 mortality, contributing up to 40%. WHO and UNICEF together recommends essential newborn care, which includes thermal regulation, early initiation of breastfeeding, and cord care. Thermal regulation, skin-to-skin forms a key pillar. So WHO recommends same that every newborn should be given breastfeeding and put on skin-to-skin within 1 hour after delivery. So as per studies, linear relationship is found between risk of mortality and early initiation of breastfeeding and skin-to-skin. Those babies who received breastfeeding between 2nd and 23 hour of life had 33% increased risk of mortality and those who were fed after 24 hours had 2.19-fold increase in mortality compared to those who were fed within 1 hour. And in India, it is noted that 42.7% baby receive breastfeeding and only 15% receive skin-to-skin within 1 hour. And at our institute, we noticed only 61% of stable vaginally delivered babies received breastfeeding and 22% received skin-to-skin within 1 hour. So we planned a quality improvement study using point of care quality improvement model. Objective was to increase the early initiation of breastfeeding and skin-to-skin practice in a vaginally delivered stable newborns at or above 36 weeks of gestation from a baseline to over 85% over the 3-month period. So duration was 3 months from between December to February, and the sustenance phase was conducted between April to June. Place of study was labor room of our tertiary care hospital. We had received approval from the Institute Ethics Committee for the study. We had included all stable newborns born through vaginal delivery more than at 36 weeks of gestation and excluded those with congenital anomalies, gastrointestinal malformations, those hemodynamically unstable requiring NICU, and those whose mother were unstable or in whom breastfeeding was contraindicated. So baseline assessment was done during the month of September over a period of 4 weeks, where we collected data from medical notes and entered those data in a pre-designed Excel form. From this, we did a root cause analysis to know the barriers for inhibition of skin-to-skin and early initiation of breastfeeding. This is what we found out. In policy, there was no focused guideline for routine immediate care. Though the policy was there, it was not focused on early initiation of breastfeeding and skin-to-skin, and there was no communication of policy between the staff. And there was also misconception that mothers won't get the feed initially, and also to initiate the feed only once the mother has been shifted to ward. There was lack of separate room and overcrowding, so lack of privacy. There was no written SOP to carry out routine care, and also mothers were not aware of this practice. So based on this causes, we started the PDSA cycles. In the first cycle, we modified the policy which was existing, emphasizing more on immediate newborn care, that is early initiation of breastfeeding and skin to skin, and we sensitized the stakeholders regarding this policy. The policy was pasted in the delivery room, and also fortnightly meeting was conducted to educate the stakeholders. Through this, we saw improvement in skin-to-skin contact from baseline of 22.2% to 47%, and early initiation improved up to 71%. The timings was first initiation of breastfeeding was 48 minutes. But we observed that there was lack of clarity among the staff, and also new residents were not aware of the policy. So in the next cycle, we conducted regular meetings regarding sensitization, and also we started documenting the duration of skin to skin and early initiation of breastfeeding timings in the case sheets. Same thing was told to the staff nurses, and handover was given by labor room nurses to the ward nurses, so that the awareness spreads. And through this, we found out that skin to skin coverage improved to 92% and early initiation of breastfeeding to 100%. But here we observed that few mothers were hesitant and relatives were confused regarding the practice. So we involved relatives and mother in the next cycle through antenatal counseling, where the mothers were counseled regarding benefits of early initiation of breastfeeding and skin to skin. And we observed the skin to skin contact coverage improved to 100%, and early initiation of breastfeeding also improved to 100%. And it is also noted that the duration of skin to skin also improved to 21 minutes, and the first feed was given at 38 minutes. So this practice was continued, and we didn't intervene for 1 month, and then we started monitoring for the sustenance. In the sustenance phase also, we observed that skin to skin contact compliance was maintained at 100%, similar to early initiation of breastfeeding, and the duration of skin to skin was at 30 minutes, and time of first feed was within at 32 minutes. So this is the run chart showing the compliance percentage of early initiation of breastfeeding and skin to skin over a study period. This is the initial time of initiation of breastfeeding. Blue line shows the trend over the study period, and the red line is the mean line. Gradual fall in the time for early initiation of breastfeeding is seen. And this is regarding the duration of skin to skin. There is gradual increase in duration of skin to skin over the study period. Similarly, here blue line shows the trend in each phase, and red line is the mean line. So through this study, we were able to improve skin to skin and early initiation of breastfeeding through PDSA cycle. Initially, there was hesitancy among the healthcare staff to follow the new idea, as with any change in practice, but gradually everyone adapted to it well. This quality improvement model enabled us to observe and extract information from obstetrician, nursing staff, helping staff, thus involving multiple personnels and delivering the overall care rather than focusing on single point of view. In this way, everybody felt empowered to be the part of team and enabled to integrate the change in the existing practice, resulting in sustainability. Similar studies were conducted in New Delhi, where it was observed that from 0 to skin-to-skin contact compliance from 0 to 56% was observed over a period of 36 months. Another study in Madhya Pradesh also showed in early initiation of breastfeeding compliance increased from 21 to 36.7% over a period of 13 days. Here, the compliance improvement was not up to the mark, and the reasons could be less time given for a PDSA cycle, and more training was needed among the members, lack of communication among the team members. These were stated by the authors themselves. And counseling of parents and family formed a vital role in our study. This was observed in another study done in Karnataka, Bangalore, where it showed third trimester counseling of mothers and relatives regarding early initiation of breastfeeding and its benefits led to improvement in compliance more than the national standards. So limitations of this study were, we didn't include cesarean deliveries, which may offer more difficulty in implementing the changes. Nevertheless, some of the measures taken here can be applied in cesarean deliveries too. And also, we did not include stable preterm babies, which could pose unique challenges in process implementation. As a conclusion, this study brought out various hurdles to early initiation of breastfeeding and skin to skin, and vital areas of improvement noted were related to gaps in knowledge of the caregivers, individual ideas about the practice, and immediate postpartum care. This study demonstrated that the practice of early initiation of breastfeeding and skin to skin can be improved using simple quality improvement model, and it did not require any additional resources and had simple methods, hence it may be used for other resource limited setups too. Thank you.
How many numbers of in each PDSA you've done?
Yes, ma'am.
Each section, how many babies were involved?
25 to 30, ma'am. It was like between 25 to 30 in each phase, and sustenance phase had 30 babies in that.
Is it okay, then first PDSA it is 25, then it is second one PDSA, how many babies?
Actually, in second PDSA, numbers were 11 in 12 in skin to skin and 13 in early initiation.
Enough to really call for that it is 100% you got the results?
Based on the similar number only, we had conducted the baseline assessment, ma'am. In that also we received overall coverage of 42%. So it was a alarm for us to improve the, to do something to improve this status. Even with lesser number of patients, we were not able to achieve that 100% goal. So this is what led us to start the quality improvement project in our NICU.
Again, a very nice study and much required study, and all of us know that, we have limitations, though these practices are well evidence-based. So I just want to know that, how much was the duration of skin-to-skin contact you could do it once you started soon after birth? How much was the duration?
Initially, it was around 17 to 18 minutes, ma'am. Gradually, as the PDSA cycle, we went through it, and by the time of sustenance phase, we reached up to 32 minutes.
Okay, that is one. And second, this thing is that how do you plan to work for sustainability? Because in your own study, you have seen that during second or third PDSA cycle, the percentage has come down. So how do you, always a problem with quality initiative studies is the sustainability. So how do you plan to resolve it?
Main thing for sustainability is if we do a new idea or if we put a new idea, usually there is a hesitancy among the practitioners to follow that new rule.
So how do you come over it?
So it is like really, we have included such as steps that it is carried out on a daily basis so that it becomes a practice. Once it becomes a practice, then it will be easier for the obstetricians or the gynecology or pediatric residents to follow that once it is a practice. Otherwise, this we have observed through our study that once it was in phase 3 of PDSA and once it was in sustenance phase, without any inputs, extra inputs, the practice was going on. Because daily they were writing notes regarding early initiation of breastfeeding, daily they were writing notes regarding the duration of skin to skin, and then they were counseling the mothers. So it was like, it had become the daily routine for them. So
as compared to the number of deliveries at your institution, in how much percentage you could achieve this?
Ma'am, we had included every newborn born at or above 36 weeks of gestation through vaginal delivery, and all the during the study period, how much ever deliveries have happened, we had included in this.
So you
so
had
there
this
is no
11
dropout.
or 12 babies in how much period?
That was in 4 weeks.
4 days?
4 weeks.
4 weeks?
Yes.
So in 4 weeks you had only 11 babies?
Since it's a tertiary care, we have
Most
more
of
of
them are LSCs.
complicated cases or unstable newborns like that, ma'am. So those newborns at or above
So
36
stable
weeks
babies
were
delivered
less.
after 36 weeks by vaginal delivery were about 11 to 12?
12, yes, ma'am.
Okay, thank you.
Thank you very much. So our next presenter is Dr. Divya Waghela. Her topic is exploring the perception and practice of kangaroo mother care at home and its effect on growth parameters of low birth weight babies receiving home kangaroo mother care. So quite a variation in topics. So one obstetrician, one tertiary care and one home-based KMC. So very nice
Good afternoon. Good afternoon. Myself, Dr. Divya. My topic is exploring the perception and practice of kangaroo mother care at home and its effect on growth parameter of low birth weight baby receiving at home-based kangaroo mother care. Introduction. Kangaroo mother care is the base form of multimodal stimulation on kangaroo mother care is the best form of multimodal stimulation that satisfies the core principle of the neurodevelopment with also prevent the hypothermia and management of the hypothermia. In our India, like low income country, low birth weight baby are discharged when patient is stabilized and hemodynamically stabilized and adequately taking feeding well. And on the KMC, all the literature was mostly done on hospital-based study, and there is a paucity of study on literature on KMC in a community setting, and that is home-based kangaroo mother care. The purpose of our studies was that to explore the all dimension like enable barrier to implementation of home-based kangaroo mother care and outcome analysis like growth parameter, low birth weight, that is length, weight, and head circumference. Aim of study is implementation of home-based kangaroo mother care. Objective is to observe growth parameter, weight, hair circumference, and length, that to explore the feasibility and acceptability of KMC by evaluating enable and barrier. Material and method. On sample side, total 180 mother and baby died was including study, and in our study, less than 2.2 kg baby was discharged in our government hospital. In EMNICU and IMICU was included, and patient was excluded in criteria which is unwilling for taking participation and congenital malformation with neurological sequence like birth asphyxia. Outcome measurement like gain in growth parameter like weight, head circumference, and length. Methodology, all the low birth weight baby, which is weight is less than 2.2 kg, which was stabilized and stabilized after wo baby requires respiratory support like mechanical ventilation. After stabilization, KMC counseling was done. KMC duration charting and growth monitoring duration during hospital stay, and continue growth monitoring with the counseling done on mother with the continue counseling done on discharge. KMC package was explained and diary was given for KMC charting. Follow up through audio call on day 3rd after discharge with the problem solving about the KMC during home based care, and weekly follow up 4 weeks for growth monitoring. There is some picture about the counseling and explain the KMC and discharge diary about the KMC charting. Statistic analysis, there is two type of quantitative analysis based on the growth parameter and quality based on the depth interview during follow-up and during other WhatsApp and other detailed evaluation during KMC counseling. Demographic data stratify accordingly gestation weight, gestation age of the baby, and other methodology. Total 180 mother and baby died discharged. Their weight is less than 2.2 kg. On first visit, 175 was patient was attend, and on first week 180 continued, and on subsequent 158 was attend on second visit, in which total more than 14 baby was gaining weight more than 2.5 gram. 2.5 kg, and on third subsequent visit 132 was attained, and among them 106 continued KMC. Among that 32 baby weight gain more than 2.5 kg. Consecutively fourth visit of 74 mother continued KMC at home, and among them 39 baby weight gaining more than 2.5 kg. There is a demonstration of follow-up data of KMC at home, which show the increase the weight of the baby, and result that show the consecutive weight gain and increase head circumference and length of the baby. Uh, Patient during a KMC correlation of mother parity and average KMC hour, which show that the primary para is more convenient and more giving KMC with the during feeding practice during a discharge after follow-up and breastfeeding. Initially on first visit, patient on breastfeeding with case and on the subsequent visit on fourth follow-up, there is a exclusive increase the breastfeeding and patient on exclusively breastfeeding will decrease the case feeding. And other patient on a continue KMC counseling with the interview, there is a enabled data and barrier according to KMC. Enabled data, there is a motivated by family counseling, KMC during hospital stay, and other KMC by other mother, family support during KMC at home-based care, and barrier other, that is household work, privacy, hot weather, uncomfortable on sick mother, lack of motivation, baby felt uncomfortable in KMC, baby cry in KMC, no family support, or fear of handling small baby. Conclusion that with the comprehensive KMC package counseling, supervise on follow-up, utilize social media like WhatsApp for hand-holding, and including Anganwadi worker and other field worker for KMC counseling and monitoring. And there is exclusive breastfeeding was sustained and prevent during KMC counseling and KMC at home-based care. There is prevent the extra uterine growth restriction and limitation of that for design community program to promote home-based KMC. We require multimodal study detail analysis of enable and barrier, and geographic area has different culture and community practice, has different enable and barrier. Recommendation home KMC for low birth weight baby must be part of community health program to decrease the neonatal morbidity and mortality to prevent extra uterine growth retardation. Thank you.
It is really something which you have done where home KMC you have started, which is a good thing. But at the same time, you have trained all the whoever had gone for the visit of this.
Yes, ma'am.
Yeah, and you had said that you had measured weight and head circumference. So all that is not mentioned in this, is it? It was your aim, I think so.
Yes, ma'am.
Yeah, then you have not given the conclusion in that.
Ma'am,
Another thing, how many hours KMC you have shown even the chart also?
Yes, ma'am.
That you have given hours of KMC duration, then breastfeeding, but all that is not mentioned in your conclusion, is it? But anyway, whatever you have done, at least you have tried to look at home-based KMC, because still it is not really working everywhere. But at the same time, we need to really do something about it.
Yes, ma'am.
Yes, ma'am. This one not. Yeah, again, nicely and much required study. What I want to know that your title says the perception of kangaroo mother care. So, how did you study perception, because it has not come in your paper? Means you have studied the perception of kangaroo mother care amongst mothers or family members.
Yes, ma'am.
But you have not shown that data of perception. Most of the data is of practice of kangaroo mother care. So, do you have any data on perception of kangaroo mother care?
I haven't know any data, but during we are on hospital-based setup under guidelines of doctor and staff nurse. There is a established KMC, and there is a very good weight. That is 20 to 15 gram per day. Weight gain is achieved. But
perception. Okay, fine. My second question is, what was the average duration of KMC at home? Under the supervision of Ashas, how much was the duration of KMC?
Ma'am, there is a 5 to 6 hours per day.
And who was the main KMC provider?
Ma'am, ma'am, mother is main KMC provider, but other ma'am, Ma'am,
So did the family members help her, and who other than the mother was a KMC provider?
Ma'am,
Because that will help us in for implementation
ma'am,
of
father
KMC.
or other grandmother
No,
also.
no, no. As per your study, what did it show? Not generally who can provide. In the study, did
Yes.
you find out who else provide KMC?
Ma'am, most of grandmother.
No, do you have that data?
Ma'am, mostly grandmother and mother also
Okay,
provide.
fine. Okay, and the third is that, your one of the slides said that KMC in the hospital was 6%. Only 12 babies had received KMC at home. KMC in the hospital. So why was a less percentage of KMC in the hospital? No, no, not here. In your results it is. Next. Next, somewhere. Next. See, this is 6%. Go back. See, KMC during hospital stay is 12 babies out of 180, and that is 6%. So how do you explain this?
Ma'am, in mostly in extramural NICU, there is a patient or tertiary care center, mostly patient present with the severe birth asphyxia with the respiratory distress with the mechanisms and aspiration. So mostly patient on respiratory support. Then patient, which patient low birth weight, that patient early establishment of breastfeeding and KMC was given. So after that, home-based KMC is most.
Thank you very much.
Thank you very much.
So, our next presentation is from the nursing category. The first one is enhancing community kangaroo mother care implementation, insights from the healthcare workers.
Good afternoon, all dignitaries. Myself, Silvarajan, representing Health and Family Welfare Training Center, Gandhigram, Tamil Nadu. The title of the study is about the enhancing the community kangaroo mother care implementation, insights from the healthcare workers. The objectives of the study is to assess the knowledge of the healthcare workers and community workers with regard to KMC and the importance of the implementation of the KMC at community level, and also to identify the barriers encountered by the healthcare workers in effective implementation of the community KMC. So this is the practice which we are practicing as of now. So the vulnerable newborn child, the grade 3 child admitted in the SNCU, step down ward to grade 2 and grade 1, and after that they will be discharged. And here starts the community level KMC, which is to be taken care of by the VHNs and Anganwadi workers. So the study design was about the qualitative research methods with a focus on focus group discussion for data collection. Study participants, it's about public health staff, village health nurses and staff nurses, and from nutritional department we have the Anganwadi workers. So from NGO side we have the community workers. Totally 68 participants were included in this participant. The sampling techniques was purposive sampling techniques, rural, urban and semi-urban were taken to these studies, and study period spanning from April 23 to September 23. The data collection method, it's through focus group discussion. The data was collected, and the interview guides for the target population were designed by the research team with covering the following topics: the perception of KMC, about the KMC and KMC practices, and regarding the barriers to KMC implementation at community level, proposed strategies to improve the performance. Initially, this was piloted in a small sample, and pre-tested guides were finalized. So ethical clearance, we have obtained the ethical clearance from our institute research advisory committee. Then participants' consent were received. Totally 10 numbers of GDs were conducted. Interview was recorded in local vernacular language. It's about 45 to 60 minutes in Tamil language. So data analysis, verbatim transcription was done. Thematic analysis was performed, and By adopting the deductive approach method, the researchers independently each transcript several times to identify the theme. So review data was uploaded in the in vivo software using thematic coding techniques. The emerging themes related to barriers faced by the health workers were identified and categorized. So the results and proposed strategies regarding the characteristics of the participants, we have the three groups. From the public health side, we have the village health nurses and staff nurses. There are about 12 numbers of VHNs and 18 numbers of staff nurses were included in this study. Their mean age is about 37 and 26. From the ICDS department, we have the Anganwadi workers. It's about 24 numbers were included in the study. We have conducted 3 FGDs for them. So the mean age was, it's about 37. For the NGO community workers, it's about 14 numbers. The mean age of community workers is about 32. Regarding the duration of MCH experience for these participants, for VHNs it's about 18 years, and staff nurses it's about 6 years. And for ICDS workers, Anganwadi workers, it's about 12 years, and for the NGO community workers, it's about 9 years. Regarding the theme 1, the healthcare providers' perception about the KMC, they said they are aware of the KMC practices and they know about it is to improve the health status of the low birth babies, but it is difficult to implement at community level. So one of the health workers said it is doing KMC at community level does not cost much, but it is easy to learn, but implementation is little bit difficult in the community. Then role of healthcare workers in implementation of KMC. So implementation of CKMC is one of the role they have told, and also education of the father and mother is also one of the role they have identified, and also the demonstration and supervision of the KMC by the healthcare workers also one of their role. And regarding the theme 3, it's the obstructions in KMC, they said no hands-on, that's exclusive KMC training was not given to them. So only in the half an hour oral session was only handled during the training which we have imparted to them, like IMNC training and NSSK and integrated refresher training. Only the half an hour oral sessions was given to them. No exclusive KMC training was, hands-on skill training was not given to them. That was the statement they have told during this FGD. And also regarding the infrastructure and resource constraints, they said that they need to improve the facilities in HSC and Anganwadi centers to establish the KMC practices. Also, there is no KMC chairs available as that of in the facility in the SNCU. Regarding the cultural and social norms, it is not possible to implement the KMC practice in their villages due to their misbelief. And the further KMC yet to be accepted by the family. So difficult to change the mindset of elder people for the KMC practices. One of the ICDS workers said, elder people in the family are not allowing us to do the KMC at home based due to the myths and misbeliefs and the cultural misbeliefs they have. Regarding the workload and time constraints, even the healthcare workers and also the ICDS workers are maintaining the many numbers of registers both manually and in online. So even in public health system, VHNs are looking after the many special programs like MRMBS and also distribution of delivery kit and home visits. So despite of all these number of registers to be maintained, so the time constraints is there to look after the community, implementing the KMC at community level. And also the post of the VHNs and Anganwadi workers are vacant in many places. So one VHNs one Anganwadi workers looking after 2 or 3 centers. So it is also their inability to do properly the community level KMC in their area. So regarding the mother's geographical mobility, it's a very interesting one. The mother is getting registered in a husband area, and the mother is moved to their mother area for the delivery. So tracking is a little bit difficult, even though the tracking system is available. It is very difficult to track the mothers to give their follow-up activities. So this is one of the very difficult thing to give the follow-up services to the mothers. So even though visitor syndrome is available, it is very difficult to follow. So conclusions. So totally we have identified these are all some barriers, lack of hands-on skill. So exclusive skill training programs has to be given to the healthcare workers and also to the ICDS workers. Limited training and resources, only the half an hour to 1 hour classes are included in the syllabus of the ongoing training. So separate training for the KMC, exclusive for the field workers has to be given. Then cultural resistance like misbeliefs and myths has to be deleted from the by conducting the awareness campaigns like marathon run, walk, etc. Then regarding the infrastructure at community level, improved infrastructure facility at PSC Anganwadi center has to be given, and based on these things, the impact and benefits what we have to get. So the intact survival of the vulnerable newborns will be achieved. Thank you.
You are trying to find out about how much is the knowledge and what are the problems in those nurses or whatever the community health workers.
Thank you, ma'am.
But that is a good thing. But at the same time, you have mentioned about whatever the results that they did know this, that. What about breastfeeding? Is it included in this to find out?
No, we have not included in that.
Because always kangaroo mother care and
Yes,
breastfeeding go together. So this was one thing, and
it has to be included. Yes, ma'am.
I just looked behind. So, yeah, a nice study and much required study. Tell us, what do you plan to do further?
Yeah,
Means you have said enhancement of this. So what is your plan after this study?
Yeah, because I am coming from the background of the training center. So we have to give the exclusive training program to the healthcare workers and to the Anganwadi workers. That has to be given immediately with the help of the government policies.
Yeah, okay, thank you.
Thanks a lot, ma'am. Thanks a lot.
So the next presentation is Father Kangaroo Care, a qualitative exploration of facilitators and challenges at the facility and continuum in the community. So our second presentation is evaluate the efficacy of need-based strategies of kangaroo mother care among parents of low birth weight child.
First of all, I would like to thanks to the team of KMC Care Foundation for organizing such wonderful conference and providing the opportunity to nurses to present in front of all the doctors. So it's my privilege to present here my research paper. Title of the study: Evaluate the efficacy of need-based strategy of kangaroo mother care among parents of low birth weight child. Introduction. WHO estimate that the 25 million babies who have less than weight, they are the LBWs, are delivered every year, comprising of 17% total live birth globally, and estimate that 16 to 18% babies born in developing countries are LBWs, having a low birth weight that is less than 2.5 kg, and KMC instead of standard incubator care, the marsupial care especially important when caring LBW newborn in low income countries like India and other countries, where frequently excessive death ratio in hospitals occurs day by day. So to decrease that, the figure of LBW neonate death in hospital because of no incubators,
that can be reduced with effective kangaroo mother care. So with that, the researcher found that to have increase the, give the knowledge to the parents, low birth weight children to improve the life of the child. Okay. So for that, the researcher view to help the parents to low birth weight babies by giving awareness, demonstrate the procedures so parents can assist the babies easily and lead to healthy life. So objective of my study was to assess the need of parents of low birth weight child related to kangaroo mother care, to design and develop the customized awareness program on KMC among parents of the low birth weight child, and to administer the awareness program on KMC among parents of LBW babies, then to assess the level of knowledge, attitude, practice of KMC among parents of low birth weight child before and after administration of awareness program on KMC. The hypothesis of my study, there is significant difference between the pre-test and post-test knowledge score of parents regarding kangaroo mother care of LBW babies, and there is significant difference between the pre-test and post-test attitude score of parents regarding KMC care, and there is significant difference between pre-test and post-test practice score of parents regarding KMC care. The research methodology that I have used, the research approach, the quantitative research approach, in that design, pre-experimental design, in that the one group pre-test, post-test design I have accepted, then sample the parents of LBW babies, then sampling technique, the non-probability sampling technique, in that convenient sampling technique, then population was like parents of LBW babies of selected hospitals of Gandhinagar city, then sample size was 60, and development of tool, in that questionnaire, checklist and rating scale. For my study, I have inclusion criteria, parents of those neonates who are physically stable, then parents of those neonates who have low birth weight ranging in between the 1,500 to 2,500 gram, then available during the data collection procedure, then parents who are willing to participate in the study. Then exclusion criteria who are not available at the time of data collection, parents whose neonates with the serious health issues, then parents whose neonate was physiologically stable, who are not physiologically stable, then who was not interested in the study, and parents are sick at the time of data collection. Then description of tool, in that 4 section, A first is demographic variables, then B is like semi-structured questionnaire, C like 5-point rating scale to evaluate the attitude, then D like checklist for evaluation of practice. Then in development of need-based strategies, I have developed the customized program, in that introduction, component, advantage, discharge criteria, how to discontinue KMC care, and then procedure, I have demonstrated the procedures to the parents. It consists of the steps, preparation of KMC procedures, counsel the parents, steps of procedures, and proper positioning of KMC care. Then this is the result. For that result, in frequency percentage, demographic variables, I have plotted on the frequency percentage. Then the statistical analysis I have done. So this was demographic variables, age of parents, religion, type of family, education, occupations. Then the health status of child, like full term, preterm, then gender, weight of newborn. Then like pre-test and post-test score. I have compared the pre-test and post-test score with the chi-square. So it indicates that knowledge of parents was improved after implementation of the customized awareness program. Then this is the attitudes among the parents, the pre-test and post-test compared with the chi-square. So overall score, it found that the improvement is significant. So parents' attitude was changed. Then comparison of overall practice among the parents. So practice score, it shows that there is a good practice performed by the parents when I have done the demonstration with that. So it shows that significant improvements seen in the post-test. So conclusion of my study stated that the need-based strategy was found to be effective through customized awareness program, and it was effective for the improvement of knowledge, attitude and practice of parents regarding KMC care of LBW babies. So recommendation for my study, so that like comparison can be done in urban and rural areas of parents. Comparative study can be done to evaluate the knowledge knowledge with practice of health professionals on government and private hospitals. Similar study can be dealt with that more number of samples to generalize the outcome. The study can be performed in different settings and can be performed in the different community areas. So this was about research paper. Thank you.
Congratulations for conducting, again a much needed study and to look at what do the parents feel. So I just want you to know that what is your conclusion as related to the education of parents, and did you look at maternal education and what is the effect on kangaroo mother care?
Yes, ma'am, during my study, I have decided that the mother those who are illiterate, literate, and that those were undergraduate, graduate. But I have conducted study in government hospital. So in that case, I got the mothers, those who were like up to 10th and 12th, they were studied graduated because I have conducted in government sector.
That is okay. Even if mother is not educated, her attitude for KMC can be entirely different. It's not that education is going to change so how, how is the counseling done? These are a lot of factors which will affect.
Yes,
so did you find any correlation, in mother's education, her attitude and actually practice of KMC?
Ma'am, first of all, the mother was very anxious about the weight of the child and about the condition of the child. Then they have the attitude, they have the positive, not the positive, but they have the attitude like, my child should be recovered with that. So it's not, I cannot say that they have the negative attitude, but they have somewhat positive attitude. But after all, I got the positive response because the mother and parents, mother and father both have included. So I got the positive response with that.
And what about any difference as far as the joint families and nuclear families is concerned in the practice of KMC?
Yes, ma'am. The joint family, the member also can be given. Any family members can be.
In your study, when
no,
you
ma'am, I have not included, ma'am.
Yeah,
in demographic data, I have not included.
Okay, fine. Yeah, thank you.
Thank you, ma'am.
Thank you very much. The last study is Father Kangaroo Care, a qualitative exploration of facilitators and challenges at facility and continuum in the community.
Good afternoon to all. I'm Shantini, faculty from Health and Family Welfare Training Center, Gandhigram, Tamil Nadu. First, I thank the selection committee for giving opportunity for presenting this paper as a oral. So, this is a qualitative exploration of facilitators and challenges at facility and community regarding Kangaroo father care. So, this is the birthplace of KMC in India. I think this is Ahmedabad in 1994. After that, various steps were taken by the government as well as NGOs for the effective implementation of KMC at the facility and as well as in the community. WHO also endorsed India's for the large amount of evidence on benefits of Kangaroo mother care. The duration of KMC, that means prolonged KMC duration, is not up to the mark. So, one study conducted in Tamil Nadu, that is in the Chengalpattu Medical College, demonstrated the increased Kangaroo duration by involving father in separate Kangaroo father care ward. Another study in Tamil Nadu, that is in the preprint stage, also identified the families without father support lower the practice of community KMC than the family with the father support. Even most of the mother who had a pain, body pain due to delivery process and etc. This is the aim of the study. So we want to qualitatively explore the facilitators and the challenges surrounding Kangaroo father care in the healthcare facility and the continuum care in the community. So this mainly we adopted actually we adopted study design qualitative research with the in-depth interview method by using pre-tested interview semi-structured interview schedule between July to August 2023 after getting the approval from the Institute Ethical Committee. The study setting was community, that is the house of the newborn child discharged from the SNCU. This is the three districts were selected, and the Chengalpattu, Theni and Dindukal. Chengalpattu Medical College, that district has Chengalpattu Medical College has well established family centered care and zero separation policy unit. Theni Medical College, Theni district has a Theni Medical College. It has well established fully functioning KMC ward. The Dindukal district has a newly started medical college. KMC ward is in the initial stage. So parents of newborn discharged from SNCU after within 2 months were considered as a study participants. Totally 17 in-depth interviews were conducted with father and mother. That means 9 pairs of parents were interviewed. So the interview was conducted by the trained interviewer. Interview was conducted separately for the father and mother by maintaining a physical distance. The spot check was done for the accuracy of the information. The interview was recorded in the audio and transcribed verbatim into Tamil to English. So that transcripted was imported into the NBO 12, then it was coded, thematically analyzed. Finally, we emerged 3 themes: emotional experience of fathers in Gangaru care and support for mothers, facilitators and challenges in Gangaru father care, then feasible solutions for effective Gangaru father care in facility and community as father's words. The study finding, so mean age of father was 26, mother age was 25. Occupation of the fathers, most of them were daily wager. Majority of mothers were housewife. They were completed 10th standard. Most of the mothers were completed 10th standard. They lived, majority of the parents lived as a nuclear family. This is the current situation of Gangaru care practice in facility and the community as per the statement given by the father and mother. If you look into the 3 essential components of Gangaru mother care, almost in all the facilities, mothers were practiced Gangaru mother care. The duration may range from 2 to 14 hours. But in only one facility, father had a chance to practice Gangaru mother care, that was 40%. In Gangaru nutrition, mostly in the initial period, the baby received donor milk or milk from the milk bank. After that, they switch over to the direct breast milk. But at the time of discharge, all the babies were fed with the breast milk. If you the continuum care in the community level, if you see, those who practiced at the facility have had a less practice. That means that effective practice is not there in the community. They practiced nearly 4 to 6 hours. It is not as per the WHO recommendations. So most of nearly 50% of the mother were switched over to the formula milk, almost in all the districts. So emotional experience of the father, babies one father says, now I am feel happy by keeping my baby in KMC, so I feel the further touch of my baby's skin. So I get immense pleasure. KFC gives, because of this KMC, I started to practice keep the baby like mother's womb. So here I got a chance to share my love and affection with the baby while doing Gangaru care. So this is my, one father expressed that this is my responsibility to take care of mother and baby. So he also expressed that instead of waiting outside the newborn ward with fear and stress, Gangaru care has reduced the stress and fear regarding the baby's health. So these are all the facilitators come out from this interview. Emotional attachment with the baby had a positive effect on the Gangaru father care. Then availability of ward. The fathers expressed if facilities for us like a separate Gangaru father ward with a separated toilet, refreshment room for taking bath and all means we will be very comfort for practicing Gangaru father care. Then also they said the counseling given by the SNCU staff created a awareness for doing Gangaru father care. Then in NICU in Tamil Nadu, we were actually in the Chengalpattu Medical College, nurses were given a hands-on training to how to hold the tiny baby, and they demonstrated the skill with the father. This is also one of the facilitator. And also mother, wife and family members motivation. So these are all the barriers come out from this theme analysis. One is restriction policy means fathers are not allowed to enter into the NICU or newborn ward, or they may not be allowed to stay longer period. So there is no separate ward is also a barrier. Then lack of knowledge to handle newborn. So it again, it will not remove their fear and all. Then lack of motivation opportunity. Traditional gender role of supremacy. One father was telling that, why should I take care of the newborn? This is the primary responsibility of my wife. So this is a success story we come across during my interview. We met one father with a lot of depression due to he lost his wife in the delivery process. He had a baby with 1.65 kg. Nearly 22 days, grandmother practiced mother care at the NICU. After discharge, father was in a sad mood. Then we counseled the father. Theme of our research team as well as by involving the NGOs, we supported with the sling bag for practicing of KMC. So after that, he started to practice with the happy mode, with the console mode. The baby gained 1.8 kg at 60 days. Now the baby is in the 5th month. Now the baby weight is 5.2 kg. So the absence of mother made the father to save the life of the baby. So this way, all the male have the intention and love, affection to the baby to save their life. If you give a chance, definitely they will practice the Gangaru father care. So this is a less practice of KMC practice found among facility with no KFC ward. Very good support from milk bank for initial feeding was found. KMC duration in the community was not effective. After discharge, 40% of babies fed with formula milk. Lack of monitoring and follow-up at the community level in Gangaru care. Recommendation policy level, change in hospital policy to allow the father to take care of the newborn. Provision of separate Gangaru father care with the privacy and attached restroom. At the implementation level in the community, knowledge should be imparted on Gangaru care from ANC period onwards for the both father and mother. It should be emphasized. Kangaroo mother care, it includes it will be the tool for effective home-based newborn care practice. So it should be imported from the ANC period onwards. Counseling sessions for families at the facility as well as in the community should be strengthened. Systematic monitoring should be system in facility and community. For example, in the monitoring chart, only provision is available for monitoring Gangar mother care, but father care also should be included. So fathers expressed that if we had a peer group, means we will get a motivation and positive confidence. It will increase our KFC practice.
Time is finished.
The limitation. So this is, I really rely only in-depth interview, maybe limit the range of perspective captures. This study finding only represent the parents of SNU discharged newborn in the study area, may not be generalized. Thank you very much.
In one way, it is really good that you have really taken the interviews of fathers and tried to find out what are the facilitators and what are the problems, barriers. It is a good thing because we in Indians think that probably father, whether they really take care of babies. But you have looked into it, and at the same time, you need to now, what would you like to do after this?
Yeah, thank you very much, ma'am. This is a part of our formative research. So we are having a plan to do implementation of KMC, community KMC, by collaborating with the Tamil Nadu government. So it's the initial stage. So this is a part of our formative research. From here onwards, we will get the some idea to do some interventions for effective community Gangar mother care.
Yeah, but your aim was to find out from the father, no, perception of the father.
Yeah.
So then in that case, you have said that you would like to have kangaroo father care board. That is really too much to ask, but what else would you like to do for the fathers?
Actually, fathers, not only Gangaru care, for fathers, I already said that it should be, initiation should be started from the ANC period onwards. Not only for the mother, father also should be focused not only on Gangar mother care, should be focused on all the antenatal and postnatal care also. They are having an equal responsibility to bring up their child in a healthy environment. Thank you very much, ma'am. Thank you one and all. I extend my thanks to Dr. Satya madam for motivating me to present this study and involving in the research. Thank you very much. Thank you.
Thank you. Thank you, everyone. So it was a nice presentations from all of them. And I thank our esteemed judges, Dr. Rekha madam and Dr. Ruchi madam for judging the session. Okay, so we'll go to the next session.
Before that, we invite all of you for the photo session. The judges. Okay, so let's move on to the next session of session number 5. Online presentation by international KMC expert and champion, our chairperson, Dr. Suman Rao and Dr. Dipen Patel. Dr. Suman Rao is professor and HOD NICU at St. John Hospital, Bangalore. Technical expert and consultant WHO for newborn care, gold medal for research paper on KMC at IAP and several awards and prizes, member of executive and executive committee of International Network of KMC. Dr. Dipen Patel, Professor of Neonatology, Karamsad Medical College, President NNF, Gujarat 2023, Gujarat State Coordinator for Advanced NRP. Welcome you, sir.
Good evening, everyone, and we welcome Dr. Anne-Marie Burke to this session. She's doing it virtually. The KMC community is very well versed and look up to Dr. Anne-Marie Burke. She's been an expert of KMC for decades now. She's a very senior researcher from the University of Pretoria in South Africa. She's been a leader in KMC, and she's one person who has taken kangaroo mother care implementation to scale. particularly not only in Africa, many countries in Africa where she has handheld them, provided training, capacity building, but also in Asia. And we welcome you, Dr. Anne-Marie Berg, and over to you.
You can say hello, ma'am. You can just say hello, probably.
Hello, ma'am. We can't hear you yet. We can't hear you. Just give us a minute.
Just wait a minute. Wait a minute. You will be audible soon. You can speak when we tell you to start. Dr. Anne-Marie, just wait a minute. Hello. Can you say just hello? Can you just say hello from your side? Yeah, we can hear you. Yeah, you can just say hi to everyone, and then we'll run your presentation. Presentation run karo padse. Presentation aise run karo padse.
Share a few thoughts with you. I am also very thrilled to see so many of my colleagues that I've collaborated with in the past in the audience, and so I say hi to you, and then I also say hello to everyone else that I haven't met yet, and we are doing a pre-recorded presentation just because of my bandwidth, which is a bit of a problem, and I would just like to say that some of the things I might have said differently after I've heard all the speakers today. So thank you very much for the opportunity to be with you. Thank you.
Thank you, ma'am. Period of time.
Thank you for the opportunity to give you a few thoughts on how kangaroo mother care can contribute to the promotion of health for all. Something
This year we celebrate Thank you for the opportunity to give you a few thoughts on how Anglo Mother Care can contribute to the promotion of health for all.
excellent video lecture. We have now aware of KMC because since the newborn phase from 1978 when it was born, now I think we are keen that we can say that KMC has reached to its adolescence phase. We have still many more things to do for KMC. Through your guidance, we can do this. We do not have questions time because inauguration session is about to start in short time. So thank you again, ma'am. And I invite the team for the session.
So after excellent brainstorming and enlightening sessions throughout the day, we are done for the scientific sessions for the day. Before we move on to our formal inauguration function, I would just like to announce once again that as we discussed in the morning, to make our Sunday morning even more memorable, we are going to have a KMC awareness walk tomorrow morning from at the Law Garden, which will start sharp at 7 p.m. All the delegates and faculty members are invited for the same. 7 a.m. Yes, the march will start sharp at 7 a.m. Sunday morning at the Happy Street gate of the Law Garden. We now begin with our inaugural function. A very good evening to respected seniors and dear friends who are present here today. I, Dr. Prarthna, with my co-host Dr. Shruti Desai, heartily welcome you all to the inaugural function of the second regional conference of Asia Oceania Network of Kangaroo Mother Care, organized by the Kangaroo Mother Care Foundation, India. Before wasting any further time, I would like to invite the dignitaries on the dais. We are indeed fortunate to have with us Dr. Vinod Paul sir, the member of Niti Aayog, Government of India. Sir has also been the HOD of Department of Pediatrics at the prestigious All India Institute of Medical Sciences, Delhi, before his current designation. Welcome, sir. May I request Dr. Shashivani madam and Dr. Parag Dagli to please accompany Dr. Vinod Paul sir on the stage. May I please invite Dr. Neena Raina, Director, Department of UHC Family Health, WHO, Regional Office for Southeast Asia on the stage. May I now invite on stage Dr. Shobna Gupta, Deputy Commissioner in charge Child Health and RBSK MOHFW, New Delhi. Welcome, ma'am. I would also like to invite on stage Mr. Prashant Das, the Chief UNICEF Gujarat on the stage. Welcome, sir. I would now like to invite on stage Dr. R.B. Patel, Joint Director, Child Health, Department of Health and Family Welfare, Gujarat. May I also invite on stage Dr. Socorro Mendoza, the President of Asia Oceania Network, Philippines. Welcome, ma'am. We also acknowledge the presence and welcome our colleagues who are representatives of various specialties from pediatrics. We have Dr. Chetan Trivedi, President AOP Gujarat 2023, Dr. Unmesh Upadhyay, President AOP Ahmedabad. From neonatology, we have Dr. Dipen Patel, President NNF 2023. From obstetrics, we have representatives Dr. Parul Kotadawala and Dr. Dilip Gadvi. From nursing team, we have Mr. Shailesh Panchal and Dr. Jatin Mistry, the founding member of the KMC Foundation of India. Let us begin our program with a prayer. I would like to call upon stage Professor Dr. Nikhil Kharod for offering a prayer. Dr. Nikhil Kharod is the Honorary Joint Secretary of the KMC Foundation of India. I hand over the mic to Dr. Nikhil Kharod.
दीक्षा अमृतात्मने नमोस्तु नमस्ते गुरुवर नमो नमोस्तु नमस्ते
Thank you, sir. I request the dignitaries on the dais to please come forward for the lamp lighting ceremony. We also have special guests in the audience, the kids who were grown and developed with the help of Kangaroo Mother Care. One of the most precious guests we have today. We welcome them for the lamp lighting ceremony.
I would like to invite Dr. Shashi Vani Madam to deliver the welcome address. There is no need of introducing Madam to this audience. She is the pioneer of KMC in India and community-based newborn care in rural, tribal areas and urban slums. She is the founder, president and managing trustee, KMC Foundation of India. Shashi Vani Madam.
Thank you. Today it is really a great moment for me to welcome our own Dr. Vinod Paul here. Of course, he is a great man. First of all, he is neonatologist and our own person. And then, of course, he is now the honorable member of Niti Aayog and taking up many, many great responsibilities in taking forward the newborn care, child care, and various aspects in India. Vinod, welcome to our meeting. All our family members are here. Then, of course, I welcome Dr. Nina Raina. She is also one of us. Yes, Nina? Yeah. And she is the director of WHO now, taking care of the mother newborn care section in the Southeast Asian region. So we are really happy. Our own people are at great heights. Dr. Shobna Gupta, she is also now joining us, one of us, and now she is the Deputy Director of Child Health Division in Government of India, and really taking a lot of enthusiasm in promoting newborn care and various other aspects. We have Mr. Prashant Das. He is from UNICEF Gujarat, and he and his team, Dr. Narayan Gaokar, Dr. Shravan and others, they are helping us all throughout in our projects. Dr. R.B. Patel is there from Government of Gujarat. He has also joined us. Yesterday he visited all our workshops and gave us a lot of blessings, and that is a very promising thing that Government of Gujarat is supporting all our programs. Now all of them are our own people, so I don't know how to put them very formally. Dr. Suki, as we call her, Socorro de Leon Mendoza, and she is from Philippines, president of Philippines Association, Kangaroo Foundation, and she is the brainchild in starting this Asia-Oceania network of KMC, and she is, of course, past president of FOBS also, and she with her colleagues all have joined us. So I welcome all of them. And of course, there are so many friends in this auditorium. A team from Canada, I request them to please get up so that people can appreciate you. Dr. Douglas, Dr. Nalini Singhal, Dr. Majida, Dr. Suman Mayer. They have all come on their own to help us in improving quality. Dr. Kim Chi Leong from Vietnam, she has come. And then Philippines team, Maria Esterita and Daisy Garcia, Kitong, Luong, please get up. They have also come here. From Norway team, Serene and Caroline, both of them also joined. So special welcome to all of you. And of course, my own group here, all the neonatologists, pediatricians from all over the country. Yes, from Nepal, Dr. Asma, please. She is an obstetrician and she has also joined our fold and she wants to join from our group. Yes, Mongolian group, please, Gerelma and your team. Okay. She has not received her luggage, so she is still in the airport exploring the possibilities since yesterday. And they were the first one to register for this conference from all the way to Mongolia, and they assured us whether they get help from any other source or not, they are going to attend this conference. So that is the kind of enthusiasm we have had. And pardon me, all my friends here, not to take your individual thing, but welcome you all. And you have really given us great warmth in conducting these meetings. Thank you very much.
Thank you, madam, for your encouraging words. Now I would like to invite Dr. Soroko De Leon Mendoza, who is founder president of KMC Philippines and Asia Oceania Network.
Thank you very much, and it is my distinct privilege to be present in this very, very important occasion. And Dr. Vino Paul, distinguished friends from WHO, UNICEF, and the government of India. It is truly an honor for me to be here today to celebrate and to be with you on the second Asia Oceania Regional Conference on Kangaroo Mother Care. The network was put together in 2018 during the occasion of the 20th FAOPS Congress, which was held in Manila. We took the opportunity at that time to bring together specialists in perinatology and neonatology, specially dedicated and committed to the kangaroo mother care intervention and implementation. We took that opportunity to bring together everyone dedicated to kangaroo mother care and launched the Asia Oceania Kangaroo Mother Care Network. We all recognize the importance of networks in the promotion of quality health care, and we feel that a network such as this in our region will be able or will facilitate the delivery of important information, research findings, innovations, and program implementation on kangaroo mother care with quality, persistence, and commitment. We are all united with the overarching goal of helping to facilitate the decline in neonatal morbidity and mortality in our region. As all the speakers today pointed out, we have the largest numbers of small babies, and their mortality and morbidity is truly high. The network is open to all countries in the Asia and Oceania regions, and we convened 14 member countries to date. We welcome all other countries who are also committed to kangaroo mother care, and we feel that with collaboration in the network, we will be able to promote faster the intervention and the program implementation in the region through training, research, and collaboration in all aspects of kangaroo mother care. Before I end my short description of the network, I would like to recognize Kangaroo Mother Care India for spearheading the coordination of the network for the years 2021 to 2023. Can you open this? Madam Sashivani, please come. This plaque of recognition is hereby awarded to Kangaroo Mother Care Foundation India for its unwavering commitment and proficient leadership as country coordinator of activities in the advocacy, promotion, implementation, and research in the field of kangaroo mother care in the Asia-Oceania region. Given this December 2, 2023, at Ahmedabad, Gujarat, India. Signed, yours truly. Congratulations, and thank you very much.
Thank you, madam, for enlightening us.
May I now request Dr. Parag Dagli, the Honorary Secretary of the KMC Foundation of India, to present the activity report.
while the laptop is being set up. I'll just say one or two lines about Dr. Vani, who said all of us are her own family members. That's actually in true sense. At my home, my wife considers as her second mother-in-law. I think that must be same for many of us. She just calls and the person will go. So on behalf of Kangaroo Mother Care Foundation of India, I will present the report, the activities that we have done over the last 2 years. So, Secretariat of Asia Oceania Network for KMC was shifted to KMC Foundation India for the year 2021 and 2022. But due to COVID epidemics, it was extended for one more year. During these 2 years, we mainly did activities during this World Health Day on April 7, KMC Awareness Day on May 15, Breastfeeding Week during first week of August, and Prematurity Day at 17 November. We did several KMC national and international in-person and offline conferences, workshops for facility-based providers, facility-based TOTs, home-based KMCs, IKMC, transport KMC, and quality-linked KMCs. We did special CMS and online seminars, and we involved obstetricians, ASA health workers, besides neonatologists, and also neonatal nurses. To name a few, on 20th March 2021, we did neonatal transport meeting whereby there was a guidelines were prepared for KMC transport of newborn in India. On World Breastfeeding Week 2021, we did a symposium titled Status of Breastfeeding and KMC in View of COVID-19 Pandemic, Challenges and Way Forward. For this online webinar, we had 70 participants. On 15 to 21st November, we had Newborn Week celebrations, on part of which we had one World Prematurity Day celebration on 17th November, and then we had actual online conference over next 4 days. On 19th, there was a workshop on IKMC. On 18th, there was workshop on home-based KMC, and there was an actual conference on 20th of November 2021. Guest of honor was Dr. Ashabad Game, health specialist UNICEF, and there was lectures by guests like Dr. Natali Charpak from Colombia. We had a first quality linked KMC workshop, online workshop for 4 days at a stretch, and the Canadian neonatal group had guided us for this entire workshop, and there were 10 countries of Asia Oceania Network who had participated in this, and there were total 40 participants. It was a TOT for during that time. Home-based KMC manual was released with the help of Government of Maharashtra on 20th November 2021. These are some of the steps. Of 15th January 2022, there was a symposium on improvement of KMC and plan for the subsequent years, especially after facing the COVID epidemics, how to go ahead. On International KMC Awareness Day on 2022, we had again a CME on KMC awareness. In 2022 August, first week's breastfeeding celebration, there was a symposium on promotion of breast milk feeding to preterm and low birth weight infants and role of kangaroo mother care on it. And again, there are a few of the snaps. We made an ardent appeal to promote KMC throughout the COVID pandemic. On April 7th this year, we had a webinar on KMC and Health for All, and Dr. Anne Mary Berg was the speaker for that webinar. On World KMC Day this year, we had a meeting at SSG Hospital, Baroda. There was a webinar also on the same day. And in World Breastfeeding Week, we had early skin to skin and early initiation of breastfeeding webinar. During these 2 years, we had done several national conferences where AOK network activities were also included. That was in Bangalore 2021, we had a CME for AOK. On Bhopal 2022, we had virtual regional conference on recent developments in KMC. Then we had, in Bhubaneswar also there was a CME. We had regular training programs of different categories, as I already mentioned. And we had more than 150 workshops in India over last 2 years, and India and neighboring countries. And last not but the least, the current conference that's going on for last 3 days, and there's one more day. We have 2 days of offline and online conference. We had 5 concurrent workshops and all were overflowed. One public meeting, there are scientific papers and posters were presented by young researchers. There's one KMC nurses exhibition, there's one KMC walk planned tomorrow, and there's one nurses quiz was organized. Thank you, thank you. Dr. Suki wants to add something, please.
I'd like to really congratulate the Kangaroo Mother Care India for all the work they've done through thick and thin. Due to the pandemic, they did not stop, and everyone was kept abreast of the latest in Kangaroo Mother Care. Thank you very much once again, Kangaroo Mother Care India. I'd just like to announce that in our meeting yesterday, attended by the country representatives, the next country coordinator will be Vietnam, through Dr. Kim Chi Luong. And so the next regional conference in 2025 will be in Vietnam. We hope to see everyone in 2025.
I'd just like to add that all these activities were possible mainly because of the core team. Most of the members are sitting over here. I can't name each and individual, but I thank you all. Thank you.
Thank you, sir. May I now request our representatives from across the specialities who are present over here for the joint declaration for KMC support. The representatives from NNF Gujarat.
Every year, we request different dignitaries from the various professional organizations to join with us and again give us a solemn declaration that they will take forward KMC with their members and in their own way. So that is the tradition we have followed, and so far almost all the professional organizations, of course neonatology, pediatrics, obstetrics are there, even Breastfeeding Promotion Network of India, IYCF, Neurology Chapter, Developmental Chapter, then Indian Indian Medical Association, MCI, ICMR, means we explore all possible avenues through which we can promote KMC. And this year now, I have requested our people from Gujarat to join us. So Dr. Chetan Trivedi, Dr. Unmesh, Dr. Parul Kotadawala, he is from obstetrics, Dr. Haresh Doshi, is he here? Okay, okay. So please, all of you join. And then from nursing associations also we invite, Indian Association of Neonatal Nurses also, midwives also, so and even in International Pediatric Association, Southeast Asian, Appa, Sapa, they all call it, everybody we involve. So this year we request them to come here again and join us here, please. Raju, you can also please join, just for Deepen, are you there? Yeah, please. So all that we say is we have prepared a commitment of action which is there here. I won't read the full one, but at least the first few lines. That is a special request from KMC Foundation India. We want a joint declaration and a commitment for action from all of you that we, the professional bodies and other stakeholders of health and development of the people of India, endorse the national guidelines for kangaroo mother care and optimal feeding and the subsequent updates released from time to time by Government of India, and commit ourselves to wholeheartedly support all the central and state governments towards the nationwide scale-up of KMC and newborn care under the National Health Mission. Advocate promotion of KMC as a core component of essential newborn care. To educate that KMC is not just holding the baby in direct skin-to-skin contact on mother's chest, but also includes equally important components like promotion of breastfeeding, planned early discharge, and regular follow-up. To understand that KMC provides several benefits and lays strong foundation for early child development. That also we have to remember, and also for the long-term benefits in neurodevelopment. Like that, we have developed several commitments here, and they have been endorsed. And this time again, I request you all to raise your right hand and declare your support for the KMC promotion. Thank you very much.
I invite Mr. Prashant Das, Chief UNICEF Gujarat, to say a few words.
Good evening, everybody. To start with, let me thank Sasivani ji for organizing this Asia Oceania workshop, and also to welcome our chief guest, Dr. Binod Pal. Sir, you may not be knowing me, but I am following your work for the last so many years. I'm not a medical doctor, but I understand public health very well. But I have been working in Chhattisgarh, Jharkhand, and now in Gujarat. I had the UNICEF office for Chhattisgarh, Gujarat. And we think that you are not only a doctor or a medical profession, but you are an institution by itself. And we have seen how you have contributed to all the pediatric conferences, not only in terms of just theory, but also how to implement them. I think now with the Niti Aayog, I think you are doing a fabulous job for the country, and we have seen you how you have contributed during the COVID as well. And also our Dr. Shabna from the Government of India, I think I'm really happy that Government of India, Government of Gujarat, and Niti Aayog, and the Asia Oceania conference, they are really taking very keen care on interest on the KMC. I think KMC will go to places. So since I am here, I have also a few requests to Dr. Paul and Dr. Shabna, how we want to take it to the scale. I think Gujarat is a much better state in terms of the health infrastructure, but there are states who need your support. I think we need to really take it to the scale. I think I was speaking to some of those tutors here, and I think the largest challenge that they told me is how to create awareness and how to take it to scale. And we are a country, we have a country with very strong social norms. So we have to also think how those social norms can be broken, and how the male counterparts will come to the taking care of the babies. I think that's the most difficult, and we all understand that minimum 8 hours is required for the KMC, and the only mother either might have gone through a surgery or might have gone through something, the normal labor pain, whether that person can really support the baby for 8 hours, or we need the father or the grandfather or anybody to be there. And if that is to happen, do we have space? And if that is to happen, do we have all those supporting this those in this place? And I think I have seen them really happening in a very good way in many parts of Gujarat, but we want to take it to scale, and I think this is not only limited to India, maybe the entire Asia and Oceania region. As I think Mom has said, we have the largest number of newborn babies in this part of the world. So we have to take this in a few steps. I think we at UNICEF are really happy and to be part of it, and we do our little contribution whenever possible. And whatever little possible from our side. And as the head of the office or the chief of the office, I think I stand in solidarity of whatever possible from our side to do not only technical support, but also if it is doing in a scale in Gujarat, I think we should look at mechanisms and methods with government of Gujarat to take it forward. And with this, I end my speech, but wish everybody all the very best for taking the kangaroo mother care, rather I would call it the kangaroo parents care, to take it to the next steps. Thank you.
Thank you, sir. May I now please request Dr. R.B. Patel, Joint Director, Child Health, Department of Health and Family Welfare, Gujarat, to deliver his speech.
I am most welcome to all the nationals and international participants present in the Kangaroo Mother Care Foundation organized this type of the workshop. In this workshop present over the Dr. Vinod Paul sir and our Government of India, Dr. Shobna Madam, and all the UNICEF and WHO members, and all the neonatologists and pediatricians and gynecologists. I am happy to be the part of this Kangaroo Mother Care workshop, and it is very useful for us. We can roll out in our Gujarat for this Kangaroo Mother Care, take up the neonates and decrease the IMR and also morbidity and mortality. So it is very useful for us. This type of workshop organized our paramedical staff, medical officer, pediatrician also take part in this workshop. Thank you very much.
Thank you, sir. I invite Dr. Shobna Gupta, Deputy Commissioner in charge Child Health and RBSK, Ministry of Health and Family Welfare, New Delhi, to enlighten us with her experience.
Respected Dr. Paul sir, sir is always an inspiration and guidance for all of us. Dr. Shashi Vani ma'am, Dr. Neena Raina, Dr. Patel from Government of Gujarat, the Dr. Prashant and all the dignitaries from the KMC Foundation and the Asian Network. As we are all talking since morning about the KMC, definitely going by its objective, and we saying Government of India is always committed for bringing down the neonatal mortality rate. As per the global action of the Every Newborn Action Plan, we came out with the India Newborn Action Plan with the ambitious target of bringing the newborn mortality to single digit by 2030. So going by that to our sixth pillar about the care beyond survival actually. So KMC, developmentally supportive care, family participatory care we're talking about are the important components of that pillar. So as we say that equity at all the levels which we are talking about, some of these states, as we say, my colleague said that the few states are not doing well, definitely. In some of the states, infrastructure is really good, but we have the other states where still the NMR is very high in spite of the national average of 20. So definitely that gap of equity and the quality, they are the two main pillars to bring down the neonatal mortality rate. So with that commitment, actually Government of India in our guidelines, we have the provision for the infrastructure. I think actually many people actually from the experts, they might not be knowing that we have the provision for providing the KMC, the mother newborn care unit, and the apart from the infrastructure, even in the IPHS standards 2022, there is a provision of not only SNCU or NICU beds as well as the beds for the MNCU. And even the HR norms are there in that. The HR norms have been revised. My friend was telling in the afternoon that there are no norms. So we have the norms in IPHS which have followed that. Now it's definitely apart from the infrastructure, the capacity building also we will be providing, and going by this, definitely going forward, we are thinking of coming out with the structured training module which should cover not only the KMC but as we said that the care of bundle approach. So we'll be working on that, how we can scale up to the pan-India, not only to the few states. So that strategy definitely will work it out, and the provision is already there. So whoever state actually asks us to start as an innovation also or to pilot, that we always support. So I would request the state representatives also to tell the governments to come out with the the infrastructure to think innovatively. Like last week I was in Nagpur, so in a district Daga we saw a maternal child hospital where, when we are talking about, they had just a separate room where they have kept 20 KMC chairs for the fathers. So fathers are there giving so beautifully KMC, and it's a the 40% of the deliveries of this district are actually going to that MCH hospital. They have a very well connected DIC where all the SNCU graduates are actually going, and this is because of the committed leaders which are present in that particular hospital, and they have a separate counseling for the fathers. So if that one hospital can do, I'm sure the ways can be found out at the individual level, that how to find out that space, because when there is a will, there is a way. So we have to find out those innovative ways. And going by the evidence that we are coming out in the revised KMC guidelines, so even in the revised facility-based newborn care module, we are going to revise that. We have in fact revised that chapter on the KMC to include all the three components which have recently come out about the immediate KMC, the prolonged KMC of minimum 8 hours, and even in the small and the sick babies. So that note we have revised, and even in the operational guidelines for the sake of implementation in the states, we are in the process of revising it, so that even all others are in the uniform page, that how to take up forward. So definitely that, and going with the quality indicators, sir, with the release of the INAP recommendations, we will be coming out with the dashboard indicators as we talked in the morning, so that we always also have a denominator, that how many hours KMC is given, how many facilities are actually having functional. So we have a denominator and proportion of the children giving KMC. So we are hopeful that with these type of actually conferences and the congresses are actually a part of creating much and more awareness and the motivation to do better to achieve our goals. Thank you.
Thank you, ma'am. I would now like to request Dr. Neena Raina, the Director, Department of UHC Family Health, WHO, Regional Office for Southeast Asia, to say a few words. No, this is it. Good evening, namaste. Professor Vinod Paul, the father of newborn health in India and in Southeast Asia region. Professor Vani Shashivani, the mother of KMC. She has not only given, I would say we all have been given KMC by her. If today we are standing here, that means she has really nurtured us well. Professor Mendoza, Dr. Shobna Gupta, Dr. Das from UNICEF, national, international delegates, dignitaries, ladies and gentlemen. I was born 64 and a half years back with 1.3 kg weight. And I was the second daughter in the family, and next day, my mother tells me the story. I was born in a hospital, and my mother was discharged with a tiny baby. And my mother was taught how to give dropper feeding. Fortunately, I was born in the month of June, so it wasn't very hot. And when my mother entered home, my grandmother, paternal as well as maternal grandmothers were there. They were hoping for a boy to be born. They both started crying loudly, and everybody in the vicinity thought somebody has died. And then, because they saw I was so small, so my grandmother told my mother, I don't think she'll make it for more than a week. And my mother got very touched. And she tells me the story that she used to wrap me in a cotton wool because I was so small. And she really used to tie me on her chest, and wherever she went in the house, she used to carry me along so that my grandmother doesn't kill me.
So my mother really, and that led to delay. In the third child, we have 5 sisters. And my mother was the epitome of women empowerment. And then I got in touch with, I had the fortune of 1980 to meet Professor Vinod Paul. And I wanted to do some study on low birth weight babies, and my PhD thesis was on low birth weight babies. Do they survive in community? Do they grow and develop as well as normal birth weight babies or not? And whether community-based interventions can save lives or not. And I'm talking about 1980. And to really know about KMC is the time when I was put in touch with Professor Shashi Vani by Professor Vinod Paul, by Professor Vijay Kumar, who was my mentor. He's no more. I think he mentored us very well. And that is the time in whatever way we learned, I used to teach mothers how to do KMC in the homes. And the findings were they catch up by 1 year. They do catch up with interventions in growth. But in development, the development is delayed. And I'm still searching which development milestone has been delayed in me. Growth, I know, I never caught up. My mother was 5 feet 9 inches. All my sisters are much taller than I am. But growth, I could not catch up. Development, I'm sure I've done well in life. So friends, I think by the time we finish today's meeting, we would have lost about 1,600 newborns, 1,600 newborns in Southeast Asia region. Southeast Asia region is 11 countries, but major population is India. We have made remarkable progress in reducing deaths of mothers, newborns, and children. And our region has the highest reduction in the last 1 decade. We noticed highest reductions in 3 mortalities: maternal mortality, neonatal mortality, and under 5 mortality, compared to the global reductions. For example, neonatal mortality, our region achieved 45% reduction as compared to global reduction of only 26%. So I think our region has done well. And thanks to champions like Professor Vinod Paul, who is the chairman of our Southeast Asia Regional Technical Advisory Group of WHO as well. And under his guidance, I think we have always been pushed. As of 2021, the 5 countries of our region, which is DPR, Korea, Indonesia, Maldives, Sri Lanka, have already achieved the target of both under 5 mortality, which is 25 per 1,000 live births, and neonatal mortality of 12 or less newborn deaths. Coverage and quality of intervention still remains a challenge. I think since its introduction in Colombia in 1978, KMC has come a long way, and the interventions have evolved in terms of evidence, policy, and implementation. And in past 2 decades especially, WHO has played a very significant role in generating evidence and policies for KMC. We came up with KMC Practical Guide in 2003. The KMC as a critical life-saving intervention for preterm infants was also highlighted in Born Too Soon report of 2012, then 2019, 2023. The Every Newborn Action Plan has focus on KMC. The Cochrane Review, which resulted in 2016 publication in Lancet, also showed the potential of KMC to reduce mortality in low birth weight babies by 40%. I think this is something which we have been talking about since morning. However, despite all these actions, the countries and policy makers were not convinced, and they were concerned about the fragmented evidence. So the coverage remained poor. Coverage is still poor. I'm not saying it's better, but it's getting better. So working with other partners, WHO coordinated multi-country research across Southeast Asia region and parts of Africa and came up with the WHO guidelines for care of preterm or low birth weight infants in 2022. And following the guidelines, 2 new publications have been brought out this year, and which is Global Position Paper on KMC, which Dr. Rajesh Khanna today morning made the presentation, and implementation strategy for scale-up. I think with the rapidly changing world and new emerging challenges of which I say 4 C's, COVID, conflict, climate change, and cash crisis. These 4 C's are very, very important. They are putting pressure on the health system. And the recent KMC evidence and recommendations have become very, very important for us. Why it is important? It provides new vision with the newborn and mothers and families in the center. They are the driving force. They are the ones who are going to drive KMC implementation. KMC is an intervention for gender empowerment and respectful maternity care, which I alluded to with my example, how my mother got empowered and how she saved me. It shifts away from technology to humanizing care. I think somebody showed the slide where the boxes were there in 1901 where the babies were kept. So it humanizes maternal newborn care by empowering, involving those who care most for the infant rather than focusing predominantly on technological solutions. It also promotes self-care with mothers, fathers, families taking charge. And lastly, aligned with primary health care approach. And that is a new baby, which not any more new, but I think quite old, which Professor Vinod Paul Sir has adopted. Aligned with primary healthcare approach, the concept of KMC is completely aligned with PSC approach of health and well-being, and it empowers individuals, families, and communities to take charge of their own health. And moving forward, it should become a critical component of universal health coverage, wherein everyone, including newborns, have access to health system, health services they need without facing financial hardship. Sir, as we are midway to the SDG 2030 targets, I would urge all the stakeholders who are present here to work together in taking these evidence-based interventions forward. It requires shift in thinking, behavior, and organization of newborn care. We have to move to zero separation. We have to, both in the private as well as public sector. National government ministries of health and finance commit to prioritize small and sick newborn care with KMC as the foundation. That means apart from having costed national plans, it requires regulatory and legislative reforms, for example, extending parental leave and entitlements for preterm or low birth weight infants, financing, expanding health insurance for preterm or low birth weight infants. Believe in me, families have to sell their lands, they have to sell their houses when a baby is kept for 1 month in the newborn intensive care unit in a private sector. Every day it costs them 30,000 rupees. And I think this is a huge out-of-pocket expenditure which has been ignored by many countries when they talk about health insurance. And promotion of private sector engagement in the scale-up effort. Private sector gains by keeping the babies in the incubators because they can show that we have kept your baby in a machine, so that's why we are charging you more. But if they keep the baby onto the mother's chest, they just cannot claim more money. And I think I urge all the private sector stakeholders to really come forward and embrace KMC. What gets measured gets done. Efforts should be made to include globally agreed indicators, which I mentioned in the morning as well, in routine health information system and track them regularly. Partners, donors, professional associations who are present here, my appeal to you is to demonstration of change in practice. Work with the government in implementing and scaling up efforts. Advocate for policy where all barriers are removed and mothers and newborns are enabled to remain together. develop capacity, motivation, and momentum of the health workforce, evaluate economic and societal perspectives, and reinforce that mothers and their newborns remain together after birth and receive combined care in one place with KMC as the standard of care in health work and training. In the end, I congratulate the Asia-Oceania network of KMC in organizing this second regional workshop, and I wish them all the success. KMC is an entry point for essential newborn care. It brings everybody together. Thank you.
Thank you, madam. I now request.
Now, I have a special request here. We had prepared a module for home-based KMC for the primary health workers earlier for the government of Maharashtra. After doing several training programs there and mainly in the 78 tribal blocks. So depending on that module, now for the UNICEF Gujarat, we have prepared the same module in Gujarati also and English also. Today, just since Dr. Vinod is here, we are requesting him to release the first copy. We are yet to take it for the printing. Since 2003, we have introduced community-based KMC. And now we are taking it up in many other projects. Almost 20 years experience we have now in community KMC, starting with the day when WHO had expressed their concerns about introducing primary care. And now we are requesting Dr. Shobna Gupta to include that as a part of home-based newborn care. And one more thing I want to reiterate here, that kangaroo mother care, we don't want to project it as a vertical isolated program. It is a part of essential newborn care, but we want to promote it in a big way. We want to build up the skill, we want to build up the confidence and the compliance and the confidence of the workers, and that is why we are promoting this kangaroo care in isolation. But it is a part of full comprehensive newborn care. That is the. Thank you very much.
I now request our honorable chief guest, Dr. Vinod Paul sir, esteemed member Niti Aayog, ex-HOD and Professor, Department of Pediatrics and Neonatology, AIIMS, New Delhi, to deliver his presidential address. Dr. Paul has contributed to India's national programs, including reproductive and child health and nutrition. He is a visiting professor at Public Health Foundation of India. He is a well-known researcher and public health exponent. He has over 350 publications to his credit and is a recipient of prestigious Dr. B.R. Ambedkar Centenary Award for Excellence in Biomedical Research by ICMR and Public Health Champions Award by WHO. Dr. Vinod Paul, sir.
Namaste. Good evening. Most respected Madam Shashivani ji, Dr. Socorro de Leon Mendoza ji, Dr. Nina Rana, distinguished Dr. Kharot Sahab, Dr. Parag Dagli ji, Dr. Jatin Mistry ji, Madam Shobna Gupta, and the leadership of neonatology in the country, leaders, pioneers of kangaroo mother care in our country and in other nations who have graced us, whose representatives have graced us today here. My very distinguished colleagues, students, residents, and friends. It's a true honor to be here at a very warm invite from my mentor, Dr. Bani, to be present here at the second regional conference of Asia Oceania network of KMC, and a special welcome to Ma'am President. Being hosted by Kangaroo Mother Care Foundation of India, established by Madam. I am very pleased to welcome the delegates from our other friends and other nations, team from Vietnam, team from Philippines, Norway, Canada, US, Mongolia, Nepal. Very warm welcome on behalf of the Government of India. I'm feeling truly at home after a long time, and therefore, friends, thank you for making it possible. I get that good old warmth. I find myself in kangaroo position, and therefore very kind that you all turned up, and you are here, and your presence is very heartening, all of you, Kumada ma'am, all of you. If I name, my fear is I leave somebody out, and that's something I don't want to do. But there are stalwarts of KMC in particular. Rekha Udani ma'am, you are there. Of course, Somshekhar, you have done so much of work, and others. I'm being cautious of not naming, although I have a great temptation to name each one of you. But first, my big salute, tribute, and affectionate submission to Madam Bani. Ma'am has changed the face of newborn health in a very special way for India and influenced this across other countries. Ma'am, we are so very proud. What you have done is phenomenal. I distinctly remember not long ago, just about 35 years ago, she developed a special affection for me very early. It was love at first sight. She invited me way back, I think in 88 was my first visit to Madam's unit, and she was at it already. 80, 88, 89, remember, you started that process. There were many questions, but ma'am believed in the intervention, and then she nurtured it, she honed it, and she created the Indian model, which we all are so proud to have embraced and followed in the footsteps of ma'am. But it was her confidence and her commitment, and to take the difficult path of moving from proof of principle, moving from how to start doing it, and then taking it all the way through research, through demonstration, through adaptation, to where KMC in India stands today. So you've been my student, ma'am, you are my mentor, and this journey of Madam reminds me of what Swami Vivekananda, the sage whom we adore, said as a philosophy, and I quote, great example of what he stated and how, ma'am, you made it possible. He said, and I quote, take up one idea, make that one idea your life, think of it, dream of it, live on that idea. Let the brain, muscles, nerves, every part of your body be full of that idea, and just leave every other idea alone. This is the way to success, unquote. Power of pursuing one great game-changing, society-changing idea. Ma'am, I salute to you. And I'm going to do something without her permission. So I'm going to join by, this is from Government of India, let me say, WHO and the foundation, Thank you, ma'am. Thank you. Our good wishes, our prayers for so much more work to come from you, ma'am. Friends, as we meet here today, we have a very special context. And KMC fits into that context in its own way. First and foremost, we have the context of being gathered here after a terrible three-year phase of pandemic. We are proud that we were Corona warriors, all of us in a way, the health profession, pediatricians, neonatologists, each one of us, policy enablers, and so on. And we learned several lessons. Among them, we learned the lesson that health systems have to be strong and resilient to be able to make a difference. Our capacity for preparing, developing, testing countermeasures has to be strong. Our epidemiological principles, disease control principles have to be strongly embedded in our system and expertise. There's a lot that can be stated in that context, but remember, just remember, if India did not produce 2.2 or 2.3 billion doses of vaccine on its soil, there simply wasn't enough vaccine, not enough. I mean, there wasn't any vaccine to be offered to us. There simply wasn't that level of production anywhere to give vaccine to 1.4 billion people of India. We have to be on our own. So it's a big lesson. Such a large population cannot be served on products, solutions, interventions that are not mastered by us. The total doses, let me elaborate, the total doses that we were offered of vaccines in late July, August 2021, before that, 0, were enough to vaccinate 90 million people. Looks big, but that's 9 crore. And that's the population perhaps which from Delhi, a circle of 50 kilometers, 60 kilometers would cover. Imagine if we didn't have the capacity to develop as well as to produce on large scale the vaccine, the ventilators, the PPEs, and so on. The short point is, when it will matter, we have to be on our own. Therefore, pledge to make India's health system strong in every possible way, and above all, for the care of children. The second context, the Honorable Prime Minister has given a call, and the nation has accepted that call, that by the year 2047, when we celebrate 100 years of our independence, we shall be a developed nation. We shall be an economy currently of $3 trillion. At that time, we'll be an economy of $30 trillion, if not more. We know we can do it. This is not a trivial statement. It's a well thought out statement coming from the apex think tank of the Government of India that I represent here. We will be there. If we have to be there, then our health system has to be as good as what the developed nations have. Now that's a challenge for us. Every day that we now work and serve, please think how this generation, our generation, we will make sure that during the Amrit Kaal of these 25 years, we strengthen the health system, we improve the quality of health system, and we ensure that the services are delivered at saturation level. That reminds us of the SDG theme, leave no one behind, 100% coverage with high quality. So we need to recommit to this, all of us, the senior ones. Murki Saab, now you are senior, tum to bacche the, and all of us. So I want to remind us the perspective through which our action, our work should now emanate together has to be seen through that filter. We cannot allow that goal not to be achieved. And then Because I believe health is an enabler of development and well-being and welfare and higher pursuits of a society. We have to achieve that status by 2040 or 2035, not in 47. We are enabler. We are going to push the nation to that level, and health being an enabler, we have to work doubly hard in our sector, and that's something that I would like to remind all of us. It's about then neonatal mortality rate of say 4 or 3. That's what Norway is, for example, just as an example, and so on. The third context en route to that is the SDG goal, which is not too far. We shall not forget the SDG commitments to be achieved by the year 2030, which is something that we have signed up to. India should strive in the health sector not only to achieve those indicators, but excel them. As the Prime Minister has told the nation to eliminate TB by 2025 and not the global goal of 2030. And likewise, Shobna, not 12 NMR, but below 10. That's our goal, conscious goal that we decided that we will better than the SDG average. So we should think like this. I urge that that's the context that we cannot ignore. It's a reminder. For 3 years, we were all managing our affairs in a very different way, but let's not forget these 3 important contexts. The fourth one is that in the last 9 years, health sector has transformed itself. Health sector has new energies, new ways, and systemic approach to overall strengthening of health system is visible to you. Now I'll make that case how it is so. Very briefly, health spending per capita by the government has risen from about 1,000 rupees to 1,800 rupees. 71% increase, it shows the path. There's so much more to be done, but this much has happened. Out-of-pocket expense in 2013-14 was 64%. It is down to 48%. NMR was 26 down to 20. And we are on track, I'm happy to say, and I'm going to return to this very briefly and very shortly after I try to project the big picture. That's my job. We are on track for SDG, for NMR and under 5 mortality. We'll be there. But the issue is, can we have most of the states achieving that? That's the issue. Most of the districts achieving it, so that there is equity. We'll come back to that. The number of government medical colleges, just a few things, I'm not going full course on this one, but number of government medical colleges have doubled since 14. We were 181. Today, we are more than 300. Okay? Double, more than double actually. PG seats from 32,000 are 68,000. This concerns us. So we have a job to do here. Undergraduate MBBS seats have more than doubled, from 52,000 to 108,000. This is all step-by-step hard work, policy shifts. We have a National Medical Commission bill, we have the new National Nursing Council bill, and so on. And you have the Allied Health Professional bill. I can go on, but I have to make a few points that are relevant to us. But I do want to mention the 2 flagship programs which concern us, because a reference was made directly and indirectly to them. Through Ayushman Bharat, Pradhan Mantri Jan Arogya Yojana, you are aware, 50 crore people to start with are being provided ₹500,000 rupee coverage per family per annum for about 1,400 plus packages. That includes practically everything. It includes renal transplant also, I'm happy to inform you, kidney transplant, cancer care, and thankfully it does not include the Botox therapy. So it covers everything, okay? It covers practically everything. It's delivered through a partnership with states. States put in 40% typically, center puts in 60% of the budget, and 77,000 crore rupees have been invested in this already, and the scheme has been used by as many as almost 6 crore hospitalizations have been covered. It's attacking the catastrophic expenses. It also has newborn packages, 13 of them. Basic. I did a lot of this, but I did this one in particular with the help of several of you. It has 13 packages, ROP, BERA, and of course, critical care, continuing care, intensive care, basic, specialized, and so on and so forth. So I'll probably touch on this a little later as to how to use it as the way forward. But this is an aspirational, unforeseen, unheard, largest health assurance scheme of the world. $500 million to begin with, but in partnership with the states, we are now covering 670 million, 67 crore individuals, which is half of India. Help connect this to the system. Care being delivered by a partnership of private and public sector. It's only one sector now. Through this, there's only one sector. 27,000 hospitals, about 12,000 plus are in the private sector, the rest are in the government sector. The package rates are same, payment system is the same, and many of you are a part, transformative for the journey for universal health coverage. And the second one is the twin of this, the second original Ayushman Bharat announcement, which is Ayushman Bharat Health and Wellness Center, which are now being called as Ayushman Arogya Mandirs, Health and Wellness Center. Over a short period of 3 years, and despite COVID, 160,000 health and wellness centers, these mandirs have been established. 150,000 new workers have been put in place, from nil to 150,000. These are called community health officers, for those who are our guests, and they are typically trained nurses, BSc honors nurses with specialized training. They are there. All of them have telemedicine facility. And the sub-centers have 14 diagnostics. The PSC ones have 23 diagnostics. There are more than 100, 105 for the small ones, and 172 free drugs to be provided to the population. Another transformative foundation of our primary health care. We are using it for the classical maternal, newborn, child, family planning, communicable disease platform, but now moving in the direction of non-communicable diseases in a big way. Screening and treatment, including 3 cancers, cancer cervix, breast cancer. We still have to do a formal job for these 2, but oral cancer, hypertension is happening, diabetes is happening, and we still have to add ENT care, eye care, mental health, geriatric care, and so on. Short point, here is a new India's primary healthcare platform being developed, and our policy states that we will spend 60% of government money, government budget on primary healthcare services. So primary healthcare platform being rebuilt and re-energized, revamped, recontextualized, and secondary tertiary care hospitalization being covered to health assurance system. These are 2 very impressive pillars and path-breaking pillars of our health system, to which Ayushman Bharat digital mission and infrastructure mission and so on, a lot more is happening that we will be leaving it for some other day. Let me also say something that should be stated coming from public health dimension. 3 things. All our villages are now open defecation free. 110 million toilets have been built since 2014. To make the women have better life and household have a better life, 960 million, 9.6 crore, okay, it must be 96 million then. 9.6 crore gas connections have been provided to households for clean air. But the last one you may not know, that 71% of India's houses now have tap water supply. 4 years ago, this was 17%. 1.7 has now become 7.1. And by the time we complete this, we nation would have given clean water taps to additional 70 crore, 700 million individuals. That's about 16 crore. 16 crore means 160 million households to such a large population in about 5 years' time. Now, this population, to contextualize, is bigger than US plus Brazil, plus UK, and plus maybe other few countries together, tap to that kind of a population in 5 years. That's what India is capable of doing. I'm not going in the direction of our achievements in infrastructure, but the context is we are moving strongly to build a resilient, comprehensive, transformative health system, and these are just a few examples. There's a lot more that we can cover. So that's the context that I will not forget, and last but not the least is the context, coming back to the issues of the day, is the INAP context. The India Newborn Action Plan 2.0 is being shaped, is being crafted. It's a great opportunity for you to put the wish list to Shobna and her team, and we assure you it'll have your wish list as part of this, provided you're going to work hard to implement it. That's our job, and I'll come to what you guys are going to do it. So here is an opportunity to refine the newborn care approach, going forward with 2030 goals, and that's another context in which KMC has a very central place. Now that takes me to where the current audience's focus has been. For the last 2 days, we are deliberating the role. I'm not going into the science of KMC. What I'm proud of about KMC is taking cue from what, Madam, you started. India's contribution for research toward KMC is a stellar example of India's capability. Just as having delivered UIP vaccines, we had the confidence we could do the COVID vaccine. The short point I'm making is we have a base which is an academic base to solve problems, to hone problems, to create interventions, adapt interventions. And when I look back, there are heroes of KMC research and activism and community application and facility application. Several of them are sitting here. Ma'am, you did a great work in starting. Lucknow, KMU and Vishwajit's group. Just to tell all of you to feel good, Somshekhar, such a deep work and lasting work you have done in. Murki Saab has done work in his own setting. Madam Urani and now Madam Nanavati, another center, Geeta Gachwala Center, Aurangabad, Bhopal. Great work that has been done. Of course, AIMS did its own job. PGI did its own job. Puducherry, Bangalore Medical College, apart from yours, apart from Sumana, your group, Bangalore Medical College did the job. The short point I'm making is that as we went along, Indian neonatology, maternal health, academia rose to the occasion to continue to refine the model, adapt the model, look at the benefits of the model, and continue to improve. And that's why we are very proudly saying that now is the time to take the full package in full behest further on into the system, government and the private. But I salute the researchers and advocates and champions who made KMC a mainstream intervention, a universal intervention for newborn. That has happened. Other milestones, some more have to be achieved. I'll come to that very briefly just now. But I want to salute also the sponsors, such as the WHO, BMGF, and UNICEF, and NIPI and others, who were helping apart from the ICMR and the government system. Reference was made when I came in to SDGs and KMC. I thought it was very thought-provoking. And the point that we now realize is KMC is not only about thermal support. KMC is not only about breastfeeding. That's what we started with. KMC is also about sepsis prevention in a big way, and that impressed me most when I became a champion through my own work with our team. We are now realizing that it actually has an extension into the brain development. We expected that, but now we know it. That's a very different thing. That's a hypothesis. Now it is proven. And therefore, this modality of humane care, a partnership between the baby and the mother and the system and the family, has a great potential to move forward. Our trajectory toward single-digit NMR will be hastened by incorporation of KMC for sure. So please, we have to move forward. So that's about SDG 3, by the way. Our SDG 4, which is about education, it incorporates supporting young children, one of the indicators, through early childhood development and care and education. And that's about brain connections. That's about the stimulus. That's about pruning at the right time. That's about ensuring that the brain is protected in that earliest phase when, like Nina ji, a lot of small babies are at risk. So KMC clearly will promote achievement of both SDG 3 and SDG 4, and perhaps there are others, but clearly I want to add SDG 4 again. Clearly I can see that as a part of this. There has been my concern, which I have shared at other forums, and Shobna and others know it. When we are discharging our babies from our facilities, we are still doing the best job, of course, but we are still not happy fully. I'm not very happy. Our earlier concern in our lifetime, some of us, our work lifetime, was survival. And MDGs were about survival. It fitted well. India brought forth newborn focus in MDGs. Then we thought intact survival. But intactness meant that there is no IVH and there is no, HIE sequelae. We were happy with that. That's not enough. We left out two things. One, and this realization, Rajesh, and some of you, please think very carefully. A, we are not ensuring optimum nutrition. Study from my team, Shuchita, published very well, as you know, despite best efforts, these babies are not in the right trajectory. When you look at them at 6 months and 5 months, they're behind. Huge difference. Best efforts. What more needs to be done by science, by biology, by interventions? Please work on that. And of course, highest level achievement for cognition, language, social development, and so on. So these two are the frontiers that today's community and your students have to now pursue relentlessly. And so as you move, I charge you that please don't be happy with survival. You have proven that. You are good students of ours. You did a good job. We started, we were fumbling, we didn't know how to ventilate. And then Doug comes, Nalini, they come, they help us, Vinny Bhutani, they taught us. We went there, we saw. You all had your own mentors. Survival improved. Humane survival started to improve. We became less invasive and so on. Intact survival also improved. ROP declined. I think outcomes are much better. Severe IVH is non-issue. But nutrition, देख भी नहीं रहे थे, बच गए बस, घर जाओ. Nutrition. A study from Himachal shows that discharged babies from our SNCUs, right? SNCUs, half of them are undernourished, not acceptable. At 4 months, 6 months, not acceptable. Shuchita's data, smaller babies, even worse. So short point is, there is a disproportionate undernourishment wasting and stunting is bad, because stunting is about productivity and so on. And wasting is, of course, something which you should try to correct. So this is not an acceptable outcome. KMC helps to correct that in a big way, so we will embrace, but I urge you all to think what more needs to be done through this approach, and I also encourage scientists to think about it, because this is really, you just look at your own data. They are simply not. Just go back and look at 10 babies, random. Nutrition outcomes are not optimum. I can imagine that there is a nutrition restriction. It takes longer time. Fair enough, we can discuss that till cows come home. But the point is we can do better. We cannot have, wasted babies at 4 months. Look, So that's one. But second, optimum development. That's about high-level cognition. That's about IQ points. That's about language skills. And our national education policy, is talking about, language to be taught, subjects to be taught through mother tongue and then additional language, then another addition, and so on. So we are aspiring to be fully loaded in terms of optimum cognition that is possible for every baby. And that is partly what we start with, or our kids start with, the genetic part, the initial development. But then for babies who are stressed, it's about extra effort to be made for these babies. That has to be optimum. Still have a long way to go. That higher level, beyond IVH and HIE lesions, no. It's about optimum cognition. Such a large cohort of small babies cannot be left behind. If we lose even one IQ point on the average for a cohort of 25 million babies born every year, these are 25 million IQ points less for the nation on the average, not acceptable. So we are all going to work hard to ensure that the stimulation, protection, prevention, and things that improve that, intervention which take it in a big way, and KMC, you are there for that, and therefore we need KMC for every baby. But more, how do we then continue the right stimulus in the setting of the home, supported by the health system, because our outcomes are not optimum and complete till we handle and ensure this part as well. So please think about these two outcomes. You can look at the stories in other countries. I am worried about what we are seeing here, and we have our own unique issues around small babies and stunting at birth, and therefore it's more complex, and the solution will have to come from us, as we have always seen. For in the list of my researchers are also researchers from Chingalput. I like to recognize them. I like to recognize Bhopal, I think I said that, Hyderabad, and so on. So big salute. In the end, let me say what, from my point of view, are the big ticket way forward items. Firstly, your opportunity for INAP should be harnessed for KMC. Now it's KMC. Make sure that we embrace this. Shobna has already promised it will be there, but we have to work hard that we ensure that we are able to give training. And this training is one-to-one, by the way. This counseling is one-to-one. It's not really, cannot be given through portals and so on. Therefore, please, NNF and others and government will think about how it refresher training, and for every nurse. And there are, a lot of nurses joining the newborn care every year. So that's one. Through that, we will promote immediate KMC, prolonged and continuous KMC, continues from the facility to home. This is what we have to ensure at saturation level with high quality. Therefore, it has to become part of home-based newborn care. It was there as much as at that time in 2011 we thought it can be embraced and included, but now we have more confidence. So many of you have shown community-based models that it works, and therefore fully loading HBNC. Second suggestion is that we should use telehealth support to provide that care. Today that's much more possible. It wasn't possible 10 years ago or 15 years ago, and we didn't think of it 5 years ago till COVID came. And we are all using this system. Telemedicine has become a norm. Through our eSanjeevani, 180 million calls have been made till now. Every day, 200,000 providers are linked, and those health and wellness centers are linked, but so much more is also linked. A new Telemanas portal, which looks at providing counseling for mental health, sees 2,000 plus calls every day. It's only about 12 months old, 13 months old. It's 24/7, 14416 is the number. I'm telling you that these things are getting accepted, getting mainstreamed, and can we think about a KMC helpline in some ways? Maybe UNICEF, you can host it, so that people can talk about it and there can be visual support as well. But surely I'm requesting that HBNC tele support should be a part. My third charge request is private sector, please, we have to work with you. This is a standard of care, as Nina said. When she says standard of care, it is standard of care. She's WHO. So how can private sector not do standard of care? India's private sector, we will all do. We will all embrace it. We have to make it acceptable. We'll create that environment so that it is embraced. Otherwise, a lot of babies who deserve KMC are not there. My fourth suggestion is make KMC as a mainstream buzzword. I think that's something that India has not yet succeeded. इसके बारे में general चर्चा होनी चाहिए. Even for well-educated women, say working in IT hub of Hyderabad or Bangalore or in Gurgaon, they really may not be aware of it. I'm talking about that segment in particular. Okay? Rural, we are taking it through our health system, through ASHAs, through HPNC. We're covering them in our own way. But the segment of middle classes and the buzz around them, the media, the social media, TV, channels, that has really not happened. So in Colombia, and my tribute to Dr. Natali Charpak, who actually has been a guru for all of us alongside the Indian team, and great opportunities she provided, in Colombia it is a way of life. It's accepted already. That's one thing that we should all think about, and we would need help from other stakeholders such as the social scientists and others and so on. Make KMC a mainstream way of life for child rearing in India. Let's talk about it. I don't have a proposal as of now, but let's work that just as we made exclusive breastfeeding as a way of life, and it has helped in a big way, we need to make KMC visible to everybody. And last but not the least is that there is work to be done by way of training and retraining. I'm reiterating that because that's the kind of thing that you and I have been doing, and it's our job because it is a skill which gets passed, and therefore a researched effort for training should be instituted. And also I urge that the academics who are here, please see whether it is optimally reflected in the curriculum of nursing, BSc nursing course, A&M course, MBBS course, PGs. Can we make sure that it is there? I should have checked how it is reflected, but you all are teachers, and I'm sure pediatric and newborn teachers are very responsible. It's a matter of making sure that it's triggered, and it will happen. And therefore, please make sure that it's part of the curriculum of CHOs, the BSc nursing, and particularly because they are the ones who will look after babies, almost all of them in some stage or the other. It should be part of the nurse practitioner course for midwives that has been crafted. We'll have a look at this. We are starting 3 nurse practitioner programs, 6 more will come. Midwifery, critical care, and 1 more is already on. Make sure that this is plugged in there, so those of you who are in that space may please do so. In the end, I express my deep appreciation for the opportunity, for all of you for having carried this torch ahead. There are many who have not been able to come, but India has risen. India newborn fraternity, nursing, doctors have risen. We are very happy to have our distinguished guests from several nations who have graced the occasion. We will learn from you. We learned from you. Philippines was one of the most impressive examples when we were discussing how to craft a program some 15 years ago, and so on. We thank you very much for your support, and thank you very much for inviting me. I wish you strength, but I urge you that work harder in this area. We are not yet done. We still have a long way to go for 2047, but the journey already started, and it moves on a daily basis. Thank you very much, Jai Hind.
Thank you, sir. It indeed was an honor to listen to you. I now request Dr. Jatin Mistry, member KMC Foundation of India, to deliver vote of thanks.
Before Jatin says, I just wanted to inform you, there is a Telugu translation also for the rural newborn, community-based KMC, and our Gujarat NNF has launched an online training program for the nurses also for that, because now the time is too short, we are not giving, but please you can say it. And now please. He has to leave for the airport, so he has to, okay? Please. Thank you.
Good evening, everyone. It has been a great pleasure and matter of honor for me to be here in such a wonderful event. I would like to extend my heartfelt gratitude to all the dignitaries on dais on behalf of KMC Foundation India, Madam Vani, Dr. Parag Dagli, and our whole core team of KMC Foundation India. First of all, I would like to thank Dr. Vinod Paul sir. Sir, thank you for taking time from your extremely busy schedule and to be present here. Sir has been extremely busy. As we heard, sir has given us insight into how Government of India is achieving goals and how KMC we can improvise, how he has provided us with the mission and the vision, how we can all contribute towards a single digit NMR. I would also like to thank Madam Dr. Nina Raina, who is Director at Department UHC Family Health WHO, Regional South East Asia. Ma'am, thank you for supporting our conference in a big way. Thank you for providing us with the WHO inputs into improving KMC. And thank you for conducting the sessions over here. I would also like to thank Dr. Shobhana Gupta, Madam, Deputy Commissioner in charge, Child Health and RBSK. Ma'am, thank you for providing your valuable input in how Government of India can help in promoting KMC and providing with the various information on the programs of Government of India. I would also like to thank Dr. R.B. Patel, sir, from Joint Director, Child Health, Department of Health and Family Welfare, Gujarat. Thank you, sir. I would like to extend my thanks to Mr. Prasant Das for supporting our conference from Chief UNICEF, Gujarat. Thank you, sir. Also like to thank all the leaders of various organizations, NNF Gujarat, AOP Gujarat, AOP Ahmedabad, AOGS, and Nursing Association as well. All of them have taken KMC as a mode of treatment and declaration as well. Also, my sincere thanks to Dr. Socorro Mendoza. Ma'am, thank you very much. She has been with us for last few days and she has been contributing. She's representing the Asia Oceania network, and ma'am is from Philippines, as we have all discussed. I would also like to thank all the dignitaries who have come from various parts of the world, different countries, and sharing their experience and expertise in the field of this KMC. We had over 3 or 4 workshops and various lectures this morning as well, and tomorrow also we are going to have a lot of discussions. Also, there are a lot of faculties and champions of KMC who have joined not only from different parts of Gujarat, but also from different parts of India, who have all come here and discussing about the kangaroo mother care. I would also at last thank you all the delegates, all the doctors, resident doctors, nursing students, all ASHA workers, Anganwadi workers. Also, I think there are a lot of parents who have contributed to public awareness meetings. So without their contribution, this program would not have been successful. So I would like to thank you, all of you.
Just 1 second. I request all our foundation members to rise up just for 1 minute. Foundation Trust. Unless they had all given us the full support, this would have been possible. Thank you very much. Because of the time constraint, I am not able to acknowledge. Yes, let us have a national anthem. जनगण मन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड उत्कल बंगा विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा तव शुभ नामे जागे तव शुभ आशीष मागे गाए तव जय गाथा जन गण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे जय
All the delegates and faculty members are invited for the banquet dinner at Rajwadu. Those members who don't have their own vehicles, we have arranged a transport. One bus, AMTS bus, red colored bus, is there near canteen area. The number is DJ01 KT 1604. 1604. So you all can go in that also. So you all are invited. See you at the banquet dinner.